Good morning, everyone. I thank you all for joining in this webinar on breast and lung cancer. We are talking about the updates in breast and lung cancer in the current oncology update series that we have planned, and this is the first part of it in 2021. As we all know that oncology is a field which keeps on evolving very rapidly with time, and a lot of evolution has happened in the field of oncology as far as the new drug developments are concerned, or the talk about new molecular profiling in cancers is concerned. So every now and then it is our effort to really talk about all these things amongst our peers, amongst our seniors, and try to understand from them as to what are their experiences and how should we really bring a change in our OPD practice as far as these new updates are concerned. This is what our endeavor also is. In the next about 4 hours or so, we'll be talking in depth about what new has come up in breast cancer and lung cancer and its management in the last few months or years gone by. And we'll try to really delve deep into how should we be really taking these things forward in terms of changing our OPD practice, or should we actually wait for some time more for some data to mature more, is what we'll be trying to talk about. So the first speaker that we have today with us is Dr. Jyoti Bhadwa, ma'am. Ma'am, of course, needs no introduction, and ma'am has a vast experience in the management of breast cancers among many other cancers. I will fail my duties if I don't introduce her to my august audience. She is an alumnus from All India Institute of Medical Sciences, and currently is the director of Medical Oncology Department at Medanta Medicity in Gurgaon. And we are very thankful to ma'am for taking her time out on this Sunday morning and being with us. Ma'am will speak to us about the role of Pelvocyclip as a CDK4/6 inhibitor in the management of metastatic breast cancer, and she'll give her insights to whether we should be using this Pelvocyclip molecule more and more in the management of hormone receptor positive HER2 negative MBC. Without any further delay, I hand over the session to ma'am. Ma'am, over to you.
Thank you, Rajat. Good morning, everyone. And I would like to thank Dr. Rajat and the organizers to invite me to be a part of this academic endeavor. And over next 30 minutes or so, I'll take you through the CDK4/6 inhibitor Pelvocyclip in its journey from the origin till 2021. The talk is entitled Pelbase in Hormone Receptor Positive Metastatic Breast Cancer. Does it hold all the aces? So let's see. We know that CDK4/6 inhibitors have been a real game changer in the management of patients with metastatic breast cancer. We all know, but there's no harm in revising, that when we have a patient of advanced breast cancer presenting to us, the factors that we take into consideration in the management planning is the determination of sites of disease, the extent of disease. Obviously, we look into the hormone receptor status and HER status of the tumor, the disease-free interval from the prior adjuvant therapy, age of the patient, the menopausal status, presence of comorbidities, and the performance status. But the foremost point of decision making in the beginning itself is whether the patient is in visceral crisis or not. Because if the patient is in visceral crisis, we prefer to use chemotherapy rather than endocrine therapy. However, I would like to emphasize that presence of visceral disease does not mean visceral crisis at all. So we have to make this distinction very clearly. Now, these are the trials, the phase 3 first-line trials of CDK4/6 inhibitors. They encompassed ladies who were postmenopausal and also those who were pre or perimenopausal. We have Paloma 2 trial dealing with the combination of palbociclib with letrozole. Monarch 3 of abemaciclib with, again, aromatase inhibitor in postmenopausal women again. Mona Lisa 2, a combination of ribociclib and letrozole was studied. And Mona Lisa 7 dealt with the outcomes in pre and perimenopausal women of the combination of ribociclib with aromatase inhibitor or tamoxifen with LHRH agonist. This is not to do cross-trial comparison. However, I would wish to draw your attention to some of the points. The median age, as you could see, is similar, except obviously younger patients in the pre and perimenopausal trial Mona Lisa 7. The median progression-free survival is similar. The hazard ratios are similar, if you notice, in all these trials. The overall response rates varied from 50 to 60% across trials. The clinical benefit rate was also similar to the tune of 80%. This table lists the CDK4/6 inhibitors phase 3 trials with fulvestrant. In this, Paloma 3 dealt with the combination of palbociclib with fulvestrant in those patients who had been treated earlier for advanced breast cancer. Monarch 2 obviously had abemaciclib, and Mona Lisa 3 studied the role of ribociclib. Now, the important point to be noted in this table is the first column under Paloma 3, wherein, if you notice, the previous lines of therapy given for metastatic breast cancer in the patients, 2 lines or more prior lines of treatment were there in significant proportion. 35% of patients had been treated earlier with 2 or more lines in the Paloma 3 trial. That was not the case in the remaining 2 trials. Also, 33% of patients in the Paloma 3 trial had in fact been given chemotherapy as well prior to the enrollment in the study of the use of fulvestrant with palbociclib. The median PFS is as listed, and all the 3 trials have had significant median follow-ups to be commenting upon the overall survival. And I'll deal with this in my subsequent slides also. The subgroup analysis in the Paloma 3 trial reported the overall survival to the tune of 39 months versus 29 months in the other arm, the non-experimental arm, in patients who had disease sensitive to prior endocrine therapy. And similar results have been reported in Mona Lisa 3 as well. Now, if you compare the toxicities of these 3 different CDK4/6 inhibitors, we all know, and we have learnt through our experience as well, that neutropenia is the main toxicity experienced by patients on palbociclib and ribociclib. QTc prolongation is an important feature to be kept in mind while treating the patients with ribociclib. GI side effects are the main side effects experienced by the patients on abemaciclib, and liver function tests also need to be monitored while the patients are on treatment with palbociclib and abemaciclib. However, it's important to note that even though a significantly high number of patients are found to have neutropenia of any grade to the tune of 79% or 76%, the grade 3-4 neutropenias are less commonly seen, and the febrile neutropenias are hardly ever seen. They have been reported to the tune of only up to 2% with palbociclib. So it's not a matter of concern, and it's easily manageable in all our patients. Fatigue is also a common side effect to be kept in mind while using CDK4/6 inhibitors. So based on the toxicity profile of these CDK4/6 inhibitors, there are recommendations regarding the monitoring of patients. In the initial 2 cycles of patients on palbociclib, it's recommended to monitor complete blood count every 2 weeks. And so is the case with ribociclib, because both these drugs are known to cause neutropenia. However, following the initial 2 cycles, the patients can get away with just monthly complete blood counts. And obviously, you have to do ECG in those who are on ribociclib, and LFTs need to be closely followed in those on ribociclib and abemaciclib as well. The updated indications for the use of Pelvocyclip, it's indicated for the treatment of hormone receptor positive, HER negative, locally advanced or metastatic breast cancer in combination with aromatase inhibitor and also in combination with fulvestrant in those who have received prior endocrine therapy. In pre and perimenopausal women, it's important to remember that endocrine therapy must be combined with an LHRH agonist. Let me take you through the Pelvocyclip clinical trial data. The first one is Paloma 2. This was a phase 3 study for postmenopausal women with hormone receptor positive HER negative metastatic breast cancer. They had to have received no prior systemic treatment for advanced disease, and the patients who had received anastrozole or letrozole in the adjuvant treatment were allowed if the disease-free interval was 12 months or greater from the completion of therapy. The patients had to have ECOG performance status of 0, 1 or 2 and had to have adequate organ function. The patients were randomized 2:1 into Pelvocyclip, 3 weeks on, 1 week off schedule, along with letrozole in the standard dose, and the other arm was letrozole alone with placebo. So this was a phase 3 randomized double-blind trial held across 186 centers in 17 countries, and the treatment was continued until disease progression or unacceptable toxicity, and the standard dose reductions were allowed as per the protocol. So this was the results which were published, the lead author being Hope Rugo, and the median progression-free survival in the Pelvocyclip arm was 27.6 months versus only 14.5 months in the placebo group, which got only letrozole. So significant difference in the median progression-free survival there. On subgroup analysis, it was found, and it's important to note, that all these subgroups seem to benefit from Pelvocyclip when it was combined with letrozole. So patients, whether they had visceral disease or they did not have visceral disease, even those patients who had only bone disease, they also benefited significantly with the addition of Pelvocyclip to the letrozole. The treatment-free interval, whether it was 5 years or even more than 10 years, all these patients seem to get benefit from the addition of Pelvocyclip. The disease sites were immaterial, whether the tumor burden was low or high. Both these subgroups seem to benefit from Pelvocyclip. And even those patients who were more than 65 years of age did very well with the addition of Pelvocyclip to letrozole. So we must keep in mind the subgroup analysis while choosing the right treatment for our patients. The overall response rate on intention to treat analysis in the Pelvocyclip with letrozole arm was 42% versus 34%. The median duration of response being 22.5 months. In those patients who had measurable disease, the overall response rate was in fact 55% versus 44% in the other arm. The duration of response again being same as in the intention to treat population. So Paloma 2 concluded that at 37 months of follow-up, this combination consistently improved median progression-free survival versus placebo with letrozole in the overall population, the median PFS being 27.6 months, and the benefit persisted across all the patient subgroups, as I mentioned. Pelvocyclip was also well tolerated, and the most common adverse event was neutropenia and leukopenia in particular. However, the overall incidence of neutropenic fever was just 2%. With the long-term follow-up, the safety profile has been retained, and there are no new safety signals as well. So Pelvocyclip with letrozole is regarded as an important first-line therapy. It's not only efficacious, but it's also safe as well to treat our patients with hormone receptor positive HER negative metastatic breast cancer. The second trial is Paloma 3. This was a phase 3 double-blind study held across against 17 countries. It included pre-perimenopausal patients and also post-menopausal patients who had progressed on prior endocrine therapy on or within 12 months of completion of adjuvant treatment. And if they had received one or no chemotherapy regimes for treatment of advanced cancer, that was also permitted. So patients were again randomized 2:1 to receive either palbociclib in the standard dose with fulvestrant, again in the standard dose, and the other arm being placebo with fulvestrant. The primary endpoint was investigator assessed progression-free survival, and the response rate and overall survival and safety and tolerability were the secondary endpoints for Paloma 3. So this slide shows the updated progression-free survival of 11.2 months versus only 4.6 months in the placebo arm. So very significant difference there in Paloma 3. The overall response rate was 19% and in fact 24.6% in those with measurable disease versus only 10% in the fulvestrant alone arm. The clinical benefit rate was as high as 67% with the combination of palbociclib and fulvestrant. So Paloma 3 concluded that palbociclib combined with fulvestrant significantly improves median PFS compared to placebo with fulvestrant as a treatment for women with hormone receptor positive HER negative metastatic breast cancer who had progressed on prior one line of endocrine therapy. A median PFS of 11.2 months was reported in this group, and the clinical benefit was demonstrated across all these subgroups which were already specified in the study design. Again, palbociclib was well tolerated, and as expected, patients had very well manageable neutropenia. So this trial, Paloma 3, confirmed not only the safety but also the efficacy of palbociclib and fulvestrant, and obviously established its role in even those patients who had progressed on one line of endocrine therapy. So this combination is a definite effective treatment option for those women who had progressed on prior treatment. So herein I show you the previous overall survival analysis presented at a median follow-up of 44 months. And now the more recently updated follow-up data at 73 months, which shows that the median overall survival with the combination of palbociclib with fulvestrant is 34.8 months versus 28 months in the placebo with fulvestrant arm. So again, the results do seem impressive. The 5-year overall survival rates were to the tune of 23% in the palbociclib arm and only 16% in the placebo arm. What about the real world evidence? We often feel as clinicians that we do not work in the ideal scenarios. Our patients may not fit in well with the clinical trial patient subset. So let's see what has been our experience in the real world with palbociclib. And herein, we have different studies performed in the real world on palbociclib. To name some of them, they are IRIS, the Flatiron analysis, Polaris, the expanded access program, and I'll show you the two papers that have been presented from Indian experience as well. So let me start with the Flatiron study. So this was a real-world retrospective analysis of electronic health records of post-menopausal women with hormone receptor HER negative metastatic breast cancer who had been treated with palbociclib with letrozole or letrozole alone in the first line. So data of 2.2 million active patients, 800 sites of care across more than 280 cancer clinics in USA. The total population of patients who received palbociclib with letrozole was 772, and letrozole alone in the number of patients was 658. In these two group of patients, they were well matched for the patient characteristics. The median real world progression free survival. So, this is what these curves show, and you can see that the median PFS in the real world scenario with palbociclib with letrozole was 20 months versus 11.9 months in the letrozole alone arm. So, these results are, in fact, they seem to mimic the trial data which we are already aware of. Again, the median real world overall survival, if you notice with the palbociclib and letrozole, in fact, is not yet reached, and it is 43 months in the letrozole alone arm. So, again, quite similar to the trial data results. The overall survival on subgroup analysis seem to, all these subgroup of patients seem to derive benefit in terms of prolongation of their life. So again, irrespective of the site of involvement, whether it was visceral or non-visceral, whether there was presence of brain metastasis, whether it was only bone disease, the initial time from diagnosis to the diagnosis of metastatic disease, the performance status, whether less than one or more than one, all these patients seem to benefit from the combination of palbociclib with letrozole. So this study concluded that in the real world setting also, first line palbociclib with letrozole is more effective than letrozole alone in terms of progression free survival as well as overall survival in this heterogeneous population. And the various subgroups again seem to benefit from this combination. So this actually confirms our belief in this combination of palbociclib with letrozole. The second study that I want to talk about in the real world scenario is the IRIS study, and this had patients from USA and Europe. So again, retrospective medical chart review study in different parts of the world across USA and Europe, and there were 360 patients from USA and 982 patients from 9 European countries. And again, if you notice, the progression-free survival rates at 12 months were to the tune of 84%, and in USA population and 88% in the European population. The overall survival, 90% of patients were alive at 2 years and 93% in the European population. So the responses reported in 2 continents were similar, except that the complete responses were reported in a greater proportion of patients in the European patients, 21% versus 11%. But if you look at the overall response rates, they were similar, 80% and 84%. So again, very impressive results there. And this IRIS study, thus this was the first real world assessment of clinical outcomes in USA and European patients with palbociclib in combination with AI or fulvestrant, and it did demonstrate its effectiveness in terms of progression-free and survival rates. So again, there was another small difference noted in the European population of patients, that a higher proportion of patients initiated at 125 milligram per day, and lower dose reductions were observed in the European populations, indicating a better tolerance to palbociclib in the European population compared to the USA patients. However, immaterial, this does again reproduce the effects of the clinical trial on palbociclib in the real world experience. The third real world experience study is the Madeleine study. So this looked at the neutropenia and the quality of life, and we all will be again reassured that the patients, even though they had neutropenia, they did not report any worsening of quality of life. So even though we see higher proportion of patients having varying grades of neutropenia, however, the quality of life is maintained while on palbociclib. So as found in the study, almost half of the patients, though they experienced neutropenia at some point during the study, however, the quality of life during the study did not get worse, and it was maintained throughout the follow-up period. Now, what about the Indian experience? And we do have important papers here. So, two studies, one, a retrospective analysis reported from two hospitals from Delhi of 188 patients of treatment with palbociclib, either in first line or second line. They did include patients who had premenopausal status, also men with metastatic breast cancer, and also patients who had brain mets were a part of this retrospective analysis. And it looked at the effectiveness of palbociclib and also its tolerability, and it did find experience in real world which was quite similar to the global data. The other one is from South India. Again, a retrospective analysis from 5 South Indian hospitals from Dr. Amit, 133 patients, again of palbociclib's use in first and second line, and again looking at its effectiveness and tolerability. So this is the first one, the largest real world data from Indian population of patients from Rajiv Gandhi Cancer Hospital and BLK Hospital. Dr. Chaturbhuj was the lead author. And as I mentioned, 188 patients studied between Feb 2017 and May 2020. And obviously, the premenopausal women had either undergone ovarian suppression or ovarian ablation. So the median progression-free survival in the first line was 20.2 months, and in the second line, 12 months. The overall response rate in first line was as high as 80%, and even in second line, it produced impressive response rates to the tune of 48%. 10% of the patients had grade 3 or 4 adverse events, and 20% of patients had grade 3 or 4 neutropenia. However, the point to be noted here is that in this retrospective analysis, none of the patients had febrile neutropenia. So this real-world data of palbociclib use in Indian population does suggest similar effectiveness to previously published real-world evidences, and this combination is the standard of care in the first and the second line treatment of hormone receptor positive HER negative breast cancer. The second study from India is by Dr. Amit Rothan et al. And this was across 5 centers of 133 patients. Again, 62% of patients received it as first line and 37% in the second line. The median age, 56 years. The median progression-free survival in the first line is not yet reached at follow-up of 38 months. The second line median progression-free survival is 14 months. The patients who had, whether they had bone-only mets or visceral mets, seem to have similar progression-free survival in the second line setting. Neutropenia, again, as expected, was reported in 75%, thrombocytopenia in 20%, and 18% of patients had anemia. Again, vast majority had grade 1 or 2 neutropenia, and again, no febrile neutropenia was reported in this retrospective analysis as well. 8% of patients, however, did require dose reductions for management of cytopenias, and 30% of patients had some dose delays. So this study from India again concluded that palbociclib has similar efficacy and safety in Indian patients as was reported in the Paloma trials. Neutropenia is the commonest side effect. However, it's uncomplicated and easily manageable with dose delays. So the palbociclib with hormone treatment has obviously become the standard of care for our Indian patients as well. There was another meeting held on this issue, and consensus guidelines were or recommendations were issued, which were subsequently published in South Asian Journal of Cancer in 2018. The point to be noted in this is that a combination of aromatase inhibitors and palbociclib was recommended to be the preferred first-line hormone treatment for hormone receptor positive metastatic breast cancer, and a combination of fulvestrant with palbociclib to be offered to patients who had progressed on an aromatase inhibitor. So we have data not only from the original trials from USA and across the world, the real world experience also resonates with the data, the clinical trial data. So, has palbociclib changed the treatment paradigm? The answer is yes. So, prior to 2015, there were hardly any new treatment options being offered to these patients after the addition of aromatase inhibitors for a long time. And then came in the CDK4/6 inhibitors, which have proved to be a real game changer. The data does tell us about the efficacy of palbociclib with letrozole in the first line treatment with a median progression free survival of over 2 years to the tune of 27.4 months. The real world data does complement the superior efficacy as reported in the randomized controlled trials, and it does support the use of palbociclib with AI as the standard of care for first line treatment of these patients. The safety is very well established. No cumulative side effects, no delayed toxicities with palbociclib with endocrine therapy. We just have to monitor the blood counts initially, as I mentioned, for every 2 weeks for the initial 2 cycles, and then every month. The quality of life, it's reassuring to know, is very well maintained despite occurrence of neutropenias. So palbociclib does represent a significant advance in the care of hormone receptor positive HER negative metastatic breast cancer, not only in the first line treatment but also in second line treatment when the patients have failed a prior endocrine therapy. So I would end my talk here and hand over back to Dr. Rajat.
Thank you, ma'am. Thank you very much for this very enlightening talk and a detailed discussion on the role of palbociclib in the management of HR positive metastatic breast cancer. I think we have time to take a couple of questions from the audience. Ma'am, I would like to ask you, in your practice, when you've used palbociclib, have you experienced any unexpected side effect till now? What we already know and what you have very in a detailed manner elucidated in your talk is about neutropenia, about diarrhea, about fatigue. Many ladies do complain about alopecia also. So, ma'am, any unexpected side effect, or for that matter, any patient in whom you had to reduce the dose, which was kind of not pre-planned?
Yeah, so in my experience, one thing is that I'm very comfortable using this molecule. And I would agree with you that fatigue is reported also by the patients, and alopecia also. They do report hair fall, which can be bothersome in a few patients. Neutropenia, very well managed, but I remember two patients, one with chronic liver disease, decompensated, and the other one with extensive skeletal metastasis, wherein I had to come down to 75 milligrams a day. But despite the dose reductions and sometimes dose delays, it's very heartening to know that the molecule is so good that even then it's able to offer the advantage and the benefit in terms of PFS and OS and response
Yes.
rates also. So I'm happy using this molecule.
Yes, ma'am. Yes. And ma'am, your thoughts on the European and the American guidelines, both of them saying that if we are using hormone therapy in metastatic breast cancer in COVID times, we should try not to give CDK4/6 inhibitors when they are comparing it with only hormone therapies, just because they think that because it can cause neutropenia, be it only a non-febrile neutropenia, patients may not be comfortable coming to the hospital in that setting and may have a deterioration of the quality of life. So are we really adopting these measures in our COVID times? I'm not talking about the current scenario when the cases are at its trough, but then when it was peak time during February, March, was there any sort of a change in practice that you did as far as these guidelines were concerned?
No, not really, because we were available via telemedicine to guide the patients, and we know that even though there is neutropenia, it's very well managed. Uh,
Yes.
Febrile neutropenia is hardly ever seen. So, with dose delays and dose reductions, you have to just monitor them, carefully as per the guidelines every 2 weeks initially, and then every month. You have to be religious with complete blood count monitoring. But even at that time, I did not notice. I did not have to choose or offer inferior option to my patients because of COVID times. They somehow they did manage quite well. Almost
Right.
all of them, majority, yes.
Right, ma'am. Right, ma'am. Regarding the dose reductions, as you said, one of my patients also, because of the extensive skeletal mets, I had to reduce it to 75 milligrams. Barring these few rare occasions, I think 125 milligrams per day is well tolerated. So,
Yeah.
thank you, ma'am. Thank you very much once again for being a part of this webinar and sparing your valuable time. Thank you.
Thank you, Rajat. Thank you.
Thank you. So after this very insightful talk by Dr. Jyoti Bhadwa ma'am, we move on to our next talk. And this talk is on the role of alpelisib in the management of hormone receptor positive metastatic breast cancer. As we know that CDK4/6 inhibitors, or for that matter, any first line hormonal therapy is going to fail sometime or the later in the life of a patient, and we do need to know as to what exactly are our good second line options. And now with the coming in of this molecule called Pivicto by Novartis, certainly we have lots of hope for patients who are having a PIK3 mutation after the development of resistance to first line hormonal therapy. And to take this talk forward and to give us more insights into this particular topic, we have with us Dr. Sushant Mittal. He happens to be a young medical oncologist and a very dear friend and colleague. He is a senior consultant in medical oncology department at Action Cancer Institute in Delhi. And we are very happy to have him with us. And we would be very eager to know his thoughts on how he uses this particular molecule in his OPD practice. So, Dr. Sushant.
Thank you, Dr. Rajat, for your kind
Over
words.
to you. Over to you.
Thank you.
Good morning. Yeah.
Good morning. Thank you, Dr. Rajat, for inviting me. And it's a Monday morning. I think everybody is relaxed and happy to hear various thoughts on various topics of medical oncology. So, topic given to me is hormone positive, HER2 negative, picking the right strategy for patients with hormone positive, HER2 negative PIK3 mutation. So as we all know, next slide please, that PIK3 is the most common mutated gene in hormone positive breast cancer, and it's present in about 40% of the population. And I would like to draw your attention that it's a truncal mutation. It is present since the beginning. It's not an acquired mutation. So the testing for this can be done either upfront or after the patient has progressed. That's a topic to be debated upon. But patients with PIK3 mutation face a worse prognosis. Next slide. So, as I told, it's a common indicator for poor prognosis, and it has been proved in various genomic analysis of the 649 metastatic breast cancer patients who are hormone positive, who have relapsed or progressed during endocrine therapy or less than 12 months after the end of endocrine therapy in adjuvant context, and then meta-analysis of about 1900 patients who had received prior adjuvant chemotherapy, endocrine therapy, or combination of these therapy, and a mutation of PIK3 was detected, and it was a negative prognostic factor associated with poor response to therapy and an overall poor prognosis for the breast cancer. So if we maybe 2 years back, when our patients on endocrine therapy did not do well or who used to progress early, we used to think what was the reason, and probably this was the reason that PIK3 mutation was not identified that time, and hence the patient were not doing well. Next slide. So knowing the PIK3 mutation will help us to strategize our strategy. Why? Because PIK3 mutations causes cell proliferation, tumorigenesis, poor prognostic factor, and endocrine resistance. So it may inform upfront treatment strategies and response to the treatment. Next slide. It's available as a potent and a selective inhibitor of PIK3 inhibitor. PIK3 mutations may lead to hyperactivation of PIK3 alpha, a key upstream component of the PIK3 pathways, And Pluvicto inhibits the alpha isoforms of PIK3 50 times more potently than other isoforms such as beta, delta, and gamma. And Pluvicto, along with fulvestrant, works synergistically to inhibit both the PIK3 and the endocrine resistance pathway, respectively. So targeting the PIK3 helps us to take care of the resistance of the endocrine-based therapy in hormone-positive advanced breast cancer. Next slide. So this is the pivotal trial, SOLAR-1, phase 3 trial leading to approval of the PIK3 inhibitors. It was a randomized, double-blinded, placebo-controlled, multicentric phase 3 trial. 572 patients were enrolled, including 341 with PIK3 mutations. Postmenopausal women, hormone positive, HER2 negative, recurrence or progression of breast cancer during or after the AI therapies, ECOG performance status 0 or 1, and PIK3 were identified, and 1:1 randomization was done. Pluvicto 300 mg daily, along with fulvestrant versus placebo with fulvestrant were given, and the primary endpoint was progression-free survival. Secondary endpoint was overall survival in PIK3 mutation, overall response rate. Clinical benefit was also assessed because it's important. Sometimes the PET scan may not be showing what we want to see, but the patient is benefited, and the safety and the quality of life also was assessed. Next slide. So as this graph is showing, with the placebo, the median PFS was 5.7. However, with addition of Pluvicto, it became about 11 months. So there was 2 times more benefit of Pluvicto with fulvestrant, and hence it is an NCCN category 1 recommendation in such kind of patients. Next slide. Previous slide, please. The important point also to note is that the graph starts separating within 2 months of starting the treatment. So it is also beneficial for patients in whom we want a rapid response. So the graph shows that the at 2 months interval, it starts separating. Next slide. Subgroup analysis, the diamond is away from the unity in all kind of patients, whether with lung or liver mets or bone mets or prior CDK4/6 inhibitors. The patient who had received prior CDK4/6 inhibitors were about 20 versus who had not received were about 320. Prior chemotherapy, adjuvant chemotherapy, advanced chemotherapies in form of first line or second line, or endocrine resistance, primary or secondary. Even in sensitive patients was seen the response, but it was less. So across all subgroups, Pluvicto had shown a response. Next slide. So the response rate has been doubled. As shown, the PFS is 35 versus 16.2, and the overall response is 26 versus 12. Next slide. So the waterfall graph shows that the deeper responses are achieved with Pluvicto, leading to a, as we can see, about 75% of the patients have responded beautifully with the Pluvicto. Next slide. The recommended doses are, there are 2 tablets of 150 milligram. So 2 tablets have to be taken together, same time of the day, and approximately at the same time as we are taking the food. The dose reduction is in the form of 1 tablet at a time, and along with that, 500 mg intramuscular fulvestrant has to be given on day 1, day 15, and day 29 as we have been following. Next slide. Now the adverse side effects. Most common adverse side effects are hyperglycemia, present in about 40% of the patient, and rash, present in about 20% of the patient. The rest of the side effects such as diarrhea, nausea, stomatitis are easily manageable, but these 2 needs a special mention. Next slide. So why the hyperglycemia happens is because this insulin, which is present, which helps in taking up the glucose transport at the domain level, does not happen when Pluvicto is given. Hence, the glucose transport stays inside the cells, the glucose remains in the blood levels, and hence the glucose level rises. Because of this, If we give insulin to the patient will not respond because the insulin is present, but it's not able to work. So when we are giving artificial insulin to the patient, it will not help. Hence, we need to give oral hypoglycemic agents such as metformin and pioglitazone. Next slide. This is important because sometimes in our busy OPD, we do not manage the sugar. We send it to the endocrinologist or to the physician to manage the sugar. So they must be aware that this sugar will not get controlled with insulin and they need to add the tablets. So these are various grade of side effects which have to be managed. Initially in grade 1, nothing is to be done. However, after that, if the sugar is still high, then initiate metformin at 500 mg once daily, then 500 mg twice daily, then maximum up to 1000 mg twice a day. Even if that patient is not responding, add pioglitazone, which is an insulin sensitizer. Even if after that it is not getting control, then we need to stop the medicine or reduce the doses of the medicine. Still, the sugar falls in grade 2 or grade 1 category. Next slide. Lifestyle modifications are very important for the management of sugar. Proper exercise and weight management, low carbohydrate and high fiber diet, limited intake of trans and saturated fats, 3 small meals, 2 small snacks rather than 1 large meal, and personalized diet plan from a dietitian. All these, along with the medication and information to the patient, will help in managing the sugar. Most important is that you need to tell the patient before starting the drug that these things will happen. Sometimes if you forget not to tell the patient, then they lose their confidence and they feel that now they have now sugar also, they already have cancer in the metastatic state, so they lose confidence. So you need to tell them beforehand that this will happen, this is normal and is manageable. Next slide. Next slide, this already discussed. Now rash, about 20% of the patient will have rash. So prophylactically, you can start them on antihistamines, or you can wait because it's just in about 20% of the population and it is easily manageable along with cetirizine or atarax when it is given. I have seen in about 10 to 15% of my population of my patients, they do have rash, especially on the shins and on the elbows, and it is manageable with cetirizine. Next slide. Now, why do we test? How do we test? So why we test, we have discussed. When to test is when the patient of metastatic breast cancer comes, we can test it that time, or after the second or third line. As I told you, these are truncal mutations. It can be tested anytime. It doesn't matter. It's not an acquired mutation. How to test? Quagen Therascreen, which is a PIK3 RGQ kit. It's an FDA approved kit, is now available in India. And the sample which needs to be collected is either tissue or liquid. Next slide. This slide is very important. What we need to know that the tissue tumor biopsy, if positive, start on the Pluvicto and fulvestrant. If it is negative, then it is negative. Need not do anything. However, in liquid biopsy, when we are taking circulating DNA in the peripheral blood, if PIK3 is positive, you start the therapy. However, if it is negative, then you have to confirm with tissue biopsy again. So before sending the liquid biopsy, tell the patient that if it is negative, then they need to give the biopsy again, or from the archival tissue, we need to send the sample. Because if it comes negative and then they are happy and you tell them again that no, you need to undergo. So telling them beforehand, trust the patient-doctor relationship and helps in getting the test done. Next slide. So to summarize, PIK3 is present in about 40% of the hormone positive, HER2 negative breast cancer and it indicates a poor prognosis. It's a tablet specifically targeting PIK3CA mutations. It nearly doubles the median PFS from to 11 months from 5 months, doubles the response rate to 36 from 16, and safety and information, as I told you, are manageable and reversible. So it's a biomarker-driven therapy with NCCN Category 1 evidence of hormone-positive, HER2-negative advanced breast cancer with PIK3 mutation. Thank you. Back to the organizers.
Thank you, Dr. Sushant, for enlightening us with this talk on alpelisib. As you very rightly pointed out, this molecule is probably here to stay. We are still in the learning phase of this molecule, and there are few adverse events that we generally encounter once we are giving this molecule. But because of its sheer progression-free survival that we have, and its comparison with the placebo, we do understand that certainly this is here to stay. I just would want to ask a question from you as to your thoughts on the very recent BioLive study update, which has come, which says that alpelisib, if we are using in second line, and be it the use with either fulvestrant or AI, what they did is that in the first line, they either used AI and then subsequently alpelisib plus fulvestrant, or they initially used fulvestrant followed by either alpelisib with alpelisib plus AI. They found out that there was not much difference comparing it with chemotherapy. So your thoughts on that?
So I would definitely, maybe about 1 year back, I was not confident in giving hormonal therapies in what we called as visceral crisis patient, and we needed a rapid response. But because of these studies, we know that even if chemotherapy is not given in any formulation of is either AI first, followed by fulvestrant, or fulvestrant first, then AI along with Pluvicto, I think we will definitely get a response rate and we'll be able to palliate the patient well.
Okay, and one more thing, since this particular study, Solar 1, did not have many patients who received CDK4/6 inhibitors in the first line, what are your thoughts? Because nowadays our practice is to give CDK4/6 inhibitors, and there is enough data to suggest that even after CDK4/6 inhibitor use, about 35 to 40% patients will have PIK3 mutation as a resistance mechanism. So your thoughts on using Pluvicto post CDK4/6?
I am most comfortable using post CDK4/6 inhibitors. I think maybe after 3-4 years, when we have more data and more experience, we might be using it upfront like in Solar 1. But right now, what I am practicing is after CDK4/6 inhibitor failure, I am giving Pluvicto along with fulvestrant.
Okay. Thank you so much for your talk, and we thank you once again. Thank you. So after this very insightful discussion on Pluvicto, now we move on to our first panel discussion, which happens to be on CDK4/6 inhibitors. And this panel discussion, we would like to understand as to what all are the options available as far as CDK4/6 inhibitors are concerned, and how to really use them. And to take things forward in a very diligent sort of a manner, we have Dr. T.P. Sahu sir with us. Dr. T.P. Sahu sir is an eminent medical oncologist of our country, and he needs no introduction. He is a senior medical oncologist from Silver Line Hospital in Bhopal. Sir is known to delve deep into the minds of his panelists and try to understand the insights from the topic. So we are happy to have him here and be a part of this webinar. Sir, good morning.
Good morning, Rajat. Thank you. Thank you for inviting me.
Sir, should I invite the panelists?
Yeah, sure. Please do that. I'll share the screen by that time. Is that okay?
Yes, sir, please.
Yeah, please invite.
So the panelists that we have with us for this particular discussion on the treatment options in hormone receptor positive HER2 negative metastatic breast cancer is Dr. Nagendra from Gurgaon. Dr. Nagendra, are you there?
Yeah, I'm there, sir. I'm there, sir.
Good morning. Dr. Bhuvan Chugh.
Yeah, I'm there.
Good morning, Dr. Bhuvan. Dr. Manish Sharma from RGCI.
Manish is there. Manish is there. He has requested to someone to unmute him.
Okay, Dr. Manish, welcome. Dr. Mridul.
Yeah. Hi, Dr. Rajat. I'm here.
Hello. Welcome. Dr. Shruti Kate from Nashik.
Yeah, she is there. I saw her.
Dr. Shruti, good morning. Dr. Rishabh Kothari.
Yes, I am there.
Good morning. So, sir, over to you.
I think so. Rohit has joined, if I'm not wrong.
Yes, Dr. Rohit Pai has joined.
Rohit Pai?
Yeah.
Yeah.
Yes, right. And only Novak is missing. Yeah, that's it. Okay.
Dr. Novak had some personal issues. Yeah.
No,
yes.
that's okay. That's okay. That's fine. We just need to know who's in the panel. So, so let's move on directly, because I think they're running 10 minutes short of time already. So, thank you, organizers, for giving all of us the opportunity, and let's try to do a little bit different. I know most of the things are repetitive, and I will request the panel to be very short in the answers, and I will take a cue from the last line which the previous speaker spoke, that in the visceral crisis also he would not hesitate from giving a hormone therapy with the CDK4/6, and that was interesting statement to come through from a medical oncologist, and we will discuss. Let's see what the panel feels about it and what are the recommendations all about it. So that I will definitely like to discuss. So in the first case, we have a 60-year-old female diagnosed in 2013, and this patient was a hormone positive, HER2 negative, single node positive, and the size was a T2 size, and received adjuvant chemotherapy followed by a aromatase inhibitor for 5 years. So let me start with Nagin. Dr. Nagin, what is your strategy for hormone therapy? Do you stop at 5, or this is that you give to 10 years to all of your patients, or is it that you pick and choose your patients? Very quick answer on this.
So as the data is mature, as our understanding about the biology of the disease have increased, previously we used to give till 5 years AI. Now, because of the extended survival benefit, that disease-free survival is better. So we are extending the benefit to 10 years now, and we will be happy to use.
So is it for all your patients or for some of your patients?
For majority of patients who are having hormone receptor positive and HER2 negative breast cancer and high risk of metastasis, I will be happy to use them for 10 years.
Okay, so anyone in the panel still practices 5 years of adjuvant therapy, at least in the high risk? That would be a node positive, that would be something size more than 2 centimeters, that would be a little higher grade. That is what they would define as a high risk patient. Anyone in the panel wants to still practices 5 years, or I feel that all of us have changed to 8 to 10 years? Anyone who does practice 5 years? No? Okay, so just this I wanted to put it across, that this is something that we need to change. And there is data now, although there are a lot of issues that we can discuss in some other panel some other day, but we need to look at that most of our patients today, at least in the high risk hormone positive breast cancer, would be requiring an extended adjuvant hormone therapy. What you need to do is something different. How you need to do is beyond the scope of this panel, but this is something I wanted to bring out. Okay, so now we move on. Hormone therapy was stopped after 5 years. The patient presented after 13 months of stopping the AI. The PET scan showed multiple liver metastasis, and the PET scan also showed multiple bony metastasis. We did a biopsy, and the biopsy was again representative of hormone positive, HER2 negative. I just conclude that all of us in a representative sample where we can easily do a biopsy, all of us would agree that biopsy, we all do a biopsy from the metastatic site. If it is a difficult site, that's a different thing, but most of us agree on that. So I'll move on with that. I'm not going to spend time on that. These are the PET scan images. So now, Dr. Shruti, coming to you. You're there, Shruti?
Yes, sir.
Yeah. So what do you feel? A patient is a primary endocrine resistant, primary resistant or secondary resistant?
So, sir, this patient is secondary endocrine resistance, sir.
Okay. So this patient is a secondary endocrine resistant. That's what you feel. What would be a primary? Can you just define it for our viewers or some?
Sir, the patient who has, progressed on endocrine therapy, on endocrine adjuvant endocrine therapy, or less than 1 year of
after stopping. After stopping. Okay.
Yes.
Okay. So anyone wants to define it further, because this is something we as medical oncologists need to do it, especially when now we are planning to adopt CDK4/6 into a metastatic treatment paradigm. So
or
this is something.
In a metastatic setting, if it is less than 6 months while on first line therapy.
Okay, I think that is the definition important, Dr. Mridul. I will extend it to that. Dr. Shruti has spoken most of the definition correctly. Dr. Mridul, do you feel this definition is important, especially in the context of the CDK4/6?
Yes, sir, definitely, because we also want to decide the companion drug that we want to use with CDK4/6.
What exactly have you in mind?
Sorry, sir?
what exactly have you in mind? If there is a primary endocrine resistant, you would choose X drug. If it is not, you will prefer a B drug. Something in your mind?
Yeah, so if it is a primary endocrine resistance, then I'll use CDK4/6 with the fulvestrant. But if it is a secondary, then I think we can re-challenge with the AI with the CDK4/6 inhibitor.
Okay. Anyone wants to define it further? Because would you choose your CDK partner? Would you also look at that in a different perspective of a primary endocrine resistant and not? Dr. Rishabh, what is your idea on that?
Sir, I would agree with what Mridul told, that primary endocrine resistance or secondary, we will choose AI versus fulvestrant based on that.
Okay, so that is your take on it. Dr. Rohit, any take differently from this? I want to specify on the CDK4/6 inhibitors.
So I think, sir, I agree with what everyone has said.
Okay.
Only issue is in this particular case, 13 months you had said, and
yeah. No,
so
I told 13 months. So from
exactly.
the stoppage of the endocrine therapy. Yeah.
Exactly. So this is one patient where, even though by definition we are talking about a secondary, perhaps a secondary endocrine resistance, but I would consider treating such patients on borderline, because we don't know till when the liver metastases have been present. The patient has been manifested, has come to us for a long time, but looking at the PET scan, a studied liver, if we cannot just mathematically look at 12 months or 13 months. That is my take. I don't know.
Okay,
yeah,
that's fine. That's fine. Yeah. That's an arbitrary number. You just 1 month and apart does not make a change. That's the impression you want to give.
Yes.
But
yes.
I would like to just add on.
I would like to add here that in terms of a primary endocrine resistance, the choice of a CDK inhibitor may differ when it comes to the primary versus secondary endocrine resistance.
Tell me, Bhuvan.
So the thing is, we are looking at 3 drugs now, and the latest drug which has come has obviously brought upon the primary endocrine resistance more than the secondary endocrine resistance, because I think the most of the data which was present to us was based on the secondary endocrine resistance which was there. So the Pelvocyclip and the Pelvocyclip, which has been the one of the most early entrants, focus on the secondary endocrine resistance. However, the new drug which came in, Abemaciclib, is focused more on the primary endocrine resistance, and that's where it is trying to capture the market. Sorry, I'm just using that.
I think I will phrase it differently. Although we have I agree that's what the point is. All of us feel the subset data looks at that the with the Lilly drug. Bima, we all agree that the data is that it works on with the primary endocrine resistant patients, and there is significant hazards. I would not take a take-home conclusion, but the trend is towards that. While in the Palbo, it is not. So exactly, you pointed out what I exactly pointed, that we could also we could also find out that we can choose our CDK4/6 based on the endocrine resistant pattern. There is a trend towards it. It is not a conclusive data, but definitely this is one CDK4/6 inhibitor which has shown that probably in the primary endocrine resistant, we could choose this CDK4/6 rather than the other. Dr. Amish has a question, and I'll come down to that definitely. Visceral crisis. I want to point to this because the last statement was something. Does the panel agree with? Dr. Manish, do you agree that you will? How do you define a visceral crisis?
Sir, I lost your voice actually.
Do you agree with the statement made by the previous speaker that in a visceral crisis, not in a visceral metastasis, in a visceral crisis, you would be comfortable doing a CDK4/6 inhibitor with hormone therapy and not chemotherapy?
So if we look have a look on the response rates in various trials of chemotherapy and in CDK4/6 inhibitors.
What is the answer? A yes or a no?
Probably yes.
You would. Does the whole panel agree? And while the panel speaks, I would like to have Dr. Amish on the chat telling me whether he would practice the same way. With the whole panel agree that they do a visceral crisis no different as they do a visceral metastasis. Anyone in the panel who disagrees would come in. Please come out.
So I don't agree with it. I sincerely feel that even it has to be a real visceral crisis for me to push towards chemotherapy, especially because we are looking at the. So I just would like to take 30 seconds more. So when we're looking at a hormone resistance setting, there are three pathways. There's a PIK3 pathway. There is a, it's eventually the three pathways which come into the hormone resistance setting. When it comes to, so I don't think chemotherapy has a definite role there. I think because CDK pathway is a major pathway when you look at the hormone resistance setting. So when I can have a targeted therapy to hit at a resistant pathway, I would be tempted towards the resistant pathway rather than a broad chemotherapy. So if it is not a urgent, I need a response within a week.
Visceral crisis means urgent. I feel we need to define it. And if someone is using the word visceral crisis, and if I can go through just a minute, primary resistance is what people have been telling. Within the first 2 years on the primary or relapse while on first 2 years is primary resistant. I wanted to just put it down to the for everyone to clear up, and the progression within the first 6 months. This is when you are doing first and adjuvant. It is 2 criteria within the first 2 months or relapse within the first 2 years of adjuvant or progression within the first 6 months. Secondary is defined as relapse on adjuvant hormone therapy after the first 2 years or relapse within 12 months. Dr. Amish, this was within 12 months and this patient had beyond crossed the 12-month criteria. So that is for that. This is the ESMO definition. For the visceral crisis, I totally take it. I agree with Dr. Amish on the chat that I completely feel this is one scenario where one should err towards giving chemotherapy and probably consolidate a patient and then go for a hormone therapy with CDK4/6 if you are going to give that, or a hormone therapy, whatever is the line of criteria. So I think that is what the things would be. I think there is a difference of opinion and everyone is okay, and I think everyone has an opinion for that. But I think because the chemotherapy works faster, you do not have more time, you have that one chance. I think this is where it will be. The visceral metastasis will be different. I think that is what the consensus is. And if anyone disagrees, we have the chat box and that would be a very open thing. Let me move on. I think that 2 points are clear, the endocrine and this part. And I agree with Bhuvan that if you have a primary endocrine resistant, probably the Abema is a better drug to go through, although the level of evidence is not there, but in a randomized trial on a subset analysis, that is the data. So I will just skip this. This part is done. Go to the second case. 60 years old female, history of lump in the breast, true-cut biopsy done, again hormone positive, true-cut HER2 negative. The performance status is 1. Bone scan shows multiple bony mets. PET scan does not show any visceral disease. So what would be your treatment of choice? Let me start with Dr. Manish first and then Dr. Bhuvan.
So, treatment of choice sir, would be CDK4/6 inhibitor plus letrozole in this case.
Okay, CDK4/6 for letrozole. Everyone in the panel feels so. Dr. Bhuvan, you feel also the same thing?
Yes, I would. I say the same thing.
Anyone feels that this patient, because of bony mets, and there is data that fulvestrant 500 milligrams, the Falcon trial, and also the trial with anastrozole and fulvestrant has shown that the PFS is very, very good, significant. So why is there anyone who thinks that we can give this? Because I think Dr. Amish has echoed my concern. What does the panel feel like? Anyone who wants to try this and then go to a second line CDK4/6, or because it is a standard of care, I would not err for it. For affordable patient, I'd go for it. Dr. Shruti, your take on that?
Yes, sir. So this is some single agent fulvestrant as well as fulvestrant in combination with AI is also an acceptable option here. I would definitely want to offer that to the patient, and that should be kept as an option because it may be preferable by some of our patients due to many reasons. So that is also a valid option here.
Dr. Rohit, what is in your practice? In your 10 patients who come down to you, how many of them would receive a CDK4/6? How many of them in such patients would receive a hormone therapy alone? Maybe combination or a single agent?
So out of 10, I think only 1 or 2 will receive actually a CDK4/6 inhibitor.
It is because of the cost, or you all also
cost issues.
Okay, okay.
So
okay.
If it was left to me, sir, I would prefer to give the standard first line combination of CDK4/6 inhibitor plus AI. The subgroup analysis have shown even in bone only mets, even in across the subgroups, there is a reasonable benefit. I would prefer to use the standard first line. Practically speaking, sir, only 10 to 20%, sir, to answer your question, are actually
there is a pooled analysis of 5 randomized trials which of these CDK4/6 inhibitors, and they had seen across the various subgroups such as progesterone receptor negative trials and lobular breast carcinoma. Then bone-only metastasis was one of the subgroup analysis. So in that FDA pooled analysis in which all these 5 trials they were seen, the PFS was 27.3 months in bone metastasis compared with 15 months in
here the fulvestrant Falcon was around 22 months. It was 22 months is the impressive 22 months.
So across this subgroup also it was significant.
Agreed. So I'm not at all at a point arguing that the CDK4/6 does not have the superior data. It's a matter of fact that we should not, in this scenario, even I agree that we should be very much convinced about a single agent fulvestrant or the anisotropy fulvestrant, because costs are an issue, and that is a reality.
Who are not willing to pay the cost, I would go for CDK4/6.
Yeah, the only point which I wanted to point out is with the data, we have 20 to 23 months versus 27 months of PFS. I would be very happy if a patient takes their fulvestrant 500 or a combination in a sincerity and does not is not lost to follow. That's the only impression. I've never intend to tell that CDK4/6 is not a treatment of choice, but we normally in the fancy of adding a CDK4/6 somehow fail to convince a patient enough for this drugs combination. That's the only idea I had to put out. And I totally agree to all of your things.
May I add something, sir? May I add?
Yeah, please, Dr. Nagin, please.
So in the prevailing situation of COVID, sir, whether a decision will change if affordability of
I totally second the point.
Of COVID is on the way. So are we justified enough to use CDK4/6 inhibitor with AI?
You would not be doing a disharm to your patients. That's what I feel. And in the COVID scenario with third wave lurking around, I think this is a very valid option. And when Dr. Amish Vora vouches for you, you have nothing lost. And you can tell in the legal court, Dr. Amish Vora vouched for me. Okay? So that is for Dr. Amish. He told that on the chat. So you take a screenshot, put it in the court. Say, Dr. Amish has vouched for me.
And one more thing, sir, regarding the use of chemotherapy in the visceral beds as compared to CDK4 inhibitors, as we were discussing earlier. If you see the response rates to the chemotherapy and the response rates to the CDK4/6 inhibitor, I think the response rates are in tune of 50 to 60%, and similar responses we get in chemotherapy as well. I don't think we are going to do any harm if we are.
I totally take your point. I have the slide on response rates, but I still feel the standard consensus, even in all the guidelines and all the experts, is to give chemotherapy, because you have just one chance.
Except in the case where we are really defining it to be a visceral crisis, because sometimes we don't define visceral crisis correctly. And
we have to define it correctly. It is both a clinical parameter, it's both a laboratory parameter, rather than more of a radiological. It's more of a clinical and radio and laboratory parameters rather than the scans which should define your visceral crisis. So I think that debate will go on. We just move on to the next part of it. Now I go to Dr. Mridul. Dr. Mridul?
Yes, sir.
Yeah, which CDK4/6? The whole first line is there in front of you. And would you go for fulvestrant as a first line with your CDK4/6, because you have data now for first line for fulvestrant?
Sir, basically the magnitude of benefit is same with all the CDK4/6 inhibitors. Yeah. So we mainly have to look for the comorbidities and the toxicities that it can infer to the patient. In a 60-year-old postmenopausal lady, I'll be more comfortable using Pelvocyclip because of more personal experience with the drug. Although if there are no cardiotoxicities, then in fact ribociclib is also fine. I mean, all three are fine, but we just have to look for the comorbidities based on the magnitude.
So basically, you're looking at that. I look at the patient, the profile, and the toxicity, and then decide on the CDK4/6, because all of them look similar. The hazards is exactly sitting on the same point. Which I take a point, and that's what all the answers will be from every one of us. Dr. Rishabh, which hormone? A lot of you spoke of in that patient fulvestrant versus letrozole. You will go for fulvestrant. That is something important, because the choices are now getting so vast. Which is your hormonal agent of choice?
Sir, as of now, I am using AI in all the patients.
In this case, what we told, you would be using AI.
Yeah.
Okay.
AI.
Okay. Anyone would be using fulvestrant, because the maximum PFS data which has come actually has come from the fulvestrant data from Mona Lisa. That is the highest numerical number of 33.6. Anyone in the panel is interested for fulvestrant as a front line?
So we have a single trial, which is Persephone trial, which has compared palbociclib with fulvestrant versus palbo plus letrozole.
Exactly.
So with fulvestrant, I don't think it makes a difference, except in the cases in which we have ESR mutations.
Okay.
So those patients, if we are able to do the genomic assays and we find that there is ESR mutation, I think fulvestrant would make a difference here.
Fulvestrant is okay with you. So to take that on, Dr. Shruti, what the trial is speaking of is the Parsifal, and we find that this trial has shown that these two are okay and these two are similar. It was a non-inferiority trial, but I have an argument, Dr. Shruti, for those who use fulvestrant in the first line. My point is, would you give an injectable? I don't know why Amish and me already think in the same directions. So first thing, when there's a similar pattern and similar reason to do it, why do you want to give an injection in the front line? Second, Parsifal is a phase 2, which he spoke. We need something more randomized. Number 3, what do I do second line after I fail this CDK4/6? Because the data which I have for picking these patients is with fulvestrant. So why do I need to do a fulvestrant in the first line? Should it ever be considered, except for those special cases? Probably our standard of care should be oral AI. Dr. Shruti.
Sir, here the criteria of endocrine resistance would play a role, where I'm choosing fulvestrant over AI. Other than that, I agree with you that it is comparable. But wherein I don't want to use an AI, I would want to couple it with fulvestrant. So,
is there any data to tell of what you're speaking in that that this trial?
These trials have not. I mean, like these. The trials have been very selective on the populations that they have chosen. So I can't justify it very well, but given a choice, I will be equally open to fulvestrant and letrozole, and would want to I also will give a thought on sequencing. So I would definitely want to keep fulvestrant for the second line. In that case, either with alpelisib or
Dr. Rajat has put on the chat, and I totally was there. I'm with him on this study of the second line use of letrozole. But I still believe that fulvestrant with the injections going on and the median PFS is going to be much longer in the first line than in the second line. The PFS of around 24, 28, 30 months, that is going to be a big help for the patients to go on taking an injection. I personally in my practice believe strongly in the tablet and the CDK4/6. So this is what it was. Any one of you have experience on tamoxifen with CDK4/6? Would someone volunteer to come out on that? Dr. Rohit or Dr. Nagel or Dr. Manish, any one of you?
So tamoxifen and with CDK4/6, it was used in the Mona Lisa study with ribociclib. The issue was with cardiac issues. I think it is not recommended. I have not personally used it per se.
Okay. Anyone has some personal experience?
No.
Dr. Bhuvan?
No, sir. I've not used tamoxifen.
No. So anyone thinks that he can do that? Because I think this is an option which you can do. And if you look at this study, it looks very clearly that with ribociclib with the goserelin, you have to give a LHRH agonist. The study mandates that. And then the tamoxifen was there. You just cannot, the study did not ask you to give tamoxifen with a CDK4/6. It was LHRH agonist plus TAM plus the CDK4/6, and the data looks very, very impressive. So that is something which I wanted. Please.
There is significant toxicity with this combination.
Agreed. Totally agree. But the efficacy.
They have withdrawn that. They have withdrawn this indication, isn't it? Novartis guys have withdrawn this indication.
Yeah.
Yes. You will not be. There will be nobody to protect you in the court of law if you eventually.
I was coming to that. I was looking at the efficacy and then coming to the second part of it. The efficacy is very good, which I was also surprised with, because the toxicity was an issue when the first data came with CDK4/6, even with Palbo. And then this data came in, which looked very, very impressive with the Mona Lisa. And I think we all of us avoid using TAM, and this is where it is now. The Monarch 2, which people spoke of, and I think so, Bhuvan, you spoke of this. And this was something which you spoke of, the primary endocrine resistant. This is one subset analysis which showed that you have a significance for the monarch in contrast to the other CDK4/6 with prior to endocrine sensitivity. The others have not shown efficacy. This data has been spoken of. I'm going to skip this, coming to the last part of my discussion. First line or second line? Anyone has some ideas, and all of you believe it should be first line? Because I think that's what the panel felt. Anyone wants to reserve the CDK4/6 for the second line?
I won't. I personally won't.
Okay, you personally would like, and most of us would like. I'll just come to that in Rajat in a minute. But the only point is, although the hazards is exactly 0.5 odd for both the first line and second line for a CDK4/6, the PFS is much shorter in the second line. So I totally take your point that if a patient can afford, probably CDK4/6 front line is better than using in the second line. But if someone has not used it, then I think the second line you should be giving option. Also, the Indian data from Amit showed a very good thing. Even in the bony mets, although the data is small, the subset in second line, it did not matter. Both the bony mets and the visceral mets acted the same way, while in the first line, the bony mets with CDK4/6 did much superior to the visceral mets. That was the data from Dr. Amit, that 133 patient data. This concern has been spoken about till I will not go into much of it, but want to take up what Rajat has put in the chat. Is everyone convinced about the monarch data for primary endocrine resistant? Dr. Rohit, you first, and Dr. Mridul, you next.
So abemaciclib is a somewhat of a different drug than ribo and palbo, and I would definitely consider using it in a primary endocrine.
So if you have a primary endocrine resistant,
I would consider, sir. Yes, sir.
So that is your go-to drug.
I would consider, sir. I have not had the opportunity of using it. I would consider, definitely.
Yes. So definitely you consider all the CDK4/6, but that would be something you put.
Abema.
Dr. Mridul, in that setting, what is your go-to drug? Although the data is still, we would like to have a larger data of that.
So definitely, since the primary endocrine resistance, then should try for abemaciclib in the first.
Rishabh, your take on that?
Sir, with whatever data we have and financial concern means are similar, so I would not hesitate to give abema when there is primary resistance.
Okay, so again, I think the panel is quite clear, and I think Dr. Rajat, you want to add something here? You had something in mind which you want to add, you can just pitch in and add. Because I think the panel feels that although we would like to have further robust data, but whatever data we have, if there is a given a choice and the toxicity is not a concern, the abema would be a go-to drug probably in this select patient who are primary endocrine resistant. Dr. Rajat, you wanted to make a point?
I agree. I completely agree, sir, with all the panelists that if we have this data with the monarch study, and there are very few other trials which have really tried to rake up this issue, there is no point extrapolating the data from the other trials, and we should agree that abemaciclib definitely is a drug which is a little different. We have other indications of abemaciclib also in the adjuvant setting. We have the trial, so definitely there is a difference. Our understanding of the CDK4/6 in terms of the genomics may not be very complete as of now, but if there is a primary endocrine resistance, I will also be very comfortable using abemaciclib instead of Palbase and Crixana.
So this is what all of you spoke about, the response rates, and this is where it is. It is a very high 50s to 60s. What you get in a CDK4/6 with the endocrine therapy. That was what people were speaking about. Could we use this in visceral crisis? And
I would like to add there. Manish said that the response rate for a, I personally think when he is talking about response rate of 50 to 60%, it is not for a single agent chemotherapy.
No.
Yes. So if you look at the if you look at the toxicity profiles of it, it's completely different. And especially coming to Nagendra's point, if it's a COVID period going on, I would be, if I have to give a double agent chemotherapy to somebody who has a visceral crisis, I might as well take a slight chance with a, the CDK rather than taking a dual agent chemotherapy.
I would hear, I'll go against what you're saying, because the panel has to be very clearly that the evidence is not out there for us, all of us, to tell that. I would still go for a chemotherapy, and I would still go for a chemotherapy because the guidelines have not changed it. And these patients are going to do definitely bad, and these patients might sue you in the court. For all these reasons, I would definitely still be very, very careful before going into this line of treatment. If yes, the consent should be very clearly mentioned that you have offered chemotherapy and they have refused chemotherapy. That is the only advice I can give to all of you. I think that is all I can tell, because this debate otherwise will never end. But you are at your own right to choose your drug combination, a chemo versus a CDK4/6. But the data is there, science is there. But I think we need little more than science, and we don't have a randomized trial as such, and this will never going to come. So that is something that is my concern. Anyone has a concern of the overall survival data for CDK4/6? If there is something, please pitch in. I will otherwise skip this and go to the last part of it. Yeah, please. Anyone? All of you are convinced? Because the Palvocyclip data, there is nothing convincing as the OS. The PFS is the strong point. We have OS data very strong for the ribociclib. We have data for the Abema. For the Palbo, the best data we have is the with the fulvestrant, not with the front line. Anyone has a concern with that? Rushabh and Nagin, any concerns with the lack of OS data?
Sir, for all three,
for Palbo, I'm just speaking of Palbo, because the other two, some data of OS is there. For the Palbo with fulvestrant, there is some near close to confidence interval, it is there.
So sir, currently I use all of them interchangeably except some primary resistance or all that. So I'm not considering lack of.
You are not much concerned about the OS data. Okay. Dr. Nagin, you have the same thought, or you want to have something different?
Yeah, I do agree, sir, with my co-panelist. What I want to convey is that all the CDK4/6 are not equal; they are equivalent. There is a difference in terms of like oral survival benefit is not there as of now for palbociclib, but there are advantages with other. That's the way science evolves. Over a period of time, all data will be mature, and then we'll be able to compare. But they are all equivalent for the time being. Yes, we can choose depending on the pros and cons of each.
Okay. So basically, I come to the point that although there might be some OS data lacking in one of the few trials, but still all of us convinced that they are nearly the equivalent drugs. So no argument on that. For the CNS, any preference again, Dr. Rohit and then Dr. Shruti?
So probably abemaciclib.
Probably Abema. Dr. Shruti?
Abema, I agree. And even ribociclib has some data. I mean, it is like a subgroup analysis and in visceral crisis, in brain metastasis, and it has.
Dr. Manish, your take on that? Abema, still inking towards Abema?
I think Abema would be the drug of choice.
Okay, because the data is there. The others, it is not, it does not work. The data is coming up, but I think Abema had the earliest data, so all of us feel that way. Dr. Mridul, any data call on metastatic breast cancer, chemotherapy versus CDK4/6? Any upfront data you would like to quote? The last part of it. Dr. Mridul?
Yes, sir. Yeah. So again, the only thing is maybe visceral crisis is the one indication that upfront chemotherapy.
Okay. Otherwise,
used, but otherwise, again, in the hormone therapy.
There are two trials. I'll just skip in because we have 1 more minute. Young Pearl and the Pearl data. And the Young Pearl data was phase 2 again, the palbociclib, exemestane, leupride with capecitabine, because that was the eligibility criteria. And they found that there was slightly superiority with the palbo, exemestane, leupride data. But the Pearl study design, when it came through, there are two cohorts, fulvestrant, palbociclib with capecitabine. The other one was the exemestane with the palbociclib and the capecitabine. They found it to be numerically inferior, the endocrine arm, but statistically insignificant. So basically, if you look at two trials which are putting it upfront directly with their criticism, shows that both work in the setting, but the trend normally is we go ahead and do the patient's front line, second line, and third line hormone therapy with the partners as we choose, and then we go to chemotherapy as a last point of it. Dr. Bhuvan, you agree to that part of it?
So again, I think coming to it, sir, I would like to look at what kind of visceral crisis. So my take is a slightly
leave the visceral crisis part. We can have it first because I have 1 minute left. I want to come to the part that would in any visceral metastasis or any metastatic disease in a hormone positive, HER2 negative, you go on exhausting your hormone therapy choices first, and then go to chemotherapy.
I totally
Do you agree with the rest? Yeah.
Totally
but I want to point out the two trials which are shown, the Pearl and the Young Pearl, they look similar. Both the trials look similar for both the agents. So I conclude here because the organizers have told, okay, can opinion or panelist difference between, okay. So now, is there anyone who has to want to tell it, at least with the ribociclib, that there is a subset of hormone positive breast cancers who would not do well with CDK4/6? I'll phrase it a little different. A subset of hormone positive breast cancer patients who would not do probably good with ribociclib. There is some data that has evolved over this last 6 months. Anyone in the panel has some idea on it?
So I did read about the resistance pathways, because we are talking about the resistance pathway of CDK inhibitors is what we are talking about basically here. So I agree with Dr. Rajat in terms of when you look at the hormone positive receptors. I couldn't figure out at the end of it which pathway is primarily involved in CDK resistance. So that's I think the science is still to develop there.
The small data that has come, I'll just add on to the pitch in here, that basal cell have not done that well with the ribociclib. That was what has come out with the small analysis, but it is nothing to take home as a conclusion. The data is evolving, which patients of hormone positive to choose, which not to give CDK4/6. These are not good probably. There's some data coming up that probably basal cell varieties don't do that well. That we can have some other day, Rajat. I think there is a good data that is evolving with ribociclib. So to conclude, there are this is an interesting time to be a medical oncologist, and this is why it is interesting that all of us can come together on a Sunday morning and debate and agree to disagree. That is what happened, especially with the Bristol crisis. We are spoiled with too many choices. That's why the disagreements are going to grow only. The CDK4/6 with hormone therapy are the best option, preferably in the first time. That's what the panel spoke. Premenopausal, probably because of the long data which is there, ribociclib, all of us that go through that drug. In unaffordable, in a select patient, let's say bone mets, hormone with positive hormone therapy alone or a combination of dual hormone therapy could be offered. I don't tell it is superior to the CDK4/6 combination. Post progression, the option should be a PIK3 inhibitor or a AKT inhibitor or with mTOR, will depend upon what Dr. Bhuvan has been speaking about, which pathway. You need to choose the resistance pathway, and that is how you are going to get your best possible survival for your breast cancer patient. With that, I stop, and I'm sorry if I could not give enough time to any of the panelists, but it was an interesting discussion, and thank you, Dr. Rajat, for giving all of us the opportunity. Thank you, Dr. Amish, for being active on the chat, and I think I've covered most of it, but the only disagreement at the end of the day was with Bhuvan, which we could not convince him to do chemotherapy in Bristol crisis. So he has this fair idea.
I had a chat with Dr. Amish. I think we have agreed to disagree on the fact that so we are looking at the type
that is fine. Crisis. That is fine. That is why the panels are so interesting, rather than a monologue of a talk. That's and I respect your views. Thank you, Rajat. Thank you, everyone.
Thank you, sir. Thank you so much. Thank you, Dr. Sahu. Thank you, all the panelists. Thank you, sir, for making this panel a very nice discussion. It was very expected, and I think it surpassed all the expectations. The fiery manner in which you tried to probe all the panelists. There were a lot of important topics that were really discussed, and certainly there can't be answers to all the questions, but as we move on, we will learn more and more about these things. Thank you for being a part of this webinar. So now we move on. So after this we finish with the breast cancer updates, and now we start to talk about the lung cancer updates. And in the lung cancer updates, we have a lot of presentations which are lined up. But the first presentation is on the comprehensive genomic profiling in lung cancer, and this presentation is what I myself I'm going to take up. So I'll be sharing my slides. This topic is on key to open the right door at the right time, and we're talking about Foundation One Medicine by Rash. So what we are going to talk about in the next 15 minutes or so is about how cancer and genomics, they are very interestingly related. What exactly is cancer genomic profiling, comprehensive genomic profiling, how CGP has come up in many cancers and more so in lung cancer, and few case studies which I personally have experienced, and how it has helped the patients is what I'll be talking about to my esteemed audience. So cancer and genomics, as we all know, cancer is not only a disease where there is a rapid multiplication of cells, there is also a lot of mutation in the genes which is going on. And these mutations are generally set off by a lot of external factors, be it radiation or carcinogens, which actually induce the mistakes in the central dogma of converting a DNA to RNA and then RNA to protein, because of which the cells rapidly start multiplying. The multiple copy number variations and mutations keep on accumulating, and this is what it leads to eventually as a carcinoma. As we understand from the Cancer Genome Atlas in the last few years, the human genome is very wide, over 20,000 genes. But if you look at the cancer, there are only a few hundred genes which are implicated in the pathway of carcinoma or cancer. Having said that, we also know from the Cancer Genome Atlas and the studies previous to that, that cancer is a heterogeneous process and it evolves rapidly. So this particular scheme or the diagram on your screen right now tells us that if you look at the size of clones of cancers as it moves along with time, a particular clonal selection is always on the cards. And as the cancer keeps on evolving in the body, there is a challenge of detecting the selection in a particular growing tumor. So if you look at the different colors which are depicted in this screen, there are multiple areas within a particular tumor where there will be genes which are implicated as having driver mutations, and there will be areas where the mutations are not really driver, and in the sense they are more of passenger. So in this screen, we can see that most of the mutations which are there in this particular clone of tumor is with ERBB2, and there are certain passenger mutations as well. So always the driver mutations are more strong, although they may be rare. And this is what we really have to bring out once we are trying to talk about a particular mutation which has led to cancer in a particular patient. So on the same topic of cancer being heterogeneous, we also know that there is a difference between a primary tumor and a metastasis. So the primary tumor may have a particular genetic mutation, but not necessarily will that genetic mutation be there in the metastasis. So we do know that there is a term called clonal evolution. So during metastasis, these clonal evolution mechanisms keep on taking place. And this screen also tells us very clearly that the clonal evolution is a process which also leads to the resistance in the given treatment. If we talk about the resistance mechanisms, these resistance mechanisms can either be de novo mutations, or they can be some mutations which have progressed, or they have come due to selection pressure because of the treatment which has been given. So our effort is, once we are trying to find out the genetic mutations in a particular case, and for that matter in lung cancer more so, our effort is to try and bring out these mutations in a much more in a as far an elucidated manner as much as we can, so that we can help the patient in the best possible manner. So these are the various types of genetic mutations which can be there. So if this is on the left-handmost side of the screen, we have a chromosome which is a normal chromosome. So we can have copy number alterations, we can have substitutions in a particular locus in a gene, we can have insertions and deletions, and we can also have genetic rearrangements. So these are the various types of aberrations. Sorry, we can have various types of aberrations, and these aberrations are the points of interest that we have to look at once we are mapping a particular patient's genome to find out the various genetic intended mutations. If you talk about the genetic sequencing, then these genomic sequencing and the various methods to find out are there in front of your screen. So we have immunohistochemistry, we have fluorescent in situ hybridization, we have polymerase chain reaction. These are the methods by which we are able to find out the individual mutations. But if we talk about the genomic sequencing, then the methods that we have are the Sanger sequencing method, which is an age-old time-tested method, takes time, but it is still the gold standard. Then we have the next generation sequencing based platforms where we have the hotspot testing. And then what we are really trying to bring across in this discussion is about the comprehensive genomic profiling. So this particular graph is, or the diagram is very important. If we talk about the central dogma, that is from the DNA to the RNA and then to the protein, then the DNA to the transcription to the RNA and translation to the protein. To really tap this particular central dogma process, we have real-time PCR and RNA sequencing for DNA and RNA, and for the protein expression to be understood, we have immunohistochemistry. But before that, if we have to really delve deeper into the genomics and try to find out between the particular genes whether we are having a mutation in the exons or the introns, we have the process called genomic sequencing, which I said can be looked at by either a Sanger sequencing method or NGS platform. So trying to delve deeper into what I just mentioned, if we talk about IHC, PCR, and FISH, then the routine single marker tests are these markers. The pitfalls of these tests, which we have been doing for years together now, when we did not have a broad molecular profiling like NGS or CGP, was that it used to really look at only the few aberrations, and many of the aberrations used to be missed. Then number 2 category is about the NGS and in a hotspot manner. Hotspot basically, like this particular graph tells us, hotspot is nothing but trying to find out a select region in a particular exon region of a gene where we have a pre-specified mutation which is present. This is called hotspot. So hotspot will look at only the particular regions in the exon of a particular gene, not the whole gene sequence per se. So that is the reason that this graph tells us that there are still few areas which can be missed by the hotspot NGS. But if we come to the complete profiling, which is the comprehensive genomic profiling, it helps us to know and test for all the known clinically relevant cancer genes threadbare. This is what we really want to do, so that if a particular patient has a particular mutation, that should not be missed in order to provide the best care to the patient. Another diagram to suggest the same, that if you look at the exon sequences and just ignore the introns, then these exon sequences will have various hotspots or pre-specified mutations which can be picked up on hotspot NGS, but there still will be few areas which will be missed. To not let these areas get missed, we have an approach called the comprehensive genomic profiling approach, where the sequencing of the coding region of the selected genes is done in its entirety. So another diagram to tell us that how the hotspot NGS and the comprehensive genomic profiling being offered by Foundation Medicine is different. Again, like I said, that there are various clinically relevant genomic alterations that we have, be it the base pair substitutions, the insertions, deletions, CNVs, and the rearrangements. So the hotspot NGS is going to look at mostly the base pair substitutions. At times, they can look at the small insertions as well. But if we talk about the CGPs, they look at the base pair substitutions, the insertions and deletions, copy number alterations, and rearrangements, all of them. So what exactly is comprehensive genomic profiling? This is the graph which tells us very clearly that if we have probes which are put in a particular genome to look at the sequences, CGP is doing nothing but providing overlap probes so that a particular genome or a gene can be covered in its entirety. That is, a thorough coverage is given, which increases the sensitivity. Very clear from this diagram that these probes are overlapping so that we need not miss any particular information, whichever position of a genome or a exon that particular information is. So the depth of reading is very high and highly sensitive, much more than what it is for hotspot NGS. Again, the same thing depicted here, that if you look at the PCR based NGS and the hybrid capture based NGS, the region of alignment, which is basically nothing but the sequence reads that we want to have, they are all stacked vertically here. And if you see, the region of alignment has gaps in between here. If you look at the left hand side of our screen. But if you look at the hybrid capture based NGS, which is CGP, it is a continuum and all the genes are being read in a sequential manner. So what exactly does FMI do? So FMI helps us to do a lot of things. One is that it helps us to detect the insertions and the deletions. It also detects the long deletions, which are often missed by hotspots. It also not only tells us about the fusion genes, but also the fusion variant partners are also told by the foundation medicine. So what is the result? So from bench to bedside, we've all spoken about how it should be in the laboratory, but then of course we have to replicate it in the clinics as well, so that it is important for us to tell the patients as to how they will benefit once this testing is done. So if this testing is done, we see that there is ample data to suggest that there are many mutations which are missed by hotspot, or for that matter individual gene testing, which are picked up by comprehensive genomic profiling. So if you look at the overall lung cancer genes, about 25% of the genes are picked up extra as compared to hotspot. About 17% of EGFR deletions are missed, which are picked up by CGP. About 20% of EGFR point mutations are missed by non-CGP methods, is what was pointed out in a study in 2018. And similar is with ALK fusions, about 30 to 35%. So 50% of targetable alterations are missed, is according to one study in 2016. So definitely in 2021, we would not like to miss all these and provide the best possible genetic tests to the patients, so that these patients can benefit from the targeted therapies that we have with us. And when we're talking about Foundation One, this is a validated test by even US FDA. And we all know that the gamut of Foundation One is not only for Foundation One in solid tumors, but Foundation One has now come up in liquid tumors as well, where the liquid biopsies as well, where we are doing liquid biopsies for solid tumors where tissue is not available. This is done by peripheral whole blood. And also they have Foundation One heme for hematological malignancies and sarcomas also, that is both bone sarcomas and soft tissue sarcomas. So they are looking at more than 300 genes. And one thing which is very important is that they are also looking at MSI testing, tumor mutation burden, and very recently started to include the LOH as well. So we all know what is LOH. LOH is loss of heterozygosity, and this has come up in a big way in ovarian cancer with the coming up of Ariel 3 trial for rucaparib and a subset analysis for Solo 1 trial in olaparib, where it has been seen that if you look at the BRCA mutation LOH, and if it is high, the patients are labeled as HRD positive, and these HRD positive patients, as the Kaplan-Meier curves on this screen are very well alluding to, there is an improvement in PFS in patients who are given PARP inhibitors. In this trial currently in front of you, which is the Ariel 3 trial, the LOH was calculated based on the Foundation Medicine NGS assay only. So this is a companion diagnostic test which is approved by US FDA, and we should offer this test to our patients if we have to extend the benefit of now available PARP inhibitors in recurrent ovarian cancer, or for that matter a first-line ovarian cancer. We all know about tumor mutation burden. Tumor mutation burden is the number of mutations per mega base of genome. And we know that if more are the tumor mutations burden, there are different cutoffs. Most of the trials have taken the cutoffs as 10 mutations per MB. More is the mutation, more are the chances of immunotherapy working in such patients. And there is strong data, at least from colorectal cancer, to suggest that. So this also is included in the Foundation One test. And this is the benefit that we can extend to our patients. Talking about lung cancer and CGP, we all know that lung cancer has evolved over a period of last 1.5 to 2 decades. Multiple molecular tests have started to, molecular genes have started to come up in the genomic profile of lung cancer, where in 2004 we only had 2 genes as the genetic aberrations, and now in 2020 we have over 15 genes. We all know that, and there is a host of drugs as targeted therapies which have come up, most of them being oral therapies, and many of these therapies are available in India, and we've been using them for many years, and we know that all these therapies improve the overall survival, or if not OS, then at least the PFS is certainly improved according to the data that we have till now. So we as clinicians would want to extend this benefit to our patients. And as we understand that this benefit can be extended only when we test them properly. And for this proper testing, the part of comprehensive genomic profiling is what is being offered as this test of Foundation 1 medicine. So there is ample data to suggest that 20 to 30% of patients are detected extra if we are doing CGP over and above the genetic tests which are detected by either the individual based testings or the hotspot NGS. Coming to the case studies, I have 2 case studies to show. These are my patients where I have been fortunate enough of using CGP, that is Foundation 1, and my patients have benefited. This lady whom I had 2 years back was a 78-year-old lady. She was a non-smoker with a large right upper lobe lung mass. And she had a history of a right upper lobe lobectomy, which was in the curative setting few years back, and now it was a metastatic disease. In the PET scan, there were multiple skeletal mets, adrenal metastasis. She had right-sided pleural effusion. It came out to be a non-small cell lung cancer, adenocarcinoma, as we were expecting. We did the molecular testing, which was individual testing by EGFR, by PCR, FISH, ALK by FISH, and CMET, BRAF, and ROS1 also by individual testing methods, and PDL1. The result came out to be that all molecular testing was negative. PDL1 was 0%. So obviously she was told to start on chemotherapy. This was much before we even started to send molecular tests, because she was symptomatic. So she was suggested to be started on chemotherapy. But as all of you will agree that she being a 78-year-old lady, the relatives were reluctant. They did not. So in the meantime, she developed a massive pleural effusion, started to have breathlessness. She had to be admitted to the hospital, and ICD was inserted. They were still reluctant for chemotherapy. So then they were told about Foundation 1 comprehensive genomic profiling. They initially had issues with it because they were skeptical about these genetic tests, but eventually they agreed. And this is what the report came out to be, that it was that this patient had a EGFR mutation, which was a rare mutation, which was a V774M, and a coexistent rare mutation of S768I. So when the literature was searched, it was decided to start the patient on afatinib. Although a low dose afatinib was started with 20 milligrams per day, and the patient did very well. There was drying up of the pleural fluid. The PS started to improve. She had an improvement in the appetite, weight gain, and now she continues to be PS1 after 14 months of therapy. A little side effects of afatinib here and there, but she's tolerating it well. This is a patient whom the relatives had almost given up. They probably thought that she's going to not live for more than 10 to 15 days. And this is what the effect of CGP Foundation medicine has had on her. Another patient, this was a male patient, 48-year-old, detected to have multiple skeletal mets, supraclavicular, cervical, and mediastinal lymph nodes, and a right-sided lung mass. Again, the biopsy was done, and it was found to be an adenocarcinoma, a non-smoker male, and this patient was told to be on chemotherapy and was told about the genetic tests, but initially they were reluctant. Again, the chemotherapy was poorly tolerated in this patient. One of the reasons was the poor PS in the beginning, and the other was that he happened to be a thalassemia minor, so had repeated anemia and quite a significant anemia with pemetrexate and carboplatin. So a Foundation 1 testing was advised, and in this Foundation 1, we were very happy to know that this patient had a EML ALK gene rearrangement, and after this, the patient was started on alectinib, and he tolerated alectinib well, and in the subsequent PET scans, he has been showing a good response, and his PS has improved and is doing well now. So with this, I end my presentation. I'd like to summarize saying that CGP is definitely an evolving process in our minds. We should discuss this particular type of genomic testing more and more with our patients. Yes, cost is definitely a constraint, as all of us will agree, but then this is something that is definitely beneficial for our patients and much more than what it is with the individual testing and comprehensive and the hotspot NGS based methods. With this, I thank you for your patient listening. So now on moving on with our lung cancer updates, the next session is by Dr. Anita Ramesh ma'am. I welcome ma'am and thank her for being a part of this webinar. Good morning, ma'am.
Yes, good afternoon.
Ma'am, good afternoon. So ma'am is an eminent medical oncologist of our country, and she needs no introduction. She is a senior consultant in the medical oncology and pediatric oncology from Chennai. And ma'am will be taking us through the session of management of EGFR mutant positive non-small cell lung cancer in 2021. How do we really need to treat such patients? Over to you, ma'am.
Yes, thank you very much, and warm welcome from Chennai. Yes, we are short of time, and then we'll just try to look into the key points. How do we manage and mutation positive non-small cell lung cancer? With the Globocon data and the lung cancer incidence increasing, you can very well see what's going to be the number of estimated cases as in over a period of the coming decade 2030 and 2040, and there is a relatively increase both sex as well as in all the ages. The mortality as well is going to increase over a period of time as calculated by the recent projected model. Now, if you see to the moving of the histology based on the targeting oncogenic drive, there is in Asia, if you see where the arrow points, 40 to 55% do have the EGFR mutation, which is much, much higher than what you see in USA and in Europe. And with the subsequent histologies, it is increased, there's an increase in it. And that's roundly telling us it's a high incidence what we see in this part of the country. The EGFR is a mixture of many receptors, 4 from the ERB family, HER positive, HER2, 3 positive, as well as 4 positive. And this family causes signal transduction, causes cell proliferation, inhibition of apoptosis, and as they undergo the phosphorylation and sends the signaling transduction down. Okay, and so there are several types of mutations which are also seen in this, and these are the mutations which are like activating mutations, which is presently over there. That is the as seen in the chart, and very more uncommon new mutations are also coming into it. Okay, so if you go to the next, page of our thing that shows the they are the targets for the TKI therapies. And also there are the response to the anti-TKR is also superior, and 80 to 90% of the EGFR mutation are present in the exons of 18 and 21. And mutations in exon of 18, 20, 19 and 21 are predictive of sensitivity, whereas deletion 19 and L858R, which is almost 44%, okay, are a thing to be discussed separately because the drugs are a little different and the sensitivity to the TKIs has to be done in a judicious manner. So let's look into the molecular difference of the EGFR mutations. And these mutations tells us the different subtypes. And in this sequencing, you see the compound sequencing is also there. And so it leads to the compounds sequencing leads to many of the deletions L858R coming together. So if in the incidence of the concomitant mutation and the clinical outcomes, definitely it's much inferior to then what it is seen without the compound mutation. So one thing to remember, tumor mutational burdens, because we are just talking about the EGFR mutated tumors, thus the tumor mutational burden also is associated with the clinical outcome in metastatic patient. And it is, if you have a high tumor burden, it negatively affects your clinical outcome. And that also needs to be also taken into the consideration. Now, if you see the T790 mutation, and you see that the deletion 19 are having more of the T790 mutation compared to the L858R mutations. And the prevalence of unknown mutation is more common in L858R compared to deletion 19. And these things has to be remembered because we are going to plan therapy. And also, if you see the in vitro sensitivities, the graph which shows dacometinib, in fact, is quite sensitive. The levels of as per the mutation, and also the second and the third generation. Basically, the second generation, which is apatinib and dacometinib, and the third generation, that is the osimertinib, are the ones which is mainly having a high level of in vitro sensitivities. So there is a difference between exon 19 deletion and exon 20 deletion, depending upon the sensitivity of their TKIs, their concomitant mutation, whether you had been treated earlier and your pre-treatment T790 mutation or acquired mutation. So let's look into the subsequent C, and we'll see one case and how do we sequence these drugs. 65 persistent smoker, non-smoker, persistent cough, has a nodule, metastatic lung cancer. Yes, definitely biopsy with the molecular studies is needed, and we need to know what is the right TKI to optimize these treatment for these mutation positive non-small cell lung cancer. Several things needs to be looked into before we plan treatment. And we have, as you know, we have 5 drugs available in our armamentarium, which the olatinib and geptinib is the first generation, whereas the afatinib and the dacometinib in the second generation, whereas the osimertinib in the third generation TKIs. So, and the first generations are usually reversible, and they are not very active on 790 mutation. The second generations are irreversible, but yes, they do inhibit the ERF family, and they do have a much larger and broader mechanism of the overcoming the resistance because of the irreversible binding, and also they do action against the uncommon mutations. Whereas osimertinib, yes, it is a third generation and is very specific to the EGFR 790 mutation. So now, if you see the first generation TKIs are heterogeneous, then if you go to the second, now as you keep treating with them, more homologous clones comes into it, and finally, as you go down the line, more heterogeneous clones line comes into it. Now, so there are a lot of sequencing and different options are available, whether you give osimertinib and then switch on to chemotherapy, or you start with first and second generation TKI, and if it fails, if the mutation is positive, you give osimertinib. If the mutation is negative, switch to chemotherapy, or any other mutations are there like MET and HER2, treat accordingly. Or TKI and chemotherapy, as we have seen the data from India, quite promising with the first generation TKI and chemotherapy. So several options are available, and they are all valid options. And we are here now to discuss the pros and cons and how to use them judiciously. And let's see what is the incidence of the T790 mutation positive in the real world. As we know, the T790 detection is highly heterogeneous across these studies, so it is very difficult to make a comment. But then it also needs whether we are what type of biopsy, when you are doing the biopsy, where is the biopsy to be done. But definitely the incidence of 790 mutation is much higher on a repeated sample, as suggested by some of these studies. Now, if you see the if any of the samples, 36% will be positive for T790 mutation, whereas 80% becomes positive in the subsequent mutation. So the incidence of the T79 mutation, there's higher incidence in DEL19 patients. Okay, so some of the mutations do harbor more of these resistant stains. Now let's look into another case. This patient had 619 deletion and some glutathione 746 and ALA 750 deletions for them. Now, how do we treat them? Then what is the best line of option in younger patient with deletion 19? We do have the Lux lung data with apatinib having a benefit in the overall survival, and also there is a favors the osimertinib. So both is an valuable option. And the 2 years probability of sequencing afatinib with afatinib followed by osimertinib in DEL19 patients, we had a 2 years probability of 84%. So we did start afatinib for this patient because they had a reimbursement. And so if you see the sequence, after almost a little more than 2 years, the patient has progression. And what we have seen that there is a better outcome with afatinib, and it's a major uncommon mutation. And the first generation, if you see, the overall response rate is only 42%, whereas the second generation in afatinib, the overall response rate is 71%, whereas the overall response rate, even the third generation, is 50. And it all differs by the type of mutation. And it's the second generation, particularly afatinib. And if you see in the center box, which tells us that some of the mutations are highly sensitive to afatinib. And that's the boxed out, and the median progression-free survival is almost 10 months. And that gives us a clue or an answer, quick question. If you get an uncommon mutation in your molecular profiling of these tumors, think of afatinib as the drug of choice. Now, the EGFR blockade and the adverse reaction, yes, these do have, even the first generation, second generation, yes, stomatitis, paronychia, rashes, acne, and diarrhea. And I'm sure all of us are familiar and we know, but the second generation with dacomatinib and afatinib is a little more than the first and the third generation. So the higher incidence is there, and because they have a broader range of activities in the second generation. But one way of looking into it, the toxicity of any grade are predictive of higher progression-free survival and an overall survival benefit, if you see this. And yes, we do dose adjustment, but it has been seen like drugs with afatinib, dose adjustment has not compromised the efficacy. So let's look into how long can we pull a patient to get a chemo-free in these, maybe 1 year, 2 years, or something more than that, and the longer the overall survival versus the longer chemo period. So as we discussed, sequencing of afatinib followed by osimertinib, provided you don't have the T790 mutation. And the geotag trial has shown when you do get initially with osimertinib, you can get followed by chemotherapy, best supportive care, you get an advantage of 38.6 months, okay, by good performance status. But if you have started with afatinib followed by osimertinib, and then you restart the chemotherapy, and that's another way of looking into it. Even the afatinib osimertinib is also a definitive approach, and to get something more than 38 months of the benefit, or up to even 40 months as the data says. And after you finish, yes, you do get on progression T790 mutation, and that is what is more expected out of this sequencing. Now, and the other way of looking into it, if you have already started them on first line osimertinib, yes, we do have resistance developing, and T79M 60% develops in both first and second generation, and does also develop if you had used an afatinib, as we are seeing. Most of the acquired resistance from the first line osimertinib is not targetable, but if you have a 790 which is developed after first, second line TKI, yes, you have osimertinib with you. So that's the difference. If you have finished up osimertinib in the first line and more mutations developed, you will not be able to target them. But if you have not use osimertinib and you have a 790 in a second hand. So that is an important thing for all of us to remember. The osimertinib is approved in first line, but then you don't have anything to treat after that. So this chemo-free interval is very much important for our daily practice. And as long as you're able to pull and give them without chemotherapy is what we are looking into. And also remember the deletion 19s and the L8R mutations. So we'll skip this because the geotag also does shows an improvement. And even in the older population, if you go in this sequencing, you have a longer chemo-free period. So there was an overall involvement. If you see L8R8, brain metastasis, poor performance status, yes, they also did well. Without brain mets, deletion 19, Asian population, Asian with deletion 19. And Asian with deletion 19 had almost 40 months on time without the, in this sequencing. So that was quite something observed if you follow this sequence, which was not seen in any of the other sequencing. And again, the overall survival in various subgroups, as deleted, it reaches up to 45 months overall, approximately a year, 3 years, crossing the 36 months limit to show that there is a benefit. Yes, let's look into the drug interactions and TKIs. Yes, apatinib does causes enzyme. The first generation, second generation is not that very much common. Yeah, particularly they have a interaction with the PPIs, that is omeprazole, ranitidine, and they also have with the alatinib and geptinib. Yes, some of the enzyme inducers and enzyme inhibitors do react with them. Now let's look into what are the options if you already have a brain metastasis. Yes, TKI and radiation is an option. Osimertinib has more brain penetration. Yes, even afatinib does, because being a second line. And again, in sequencing was done in the GeoTac trial to look into how much of the chemo-free interval you give and what is the best response that can be achieved in these patients with baseline brain mets. What are the common options if you have a poor performance status? Yes, again, this combination holds good. Now, don't forget there is another second line drug, the dacomotinib, and which was compared with the Archer trial with the geptinib. It's also a pan-HER inhibitor, irreversible, did show a survival benefit. Even the updated data showed a survival advantage. And they did a sub-analysis on the subtypes, particularly exon 19, exon 21 deletion. It all showed that there was improvement in the progression-free survival. And if you see the chart comparison, so it's definitely a drug to be compared and to be considered. And when we use the dacopotinib in all the subgroups, the combination was a preferred one with the prolonged progression-free survival, and particularly patients with L858R mutations, so which did not lead into. So, and if you see also the recommendation and the consensus forum for the L858R, okay, and high priority recommendation is dacomotinib, followed by alatinib and bevacizumab. So exon 21. So in L885R patient, dacomotinib has shown a much superior benefit over the other TKI and was the only TKI. So as I already told you, over here treatment matters in what the deletion is and where the mutation is and how you are going to play with these drugs. So based on molecular and clinical data, exon 19 deletion and exon 21 L88R should be considered a two distinctive type. They should not be clubbed together because the different EGFR TKIs have different role on exon 19 and exon 21. Exon 21 is a difficult to treat mutation, and we do have drugs like dacomotinib, which has definitely shown an advantage, has a prolongation in the progression-free survival, overall survival in these patients, and they do well than the exon 19 when this drug is used. Again, a subset of patients who has, that's the Archer trial. Now, also, there is a subset of patient, as I already told you, uncommon mutation. Any uncommon mutation, if you have an access, yes, apatinib is the drug of choice. But yes, if you are not having an access to the drug due to logistics, yes, chemotherapy. There's a very good article 2 years back, which TKI to prioritize to osimertinib, apatinib, first generation. Again, till date, it's a debate whether we give the first and the second, or we give osimertinib first, followed by chemotherapy and the others. As I told you, if you utilize your osimertinib, the mutations which developed after its failure is not targetable, whereas if you give afatinib earlier, you do get tumors with high 790 mutation, which can be treated by osimertinib, and that sequencing has shown that osimertinib in second line in both the groups did show a longer overall progression of survival. Yes, not taking much time, we'll not get into all these. There are more studies coming up to support what is the best sequencing in different parts of the world to let us know. And then I leave it today. And at this junction, yes, many of us do use first and second line TKIs upfront, because particularly if we are in the medical college setting, when we don't have access to the other, yes, that's also an important option. Remember, TKIs with chemotherapy is also an option. 790 mutation, osimertinib is the drug of choice. And if they fail, yes, chemotherapy. Also remember, if you're doing a liquid biopsy, look for MET and HER2 inhibitors. They are also targetable. Drugs are available. Atypical mutation, afatinib is the drug of choice. And you have exon 21, L8R8. Yes, don't forget about dacomatinib. And I thank everybody. Thank you so much. Thank you so much.
Thank you, ma'am. Thank you for this wonderful talk. Very comprehensive discussion on how we should take things forward as far as the EGFR mutant NSCLC is concerned. Ma'am, I had few questions. Ma'am, in your practice, after using osimertinib, is there any untoward side effect that you have really experienced? It is generally believed that it is a very innocuous drug and most of our patients tolerate it well. So in your practice, do you also encounter a similar sort of a scenario where there is a good tolerance to this therapy, or any adverse effect that you would like to bring across to our audience?
See, like alotinib, geftinib, osimertinib is a relatively safe drug. We don't have much toxicity along with it. And it's quite like how you say, yes, we don't know the patient is taking any drug. But definitely afatinib and dacomatinib, as I showed you in one of my charts, the second generations do have more toxicities like diarrhea, rashes, paronychia, stomatitis. But remember, these are also related to improvement in the progression-free survival. But then a quality of life is what matters, what you rightly told. Yes, these are very safe drugs like osimertinib to be used upfront, and you not basically have much of the side effects. And also you need to orient the patient that this can happen at any point of time.
Okay. Ma'am, two things that I would like to really bring across. One is that in the FLORA study, we had a subset analysis where the Asian patients and the non-Asian patients, the hazard ratio was 1, exactly 1. That means that probably there is a thought that this osimertinib is not working very well in Asian patients. So does that deter you from using osimertinib in your daily practice?
See, osimertinib, I will always keep as a second agent. That's what I told you. If you utilize osimertinib first and you do a repeat biopsy, the mutations are a little uncommon and not targetable. But if you use either the first and second generation, which I use in my medical college, but when I come to my reimbursement sector, I have another drug, afatinib and dacomatinib, I do use. And you know, when they fail and you have a 790 mutation, you have another drug. You can again prolong it to 12, 18, and maybe 24 months. Another. So I usually keep osimertinib as my second line at any point of time, until and unless the upfront by histopathology says there's a 790 mutation upfront, then osimertinib becomes my first drug of choice.
So ma'am, your go-to drug in the first line is generally a second generation inhibitor if the patient is having a good performance status?
And affordable.
And affordable. Okay.
Also, and if I'm in the medical college, okay, half of my practice in the medical college, there I also use first generation and also chemotherapy, pemetrexed, carboplatin with geftinib, okay, or geftinib, alotinib, poor performance status, just those drugs because they get approved by the government. First generation is approved.
Okay.
Use that because in India, you should not leave that as an option. That is
yes.
an option as India is concerned, and 50% of our population do get that particular treatment. More than 50, Rajat. It's more than
yes,
50.
Yes, ma'am. I agree. Definitely agree. And Dr. Amish Vora on the chat is saying that are we Asians, really Asians genetically? It is a very valid point that as well. So, ma'am, I thank you again for your presentation and your discussion, and thank you for being a part of this webinar. Thank you.
Thank you so much. I know my program now. Thank you.
Yes. Thank you. So we move ahead now. And the next talk that we have is is on the topic again of metastatic non-small cell lung cancer, and this talk is on the discussion between the two types of EGFR mutants. One is the deletion 19 and the other is L858R. So are these two different types of diseases as far as the EGFR mutant NSCLC is concerned, or are they the same? And to do justice to this topic, we have an illustrious medical oncologist who does not need any introduction. Still, I will like to do my duty of introducing him to my audience. And he happens to be the director and co-founder of Hope Oncology Clinic. With us, we have Dr. Amish Vora, sir. I thank you wholeheartedly for being a part of this webinar. Over to you, sir.
Thank you, Rajat. And first of all, I must congratulate you the way you presented genomic profiling. I think it was amazing, Rajat.
Thank you.
You know, we need to have some workshop, as I mentioned in the chat. And I congratulate Dr. Anita Ramesh also for covering the things very comprehensively and setting the stage for my talk. So the talk, what Dr. Rajat gave today is are deletion 19 and point mutation of L858 are different diseases in EGFR mutated patients of metastatic non-small cell lung cancer. Now, with this is something which is, again, I think I will have to request, I have some issue with this thing. Can I request the organizers to share my screen, show my slides? There is some issue with my this thing. Yeah. Okay, perfect. We have the full screen. Okay. Perfect. Can I have the next slide, please? No, we are sharing the screen. Yes. Is my, okay, right. So I am starting with my screen is visible and am I audible, Rajat?
Yes, sir, absolutely.
Okay, perfect. So 5 months back, I had a patient, 59-year-old female, non-tobacco user, presented with hemoptysis. Investigation showed a lung hilar mass of 4 by 5 centimeter, mediastinal lymph nodes, bilateral lung nodules, supraclavicular lymph nodes on the right side, and 1 adrenal lesion. The biopsy was suggestive of adeno-CA, which was expected. NGS for lung panel and FISH for ALK was sent, and the mutation report came as L858R exon 21 positive. Next slide, please. So the thought came in my mind at that point of time is that, you know, all EGFR mutations are not exactly the same. If you have exon 20 insertion, we are not supposed to give TKI. If you have PS2, performance status of 2 and brain mets, I think TMH study of Geftinib plus chemotherapy had one of the inclusion criteria, and we need to consider that. If patient can afford and little frail, and this is where I would differ with Anita ma'am little bit, is that if patient can afford, I think with deletion 19 especially, osimertinib is one of the drug to go to. But the question is, what about L858R exon 21? Is it same as other mutations? Next slide, please. And that's when I thought we always do check the version 5 2021 NCCN guidelines. And when I click on the first one, I see that exon 19 and L858 are still considered in the same bracket. Next slide, please. And in that same bracket, there are at least 5 category 1 recommendations. So by law, if we follow NCCN guidelines, whether it is deletion 19 or whether it is L858R, you can use osimertinib, erlotinib, efatinib, geftinib, and dacometinib as category 1. Next slide, please. So this, I came across a letter to editor in 2007. This was a time, remember, that IPA study and erlotinib studies came up, and we all were very gaga over tyrosine kinase inhibitors. And this was the first letter to editor which raised the question, are deletion 19 and L858 are different or are they the same? Next slide, please. So the journey then began, and that is the time when I started looking up, when I got this speech invite. If deletion 19 and exon 21 L858 are different, then clinical presentation will be different, molecular characteristics will be different, and outcome to same treatment would be different. Next slide, please. So this is the article which came, which showed that is there a clinical difference? They studied all the parameters. This is again an Asian study. And what they found that deletion 19 are more younger and they have more lymph node metastasis. But nothing to choose much from, right? You know, you have a 55-year-old, you have a 45-year-old, you have a 60-year-old. Majority of the metastatic non-small cell lung cancer in India will have lymph nodes for sure. Next slide, please. So this is some slides which are shown by Anita ma'am also. We know that molecular characteristics of EGFR gene is located on the short arm of chromosome 7. Next slide, please. And these, when they become mutated, they become the driver mutation, which drive the carcinogenesis. 93% of EGFR mutations are present in exon 18, 19, 20, and 21. Next slide, please. And that is what we need to concentrate when we study and when we want to treat these patients with tyrosine kinase inhibitors. Can I have the next slide, please? Yes. And one more slide. So deletion 19, one more slide. Deletion 19 and L858 are 45% and 40% across all the studies have shown. 95% will be either exon 19 or exon 21. Can we have the next slide, please? So this, if you see, this is one of the very, very important. This is where Dr. Anita Ramesh also had said, and this is where actually I don't believe that North Indians are genetically Asian, and there is a study between North Indian and South Indian. South Indians have completely different genetic makeup. We are more towards Caucasian. And as you would see from day one in the morning, Dr. Jyoti Bhadwa presented a real world scenario of Pelvocyclip in India, was exactly mimicking what was there in clinical trial. The difference in the Asian and forward we will discuss is that exon 21L858R was more commonly seen in Asian subpopulation as compared to European and American population. Can I have the next slide, please? This was seen that, I don't know, there are some slides which are skipped. Anyway, I'll go forward. The concomitant mutations also was seen more commonly with L858R mutations and concomitant mutations. In fact, I came to know that the word concomitant is based on NCI dictionary. And this, if it is present and if you treat with tyrosine kinase inhibitor alone, you have a poor overall survival. Next slide, please. Again, this was shown by Dr. Anita Ramesh that tumor mutation burden was low in deletion 19 and tumor mutation burden was high in exon 21. More the tumor mutation burden, there are more chances of TP53 mutations being present, and tumor mutation burden has a negative outcome if you treat with first generation tyrosine kinase inhibitor. Next slide, please. So to sum up in a molecular pathway, the pre-treatment or the primary T790M mutation is more present in L858R, while the acquired T790 mutation is more present in deletion 19. Tumor mutation burden is less in deletion 19 and more in L858R. Concomitant mutations are more in L858R and less in deletion 19. And as a result, clinically, DEL19 should respond better with tyrosine kinase inhibitor as compared to L858R. Is it actually true? Next slide, please. This was the meta-analysis. I'm going to present 2 or 3 meta-analysis. This was the earlier meta-analysis of 7 large randomized trials where tyrosine kinase inhibitor was compared with chemotherapy. If you see, as compared to chemotherapy, both DEL19 and exon 21 L858R are better. But if you see the hazard ratio in the bracket, the hazard ratio with deletion 19 is 0.24 as compared to hazard ratio of 0.48 with Egfr. That means there is some difference in the first generation TKI between the two mutations. Next slide, please. The response rate, if you see on my left-hand side, is much higher. As that means that the patient will respond faster and more deeper with first generation tyrosine kinase inhibitor, which remains category 1 in both the exons. Next slide, please. One more meta-analysis which is there, which again shows exactly the same thing, and this was outside the setting of RCT. These are the published trials which have again shown that DEL19 is better with first generation TKI. Next slide, please. Next slide, please. This Dr. Anita Ramesh has already covered. Okay, so finally, there are 6 different reasons that L858R is inferior to DEL19 when you treat with first generation tyrosine kinase inhibitor, and we have covered all the 6. In addition to that, it was seen in vitro that G1 arrest with Geftinib works faster in DEL19 compared to exon 21. Can I have the next slide, please? So far, I can surmise is that in 2021, July, that is today, the first generation tyrosine kinase inhibitor may not be enough to tackle L858R for sure. Next slide, please. So what options do we have? We have second generation tyrosine kinase inhibitor, we have third generation tyrosine kinase inhibitor, and we have a combination of TKI with either chemotherapy or VEGF inhibitors. Next slide, please. So let's look at the second generation, afatinib, Lux Lung 3 and Lux Lung 6. This is compared with chemotherapy. And the next slide, please. If you see this, the overall survival advantage, what is shown and what has been presented with afatinib, is true with deletion 19. But it is not true with L858R. So what it means is that you use afatinib, that is a second generation tyrosine kinase inhibitor, with L858R mutation in your patient, PFS advantage will be there, but overall survival advantage has not been reported so far. Next slide, please. And it was surprising that Lux Lung 7, when afatinib was compared with Geftinib, even deletion 19 or L858R, there was a PFS advantage, but there was no overall survival advantage. Next slide, please. And the next slide. Third generation tyrosine kinase inhibitors. This is the poster boy of today's, the 2020 and 2021 discussion. And surprisingly, again, in entire Asian population, osimertinib did not have overall survival. And in L858R, which included, there was no overall survival with osimertinib. This was little surprising, but this is what has been reported. Next slide, please. So now let's come to the combination. And this was again a slide presented by Dr. Anita Ramesh also. You see a combination of chemotherapy with Geftinib. PFS was very good. But if you take the same in overall survival, L858R, there was no overall survival, even if you add chemotherapy. Next slide, please. I love to present this data because this is our own Indian data and we are so proud of Dr. Narona and her team. This did not show a separate DEL19 and L858R, but this definitely showed that overall survival advantage, and this we need to keep it in mind. Next slide, please. So, anti-VEGF inhibitors again showed a very good performance, progression-free survival advantage, a very good progression-free survival advantage. Next slide, please. And this was the seen in relay trial. I really like this trial. And Dr. Kumar Prabhash, right from last 5 years in every panel, asks, why don't we add anti-VEGF with erlotinib if we are looking at a better PFS? And this was one of the things where ramucirumab was added to erlotinib, and we saw a very good performance there, progression-free survival advantage. Next slide, please. OS data is immature, but the curves are looking very, very encouraging. I would like to look at the overall survival of this relay trial. It actually shows a very good thing. The only issue with ramucirumab is the cost. Injectables and proteinuria and hypertension sometimes can become a major issue. Next slide, please. So this is to sum up that side effect profile when you add the combination is always going to be high, but we medical oncologists are trained to look at the side effects and we should not shy away from that. Next slide, please. This was the surmise of what I said so far, that a combination looks promising, better with PFS as compared to single agent first generation, second generation, and the third generation tyrosine kinase inhibitor as far as L858R is concerned. Overall survival data so far has not been seen in L858R. Next slide, please. So we come to one more drug which is left to be discussed, that is dacomatinib. Again, it's a second generation irreversible binding of EGFR, HER2, 2, 3, 4. I will not go into the details of that. Next slide, please. This is again was shown by Dr. Anita Ramesh, but I would say that why dacomatinib was found to be better. This was in vitro cell line studies done. You look at on my right hand side, third generation osimertinib. Del 19, you see basically the IC50, which was there was 1.1. While in L858R, it was 9. Go back to my left-hand side, the first generation tyrosine kinase inhibitor in L858R, IC50. This means that there will be a supra high dose of geftinib and erlotinib would be required, and a higher doses of osimertinib would be required for the disease control if we use this tyrosine kinase inhibitor. Next slide, please. Clinically, does this translate in vitro to in vivo and clinically? Let's look at that. The next slide. The registrational trial of dacomatinib, as we all know, is Archer 1050. Interesting thing which I found was there was a pre-stratified randomization between exon 19 deletion and L858R point mutation. So they did stratify that they want to study this differently. Next slide, please. PFS, if you see, classically exactly the same, unlike the Asian studies where the PFS with the first generation TKI was different in exon 21 and exon 19. Next slide, please. I feel this data can't be ignored today in 2021 July. This was, to the best of my knowledge and to the best of what I have studied so far, the first trial which showed OS advantage in exon 21 L858R point mutation. I don't know why afatinib has not shown, why osimertinib has not shown. I think in vitro and the development of dacomatinib is different. And as a result of that, it is working better on either concomitant mutations or G1 cell arrest or IC50, whatever you say. But overall survival advantage was seen with dacomatinib in exon 21 L858R. Next slide, please. And PFS advantage with Archer study was numerically very high, statistically significant. So not only the disease control would be longer, close to 20 months with dacomatinib, and there would be an overall survival. What it means that the second line and the third line treatment also will have an impact on survival if you use dacomatinib in the first line in L858R. Next slide, please. If you compare Flora and if you compare Archer, again I am surprised that the third generation tyrosine kinase inhibitor did not have an OS advantage with L858R, while Archer 1050 had. Next slide, please. This was Dr. Suresh Ramalingam, the famous Indian origin US doctor, who was the first author in FLORA trial, also did a pooled analysis with erlotinib. Next slide, please. Dacomatinib and erlotinib. This was the two trials which were pooled together. Next slide, please. And there was a trend towards improvement in overall survival. So geftinib and erlotinib, when compared with dacomatinib, definitely was better trend towards overall survival. Next slide, please. So this is to sum up. If you have the first generation tyrosine kinase inhibitor in L858R, they are not good. If you use the second generation, if you compare with the first generation, either PFS or OS advantage was not there. If you look at osimertinib, that is the third generation, PFS data is there, but OS data is not there. If you combine either with chemotherapy or combine with anti-VEGF, and I want to again stress on relay trial, is actually looks very good PFS, but we are waiting for overall survival data. So cross is not the right thing. I think question mark should be there in overall in this chart. Come to dacomatinib, which is in the center of this slide. You have PFS advantage and you have overall survival advantage. Next slide, please. Icing on the cake is, and what Dr. Anita Ramesh also had presented this, if you have L858R mutation, the 2020 Lung Cancer Summit Forum consensus said either high priority, moderate priority, or lower. In the high priority, you can use erlotinib plus bevacizumab. You can use icotinib. We have not presented or covered the data of icotinib today. Or we can use dacomatinib, which has PFS and OS advantage. Next slide, please. Can I have the next slide, please? So this would be, again, I am very proud. Whenever there is an Indian data, I feel I am not able to present and our colleagues are presenting. This was the real world experience. Dr. Bibas Biswas presented this in many of the forums from TMC Kolkata. There was a 43 patients, out of which 12 patients of L858R, and they used dacomatinib in all these patients with 45 milligram in 34 patients and 30 milligram in 9 patients. Of course, we need to deal with the side effect profile of second generation tyrosine kinase inhibitors, and 42 to 60% of patients will require the dose interruptions. But the most important thing is look at the 2-year PFS. This is unbelievable, 57.5%. Now, I request TMC Kolkata to take this forward and try to take this into a randomized controlled trial, because this would say two things. One, dacomatinib is a good TKI. Second, Indians are genetically different from Asians or Caucasians, if this is true. Next slide, please. So to summarize my talk today, EGFR 19 deletion and EGFR 21 point mutation of L858R should be considered two distinct subtypes. Different tyrosine kinase inhibitors have a different role in these two mutations. The first generation tyrosine kinase inhibitor preferably should not be used. The second generation tyrosine kinase inhibitor, dacomatinib, has PFS and OS advantage. And the third generation tyrosine kinase inhibitors, osimertinib, which is available, is on the moderate recommendation, but without overall survival which being reported. So dacomatinib is the only one right now with OS advantage. Combination of erlotinib with ramucirumab is excellent. We need to wait for OS data. In terms of CNS activity, we need more data and dose optimization. We have data with osimertinib, but we need to have data. We also have data of TMH where they included CNS metastasis in patient of geftinib plus chemotherapy Treatment strategies should be earmarked, benchmark on comprehensive analysis, what we have spoken so far, and of course the cost. Thank you so much. And I thank Dr. Rajat Bajaj for giving me this opportunity. And I wanted to thank Dr. Manisha Nara from Pfizer for helping me make this presentation. Without her, it would not be good. And it's so nice to see Ullas's face on Sunday afternoon. I forgot to mention him in my presentation, which I feel so sorry about. Thank you so much.
Thank you, sir. Thank you for this very clear, crisp elucidation of your thoughts on the two types of EGFR mutant NSCLC, which now they have come to be. One is L858R and the other is DEL19. There are few questions in my mind that I would like to ask you. So as you very rightly pointed out, and a very clear presentation saying that there is only a OS benefit with dacometinib, and no other trial has shown that, although we may hope that with relay trial it may come into the picture after a few months or so. But then in your OPD practice, have you already started to change your treatment and offer dacometinib to such patients who are coming to you with L858R, or still there is any reservation?
So actually, Rajat, the last case which I presented, I started on osimertinib because see, first of all, so now since Ullas is there, all patients of lung cancer in Delhi go to Ullas for second opinion. So okay. I checked for NCCN guidelines, and since NCCN guideline mentioned preferred choice in both, I started on osimertinib, and the second patient of L858R, I started with geftinib plus chemotherapy. Once you gave me this topic to discuss for today, that is the time when I also started reading. And so this is a new thing. I think this question we can ask Ullas, since he is there, and jokes apart, he actually has a more experience. So Ullas, have you changed to dacometinib in L858R?
Sir, good afternoon.
Good afternoon, Rajat. Okay, so I do agree that L858R and DEL19 are prognostically different. There is no doubt about it. We have published our literature. I think with first and second generation TKIs, we have around 11 months of PFS with DEL19. We have 9.8 months of PFS with L858R, and that's our published data now. Regarding second generation afatinib, our article is almost getting published in IJC. And we have a PFS of 15.4 months in that. It's a 43 subgroup study. Now, whether it's a predictive marker to dacometinib or osimertinib, that is something to be seen. I am not yet fully convinced, but yes, it's a good option. The point is, if somebody cannot afford osimertinib.
So we want, sorry, we want one answer, because you yourself say that you can't do
this to me. So I think in 2021, we are beginning to look at it. I would be absolutely okay if somebody really gives that. I'll be absolutely okay. If patient can't afford osimertinib, I'll be absolutely okay to give. And we are doing more studies. We are doing a retrospective study of all our 150 patients in which we are looking at co-mutations. We need some more data, but we have definitely it's more than a 50% distance that we have covered to understand fully. It's definitely worth a thought. That's what I'm saying.
No, so true. And Dr. Nagendra also has asked a question in chat box that the brain mets patients were intentionally excluded. There is nothing like intentionally excluded.
No. I'll answer that, because I spoke to Tony Mock. And he said that Pfizer came to, not Pfizer, the other people with dacometinib was there. They came to him and they said, we want a positive trial. We don't want a negative trial. So he said, the moment you want
and you are saying this on record.
I am saying this on record. It's there on Tony Mock. So last Max, this thing in which Nitesh and everybody was there, Tony Mock said this on record. They want a positive trial.
Okay. So if he said on the record, I'm okay with you.
He has. It's there on YouTube.
I think all TKIs have been shown to have a blood-brain penetration, and osimertinib has shown to be having a 9 times higher penetration in blood-brain barrier, and that's the reason it is showing a good activity. And probably that's the reason that geftinib plus chemo by Narona et al. Also included brain mets. So I think there is no reason for me to believe that either afatinib or dacometinib will not work in brain mets patient.
So there is another data which says that the patients on dacometinib, the post-hoc analysis of Archer, very few of them have developed brain mets actually. But again, we need to understand that Archer did not include these patients. So I mean, although we have a phase 4 trial of dacometinib in which we are enrolling patients of brain mets, stable brain mets, asymptomatic brain mets without RT, we are including that. Out of our 16 patients 18 patients that we had, only one has progressed till now. To me, people, I mean, a second generation TKI is an absolutely, with a 30 mg dose, is an absolutely fantastic alternative to Neurona et al. And I'm sure Vinita is going to kill me for that. But to me, in lung cancer, it's all about avoiding chemotherapy. I will not give gefitinib chemotherapy. I would give a second generation TKIs any day. If somebody cannot afford osimertinib, which 98% of people are people, poor people, not Hope Cancer Center can afford. So OC, if you can't afford, I'm absolutely looking given dacometinib. That's what I do in my clinical practice.
Rajat, just to add on to what Ullas has said, I honestly believe that erlotinib plus VEGF inhibitors, we should explore more and more where people can, because the PFS consistently. Tell me one study where PFS is not better compared to first generation.
But OS has not increased.
And it is
OS has not increased.
How many of the first generation TKI has shown an OS advantage?
Yes, yes.
So
how your Archer study,
osimertinib Asian subpopulation, where is OS advantage? So what I'm saying is that PF is very good, and they respond. They in fact bevacizumab with erlotinib I have used in few patients. They tolerate it quite well without any issues. And 1.5 to 2 years is the PFS. I think in lung cancer stage 4 is very good. उसके बाद उल्लास के पास भेज दो क्लिनिकल ट्रायल में कुछ ना कुछ करके और लंबा 3-4 साल जिला लेगा पेशेंट को.
Right. सर उसके पहले भेज दो, हमारे पास अभी 2 ट्रायल और भी आ रहे हैं. So just to place on record, we have a exon 20 insertion trial coming on of amivantamab plus chemotherapy in another 15 days. So all you NGS people, all your NGS people, do send that. We have trial post osimertinib also. We have trial post this thing also. So send all the patients for trials.
True. Agreed, Ullas. Done.
Right, sir. Right, sir. Thank you so much for your very nice presentation.
Rajat, I think I have overshot my. I think we have overshot my time. So can I just say we will all give durvalumab in stage 3 lung cancer and finish it off Sunday?
Oh no, Ullas. I concluded 5 minutes earlier. So you have all the time. We want to listen to you.
Okay. Yes, sir. We do want to listen to you. Thank you, sir. Thank you so much.
Rajat?
So we move on to the next session, and sir, just allow me to introduce you as a very privileged to introduce you. So sir, thank you.
राजीव गांधी में जब तुम थे तब तो तुमने ऐसा कभी कहा नहीं. अब तुम ये सारी बातें कहते रहते हो. चलो बताओ.
It is a pleasure to have Dr. Batra sir here this Sunday afternoon. It was not very difficult to convince him, like always, and he was gracious enough. And he is the co-director of Department of Medical Oncology and Chief of Thoracic Medical Surgery. We are happy to have you here, sir, and very eager
Thoracic
to
Medical
listen to
Surgery. Rajat?
Sorry, medical oncology. Even such. So that. So even that is also not entirely wrong. So your thoughts on durvalumab in stage 3 NSCLC? Are we actually going towards increasing hope for cure?
Okay.
Over to you.
So thank you, Rajat. Thank you for the very kind introduction, and I really hope I'm able to live to the grand essays, the things that you say about me. So durvalumab in stage 3 non-small cell lung cancer, increasing hopes for cure. And my first reactions when I first saw this, the title of my talk was like 5 years back on the occasion of Breast Cancer Survivors Day. The CEO sir asked me over there, took me to a corner and asked me, why not have a lung cancer survivors day also? That I still remember was in 2015, I think at that time. And my reactions was, sir, mazak kar rahe ho kya? And I told him over there, sir, it's not fair. You cannot compare a lung cancer to breast cancer. Then your breast cancer triple negative is better than EGFR mutant or ALK stage non-small cell lung cancer. My subsequent reactions over there at time was, gosh, I really wish this day would actually come true. So that was what in 2015. Let's just start at what exactly was happening with stage 3 non-small cell lung cancer in 2015 or 1988 and all throughout that. You give Unresectable non-small cell lung cancer, you give CTRT and you tell the patient, "हम लोग cure कर रहे हैं." You know, Rajat will remember that statement of mine. Congratulations, the disease has not gone to brain, it has not gone to the opposite lung, liver. We can actually cure you out of the disease. What we did not tell the patient was that even if you do CTRT, 40% of patients will have a local regional metastasis, 50% of patients will have a distant metastasis, and a 5-year OS will be only 15 to 25%. In fact, 15%. Stage 3 breast cancer triple negative, the same figures is around 60%. Stage 3, let's say the other cancers, the colon cancer, you still are talking about 40 to 50%. But lung cancer, 5-year OS of only 15-25% was not something which we're very proud about. So patient used to ask us, "Is that all you got?" And we said, "No, we will try." So we tried. This is just a brief summary of, what all have we done till now. We started with only radiotherapy. Then we gave to sequential RT and versus RT alone. Sequential RT was better. Then concurrent CTRT was tried between RT alone. Concurrent CTRT was better. Then concurrent CTRT was compared against sequential CTRT. Concurrent CTRT was better. Then induction chemotherapy was compared against CCRT. CCRT was better. Consolidation chemotherapy was compared against CCRT. CCRT was better. And ultimately, we found out that platinum-based concurrent chemo radiotherapy was a standard of care. But unfortunately, that also led to only a 15% overall survival at 5 years. Remember that that figure, ladies and gentlemen. So we all had limited progress. We gave induction chemotherapy, consolidation chemo, consolidation docetaxel, pemetrexed, cetuximab, erlotinib, MUC1 immunotherapy, but the end results were all the same. And all the permutation and combination basically said all the trials were negative, negative, negative. I mean, it was almost like my DNB, my DM results over there. Whatever I do over there, it was all negative, negative, negative at that time. So this was there, which was there before Pacific trial in 2015. And this was the harsh truth, 15.1% people living at 5 years. And this was the harsh truth. Whether you increase the dose of radiation, whether you give induction chemo, whether you change chemotherapy, whether you give consolidation chemo, whether you add whatever, this was the harsh truth, 5 years survival of 15%. And please remember this figure, ladies and gentlemen. This was the survival improvement in stage 3 non-small cell lung cancer. In 1980s, you had 10 months and you had 17.7 months in 2015. 2015, 2014 was almost the time that Pacific trial was launched. It was also the time that Dr. Rajat BAJAJ came into practice, and I think Rajat was a lucky charm for stage 3 non-small cell lung cancer or Pacific trial at that time. Now, this is one nice thing which I want to show. Just look at the median survival time. Let's say in 2017, 2018, you had a patient of EGFR mutant non-small cell lung cancer. You will actually have a survival of 33, 34 months. ALK, you will have 45, 60 months. IO, you will have around 30, 40 months. IO chemo was slightly lesser at that time. But if you look at stage 3 non-small cell lung cancer curative setting, actually the survival was lesser than what you could have in a stage 4. So in fact, Kumar Prabhash did tell me, should we reverse the staging? Is it time to change that the staging of lung cancer? So this was almost like stage 3 was like my career getting rotten and Rajiv Gandhi was going down south. And Rajat's career at that time was like stage 4, going up and up and up. And I needed help in 2014, 2015, and lung cancer also needed help at that time. So the help came in the front in the form of Bahubali. The Bahubali of lung cancer was durvalumab, which was a savior in stage 3 unresectable non-small cell lung cancer. So this was the Pacific design, simple design. Patients with stage 3 non-small cell lung cancer patient, after they have finished CTRT, you want to give them durvalumab for bi-monthly versus placebo for a year, and you compare the PFS and the OS. Simple design, durvalumab was compared against placebo. Now, why durvalumab? Because it is presumed that chemoradiation will induce the tumor antigen release. Chemoradiation will lead to PD-L1 overexpression, which will lead to immune cell evasion. Durvalumab will reverses the immune suppression and really leads to a systemic anti-tumor response. So very, very simple. Chemoradiation causes the release of neoantigens. Durvalumab is an anti-PD-L1. It will probably act against over there. Now, if anybody is awake at this time at the lunchtime on Sunday, disease. So this is just the patient's baseline characteristics, and you please see It was not only stage 3B, even stage 3A, 52.9 and 52.7% of people were having a stage 3A disease also in the Pacific trial. Again, you see, it was not only a concurrent CTRT. Patients had taken induction chemotherapy also, because in India, a lot of the time I get a phone call कि sir induction chemo दिया हुआ था, तो अब हम उनको CTRT के में durvalumab दे सकते हैं कि नहीं दे सकते हैं? You can definitely give. 27% of people had received induction chemotherapy in the Pacific trial, which is again depicted over here. 711 patients received concurrent CTRT. 191 patients received induction chemotherapy and then CTRT. So induction chemotherapy definitely is allowed in this. Now this was the results which was there in updated 5-year OS in the ASCO 2021. Remember, 15% surviving at that time. Now it is 42.9 versus 33.4% of people, with a median PF OS of 47.5 versus 29.1 months. 18 months difference in the OS advantage in a curative setting. That is phenomenal. Again, the PFS was there, which actually also had improved. 33.1% having a PFS at 5 years is phenomenal actually. This is the only approved immunotherapy to show a sustained and durable PFS of 33.1% at 5 years. Safety summary. So a lot of time when we initially said we give immunotherapy along with the radiotherapy, you'll have pneumonitis. I mean, that is what I was very, very scared about. And that's the first thing I looked at in the Pacific trial summary. But please look at it. A grade 3, grade 4 pneumonitis was seen only in 4% of people, as vis-a-vis against 3% of people in the placebo arm. So that definitely was not a concern at that time. Now, people, there was a lot of hula boo about less than 14 days, more than 14 days. Again, there was no difference in the toxicity profile if you start durvalumab less than 14 days or more than 14 days. It is absolutely fantastic. Now, this is what I was showing you in the data over there. If you have RT alone, you have 12 months. If you have CTRT, you have 18 months median OS. RTOG, 29 months, 29.5 months. But if you have a Pacific trial, you have 47.5% of the median OS in a stage 3. Now that looks like something which is really there. And a 5-year OS of 42%. And this definitely calls for a standing ovation, as does the RAJAT conference calls for a standing ovation actually at that time. This is what the Astra wanted me to say. But again, why listen to what Astra wants to do? Let's look at some other finer points of stage 3 non-small cell lung cancer. There are 4 questions that I asked myself. Are the findings of Pacific trial applicable to the real world setting? Time to initiation of durvalumab after CTRT? Are there any biomarkers? And what does the future behold? So there have been 3 different studies that I'm going to quote. A Pacific R trial. Again, in this, patient had taken sequential chemo RT. 15% of people, they were more likely to having an old age. They were more likely to have a larger tumor size. 35% of people started after after 42 days. Median time from RT to durvalumab was 52 days. All grade pneumonitis was 10.6. Pneumonitis dust contribution was 4.8%. So almost equal to what Pacific trial showed. Now this was a compassionate usage program of French. Again, 591 patients were taken. Please look at this. Less than 14 days, durvalumab was started only in 2 to 2.5% of people. 14 to 42 days, 57.38. But importantly, 40% of people started durvalumab after 42 days. And the results over here again were absolutely fantastic. A CR rate of 10%, PR rate of 21%, SD rate of 43%, which was almost comparable to what the with the Pacific trial actually had. This was the Korean data. Again, the real world data, which again said 54% of patients did not meet the criteria of Pacific study. So definitely 42 is not a magic number. I have just started a lady on durvalumab after 60 days of RT. Absolutely happy with that. I think it is better than nothing. Please don't get fooled by the 42 days. A real world enough data is good enough for that. Now, this is what again Astra wanted to tell me. Now, this is what Astra did not want me to tell. You know, a lot of hula who is going about the PDL1 status. You see, if you have a PDL1 status less than 1%, more than 1%, absolutely okay. You have a PFS advantage, but you do not have an OS advantage. Now, the moment I saw this slide, I said, wow, great. I'm going to have a coup over there and everybody's going to listen to me. But then I got through a presentation at WCLC 2018, which said PDL1 was not a stratification factor in the trial. It was only done on the basis of EMA because they wanted it for an approval. Only 40% or 40% of the patient did not have a PDL1 status, and it was just a post-hoc analysis. And then I looked at this Annals of Oncology article by Luis Pasares, and what he said was, look at this over here. In the analysis of OS for the post-hoc in less than 1% subgroup, sample size was only 148. The total sample size was 1000. The estimate confidence interval included 1, and therefore no definite conclusion can be drawn. Also, PDL1 was not available for 40% of these people, and they also had a benefit from durvalumab. So I think a PDL1 less than 1% not giving durvalumab has to be taken with a pinch of salt. I won't really shy away from giving durvalumab in a patient depending on the PDL1 status alone. And we know there's a tumor heterogeneity and stuff like that. This is definitely what Astra did not want me to say. And Astra told me, what about EGFR mutants in stage 3 non-small cell lung cancer? This was a paper which I just got from, I think, Journal of Thoracic Oncology. This was durvalumab for stage 3 EGFR mutated non-small cell lung cancer after definitive CTRT. And if you look over here, they said patients with EGFR mutant did not benefit with consolidation durvalumab, high frequency of immune-related adverse events. And to me, more problem is you give them durvalumab for 3 months, and then if you have to give them osimertinib, the pneumonitis effect will be slightly more higher. So PDL1 more than 1, I will definitely give. PDL1 less than 1, I will consider giving definitely. EGFR mutated, I won't give. I mean, I am sticking my neck out and saying I won't be able to give. What will I do for these patients? We will ask them to enroll them into the trial, which is called as a LAURA trial. We have an adjuvant consolidation osimertinib trial going in our institute. So if you have a EGFR mutant patient post CTRT induction sequential, please refer. We will give osimertinib for 3 years, and who knows, we may have a LAURA trial also coming up. So last 3 slides. Yes, Rajat, finishing in 2 minutes. There are 3 strategies to be considered when you consider about CTRT in stage 3 lung cancer. The A was what the Pacific was. You give CTRT and then you give consolidation chemotherapy. The second basically is that you give induction chemo CTRT along with concomitant pembrolizumab, and then you give immunotherapy consolidation. Third is you give 2 cycles of induction immunotherapy and then give CTRT and then follow it with this. So this was there with the KN799 and the Nicholas trial. The last one was presented in ASCO 21 with the AFT trial. This was the Nicholas trial where nivolumab was given in addition to CTRT. And what it basically showed was that the PFS was good, the stage was good, but the incidence of pneumonitis actually is slightly higher, it's around 8%. The major toxicity was approximately lesser, but still you have a 10% patients of grade 3 pneumonitis, which is slightly on the higher side. This is the Keynote 799 trial design, which again compared pembrolizumab 1 cycle plus chemo concurrent immunotherapy along with that. Again, a fantastic overall response rate. Again, a good 6 months OS PFS rate. But again, if you see a slightly higher increase, we had 4% in Pacific, you have 8 to 9% in a concurrent CTRT immunochemo arm. So, and nothing great advantage being shown along with that. Now, this was new adjuvant atezolizumab where you give 2 cycles of atezo, then you give CTRT, and then you give maintenance. Now, this is a trial which has actually shown, just read the last part over here. The PFS 12 and 18 months from end of CTRT was 78% and 72% PFS, which was lesser with the Pacific trial. But then again, this is a phase 2 trial. We need to compare in a phase 3 trial. For me, today, the standard of care in a stage 3 non-small cell lung cancer is CTRT, for either induction chemo followed by CTRT or CTRT, and then give maintenance durvalumab for 1 year. So my conclusions, maintenance treatment with durvalumab is definitely a new standard of care. The 5-year data continues to favor the maintenance arm. There are no new safety signals reported. And finally, we do seem to be moving towards a cure for stage 3 non-small cell lung cancer. I wrote my first slide. I wished a lot of things at that time in 2014, 2015, and both Sajjan and Rajat are smiling on that. Some of the wishes have come true. Some of the wishes are going to come true in one. Lung cancer was just, cure in lung cancer was just one of the small wishes. I really hope the other wishes also come true for all of us in oncology. So with this, hope and cure in lung cancer is definitely a reasonable possibility which we are going to see in 5 years. Thank you, Rajat. It's a pleasure to be amongst you. Thank you.
Thank you, sir. Thank you so much. And it is even a bigger pleasure to always have you present this data and understand from you as to how we should really incorporate all this in our clinical practice. Thank you for a very nice presentation, sir. I had 1 or 2 questions to ask you from this specific trial.
Sure.
So, sir, in your practice, it is a lot of data we have in the last 3 to 4 years regarding the adverse events in PD-1 inhibitors and PD-L1 inhibitors.
It doesn't
So,
change.
yeah. So
clinically, when you look at a lot of patients, it doesn't change. Theoretically, PDL1 is supposed to be lesser, but it doesn't change. It doesn't really make a difference. No.
Okay. So what I specifically wanted to ask is that I think you pointed out also that there is no increased incidence of pneumonitis or anything that you have noticed in your practice as far as all these patients have been concerned.
Yes, absolutely. Yes, we have given to a lot of people in compassionate usage, and now we are giving over there. I think the patient selection is very, very important. I do a CT scan at the end of 2 to 4 weeks, depending upon how the patient is doing. We do a PFT at the end of it. We do counsel the patients over there. I think first 4 weeks, if your first 2 to 4 weeks, if your pneumonitis is not there, durvalumab is just going to get a 3% incidence, which is normally there with anything. Patient selection is the most important thing. Let's not be in a hurry to give durvalumab or immunotherapy in particular to everyone. That's my take home.
So what is the earliest that you have started post-RT?
Oh, 14 days.
Okay. And even those patients
he has taken, I think Dr. Ranga Rao is treating that patient. I mean, they're taking immunotherapy there. She's doing fantastically well. 47-year-old lady, squamous cell carcinoma. We got an EGFR IL cross. She's doing fantastically well. She has finished, I think, 8-10 cycles over there.
Okay. And last question is your thoughts on R2 resections. A person receives a So I had a
shoot
case,
the surgeon first.
So person receives a NACT, then undergoes surgery. NACT was RGCI surgery in TMH. Then there was an R2 resection, and now a question is being posed as to whether durvalumab is to be given. Dr. Kumar Pravash says that it is an individual decision. So
I won't give. I see. I mean, I will go by the book. Kumar Pravash is a big man. He can do whatever he wants. I will not give salvage durvalumab. It will be a pseudo adjuvant thing. It will be a more of a Empower 010 kind of a question. I will not give it. No.
Okay, so you're more comfortable in these patients with
Empower. So if you extrapolate the Empower 010 data, you can. But R2 resection or R1 resection, I would rather wait for them to come back and get over that. I mean, in my clinical practice, I try avoiding them. I'll send them to Max or BLK
or BLK. People in
or
Max
BLK,
too.
yes.
Right.
What is the definition of big people? Big people have the liberty to skip the evidence and do whatever they want.
Yes. And Manish, you are also big. You can also do whatever you want.
Much less.
He's speaking for himself.
Yeah.
Rajat, there is evidence to suggest that if you start durvalumab within 14 days, you may have a better outcome than starting it later.
Yes,
that was an oral presentation in ISMO.
Yeah. So that is what I showed Manish, that it's not really the 14 days. It basically says as long as the patient is fit. It doesn't have to do with the timing. See, whenever your patient is fit, you can actually start. So definitely people who have started within less than 14 days, that basically meant they took the chemo better, they took the RTs better.
So
what
there may be a selection bias.
What I wanted to show was that you do not, just because 42 days have elapsed, you do not give durvalumab. I think that's the message I want to give. You should definitely start it as early as possible.
Right, sir. Right. Right, so thank you so much for being here and presenting this wonderful
topic. And now I'm going, wifey calling. See you, bye. Take care.
Yeah, thank you, sir.
Fantastic, Rajat. Thank you. Thanks for having me.
Sunday to you.
Sir,
जाने
से पहले patient भेज. Sir, maximum patient भेजना ना. Wife को बुला रही आपको.
Max वाला BLK में.
अरे Max BLK कहीं भेजो हम तो ले लेंगे.
चलो भाई.
Okay. Sir, thank you. So we move on to our next topic, and from first line lung cancer, we move to the second line lung cancer, and we are going to talk about immunotherapy and chemoimmunotherapy in metastatic NSCLC in second line. And to do justice to this topic, we have with us a very endearing personality, Dr. Sajjan Raj Purohit sir. Sir is a director medical oncology at BLK and Max Hospital. Very nice to see you and have you here, sir, on a Sunday afternoon. And please take it forward, sir. Thank you.
Thank you, Rajat, and thank you, organizers, for having me here today. So I'll be over the next 15 minutes taking you through wherever we are facing patients who have not been previously treated with immunotherapy in first line. When they recur, what is the role, what is the data, and which are the drugs which we have. So next slide, please. So I'll be talking on immunotherapy in general, but Fortis-centric in particular. So we now know that, we all know that lung cancer is the leading cause of cancer mortality worldwide. And over last 5-7 years, we have had huge, I would say, advances in immunotherapy. And now we have immunotherapy encompassing not only metastatic, but now also adjuvant scenarios. The next slide, please. So before chemoimmunotherapy, the survival rates were not that great. And I think Dr. Ulas did a very well presentation, and he told us that, yes, we now have hope, and more patients actually can go into functional cure, especially even till stage 3B. So I hope that in future, we will have even stage 4 patients getting into functional cures, or at least having quality of life as well as life improved and being able to fulfill a longer life. Next slide, please. So we just go through this. Please skip through the slides. So next slide. So immunotherapy has come a long way from 1903, from the first time when Paul Eldridge actually gave up this idea shape, and then from there to through various therapies like dendritic cell therapy, then characterization of tumor-infiltrating lymphocytes, go to CAR T cells, and now more specifically. Then going up to PD-L1 and PD-L inhibitors. So we have come a long way, and last 5 to 10 years have been really fascinating. Next slide, please. So this I'll skip. Please go to the next slide. So we know all this data is aware, and we all of us are aware of the various type of PD-L1 expression which happen across various tumor types. And lung cancer is one of the important areas where there's a lot of PD-L1 expression, and it is amenable to being targeted by PD-L1 or PD-1 inhibitors. Next slide. So if you just see across the various tumor types, non-small cell lung cancer, if you just see the kind of PD-L1 positivity, both in the tumor cell as well as immune sense, is quite high. Almost 1/4 of these patients will have expression of either TC or IC expressing PD-L1. There are other tumor types like urinary bladder cancers, RCC, melanomas, head and neck cancers, gastric, and to a lesser degree, CRC and pancreatic. But these are tumors which are amenable to inhibition by PD-L1. Next slide. So please skip the slide, go to the next slide. So we know the mechanism of action. And next slide, please. So coming to the first trials, which were with nivolumab. So nivolumab in second line was checked in 2 trials. One was Checkmate 017 in squamous and Checkmate 057 in non-squamous, randomized and compared nivolumab to docetaxel in the second line. Next slide. And this was both the trials were actually positive, and they were really discussed a lot throughout the world, and were really fascinating because till that time we didn't have anything great in the second line, and docetaxel was the standard of care. But we could see there was a clear separation of curves and also PFS improving. And in fact, they were all based upon the OS data. The OS also improved for the first time with the use of immunotherapy, going from 9.4 months to 12.2 months in the non-squamous, as well as going from 6 months to 9.2 months in the squamous type. So these trials were really landmark, and they paved the path for immunotherapy. Next slide. So we could just see at 2 years also the survival was different. So at 2 years, 2 years of cutoff, the curves remain separate in both the histologies. Next slide. And it was also shown that nivolumab benefit was actually independent of the PD-L1 expression in patients with squamous histology. But in next slide, please. But in the adenocarcinoma, it was dependent upon histology, and patients who do not have PD-L expression were not likely to benefit with nivolumab. Next slide. So we wanted to have a drug which would have more important role of biomarker of PD-L1, and then we had Tecentriq. And Tecentriq, the kind of expression of PD-L1 expression was checked by both checking the tumor cells as well as immune cells, and then having a score of having either 0, 1, 2, or 3 kind of a level of expression of PD-L1 in either of the tumor cells or the immune cells. Next slide. So there was a phase 2 trial, and which was the popular study, and then followed by a phase 3 trial, which was an OAK phase, which was a phase 3 study. And the patients which were enrolled were locally advanced or metastatic patients who had already had 1 to 2 prior lines of chemotherapy, including at least 1 platinum-based treatment. Any PD-L1 expression was allowed in the enrollment criteria. Patient had to be treated, and they had to have asymptomatic CNS metastasis were allowed. It was a large trial of 1,225 patients. Among them, the primary analysis were done in 850 patients. So that was the first 850 patients enrolled were taken for the primary endpoint. The stratification was done with respect to PD-L1, histology, and prior chemotherapy agents. The randomization was 1:1 to Tecentriq, 1200 mg every 3 weekly till progression of disease or loss of clinical benefit, and to docetaxel till progression of disease. The 2 co-primary endpoints were overall survival in the intention to treat population, and also the OS in patients with PD-L expression of at least more than 1% in TC or IC. That means they had to be at least TCIC 1. Next slide, please. So if we just go to the primary endpoint, so that the trial met its primary endpoint, and it showed that with respect to OS, there was an improvement in the OS in the intention to treat population from 9.6 months to 13.8 months. The hazard ratio was 0.73, and the p-value was 0.003, and the median follow-up was 19 months. So the primary endpoint of the trial was met. Next slide. Also, the OS was improved with irrespective of the regard of the PD-L1 expression. If you just see the forest plot here, then in the patients who had TC3 or IC3, the hazard ratio was 0.41, TC2-3 was 0.67, 1-2 was 0.74, and even with no expression, there was a benefit towards Tecentriq with a hazard ratio of 0.75. And in the intention to treat population, the hazard ratio was 0.73, as I mentioned in the last slide. Next slide. So at even 2 years, the superior OS was maintained in the Tecentriq arm compared to the docetaxel. So at 1 year, the difference was 55% versus 41%, and at 2 years, the difference remained at 31% versus 21%, and this was significant. Next slide. Also, one more important thing was the duration of median duration of response was more than doubled with Tecentriq compared to docetaxel. So if you just see in the intention to treat population, in the patients who are being treated with Tecentriq till disease progression or clinical benefit, the patients actually kept responding till 16.3 months. So median response duration was 16.3 months in the Tecentriq arm compared to only 6.2 months in the intention to treat population. Any patient who had any expression of TC or IC, again, was 16 months compared to 6.2 months. So any patients with no expression were very less, and that was not evaluable in the Tecentriq arm. But the impression was that Tecentriq, if it was continued till clinical benefit, was the median duration of treatment was 16.3 months, which was very, I would say, is much long compared to those studies which only required treatment for 6 months. Next slide. So we could just see there was such a improvement in such patients started early on, around 6 to 12 weeks, and by 14 months, people were maintaining the response, and responses were even durable once the patient had been treated for beyond 3 months, from beyond 3 years. So responses were durable, and the patient had great clinical improvement. Next slide. So coming to the various subtypes, So there were certain highlights which I had to go. So in the patients who were KRAS mutant, the number of patients were actually very less, 7%. The benefit was crossing the hazard ratio 1. And also in wild type, because the number of patients were less, if we compare to the patients who were EGFR mutant, actually they did not benefit with the T-centric. So this one of the subgroup analysis, though it was not a planned or nor it was a very big analysis, but it showed that patients who are target driven are less likely to benefit from immunotherapy, and this is quite similar to other trials. Whereas the wild type patients definitely benefited with the T-centric compared to docetaxel. Next slide. Again, patients who were previous smokers benefited more, and patients who were never smokers, there was a hazard ratio which was crossing 1, but then still there was a benefit, and hazard ratio was 0.71, but the confidence interval actually crossed 1. Also, younger patients had more benefit compared to older population, because the number of patients in the older population were less, and also probably they had more toxicity compared to younger patients. Next slide. Next slide. In OAK, patients could actually continue T-centric after radiographic progression based upon the protocol-defined criteria, and that was based upon RECIST 1.1. And patients who had either clinical benefit as per the investigator, had no signs symptoms indicating unequivocal disease progression, no decline in ECOG performance was attributed to disease progression, no tumor growth at the critical sites, patient who had approved alternate therapies acknowledged differing these therapies via ICF. So these patients actually, they were continued beyond progression on even RECIST, and when the patients start having clinical deterioration, then is when they were changed to next line of treatment. Next slide. So with this, it was found that in the total population, the CR rates were not there. There were no CRs, but then there was a partial response rates of around 7.1%. Vast majority of patients actually had almost 50% patients had a stable disease, which continued to be in the tune of around 16 months, which I showed in the previous slide. But there was a subset of population, almost 43% population, which had a progression of disease on T-centric, but then continued to have clinical benefit. Next slide. So treatment beyond progression. Also, if you just see compared to the 3 subgroups, so there were patients who were continued on T-centric beyond progression, and there were other patients who were treated with other therapies. We could see that at 18 months, almost 37% of patients were having overall survival, where compared to other lines of treatment where the patients had rapidly deteriorated and were not alive. So larger number of patients were alive on T-centric despite having a clinical a radiological progression on T-centric. So this was one thing which was quite interesting, that T-centric continued to benefit these patients with respect to overall survival beyond progression, even radiologically. Next slide. So overall survival stayed separated beyond progression in the immunotherapy arm compared to the patients who had progressed on docetaxel. Next slide. So this is the 2024 year ESMO update for both the popular as well as the OAK study, and we found that even at 4 years, there was almost double number of patients who were surviving both in the popular and the OAK trial compared to docetaxel arm in the T-centric arm. That is 15% versus 8% in the popular and 16% versus 9% in the OAK study. So patients actually, there was a subset of patients, around 15 to 16% patients who were reaching around 5 years of survival on in the second line, which is quite encouraging for such patients. So next slide, please. So based upon the TC3 and IC3 data, so you just see the patients at 4 years, if the patients were TC3 or IC3 positive, 33% patients of the subgroup were surviving, which is a significant number. If so, patients who had higher immune expression, or either on a PD-L1 expression, or either on immune cells or on the tumor cells, almost 1/3 of the patients were surviving at 4 years compared to the patients in the docetaxel arm. Also, the similar results were seen both popular as well as in OAK study. Whereas in patients who were TC or IC0, the survival rates were 1/3, almost 1/3, compared to the patients who were having TC or IC3. So which shows that a patient who has got immunogenic tumor is likely to get benefited for longer time with Tecentriq compared to patients who are non-immunogenic. Next slide. Next slide. So I think these all shows the same data. Next slide. So next slide, please. So all this tabulation forms another aspect was whether the adverse events were more. So median duration of response for atezolizumab at 4 years survival in the popular study was 26.5 months and Oak study was 35.2 months. And new grade 3 toxicities, which were increasing after 1 year of atezolizumab in the 4 year survivors, were not that significant. The grade 4, grade 5 events there were no events, and new grade 3 toxicities at the onset of 2 years again were no events. So we understand now that most patients who would have immune-related side effects will have statins in the first 12 weeks. Once the patients are benefiting, then it is very unlikely for them to have any side effects beyond 2 to 3 years. Next slide. So the conclusions were that long-term follow-up of patients of both the Poplar as well as Oak studies at 4 years suggests that there was a consistently greater benefit with atezolizumab versus docetaxel in patients who were previously treated for advanced small cell lung cancer, irrespective of the PD-L1 expression levels or histology. The majority of docetaxel 4-year survival received anti-PD-L1 antibodies also. So from these patients had received PD-L1 antibodies in the third line, and that's why they were surviving at 4 years. And radiological responses are not a requirement for long-term survival benefit, as some of the 4-year surviving patients had actually progressed on by RECIST criteria. And half of these patients who were surviving at 4 years had received atezolizumab beyond progression. And atezolizumab showed a consistent and manageable safety profile with no new grade 4 or 5 toxicities in the longer follow-up. Next slide. To summarize, so I'll just stop it here. The Oak studies demonstrated OS benefit in the pre-treated non-small cell lung cancer patients, irrespective of the PD-L1 expression, though we now know that more the expression, more the benefit. Tecentriq was approved in all comers, PD-L1 unselected, and it improves overall survival in patients with PD-L1 negative, irrespective of PD-L1 expression. And majority of these patients had tolerable side effects and could be easily managed. Thank you so much. I'll stop here because I'm short of time.
Thank you, sir, for a very nice presentation on second-line immunotherapy. Sir, there are a few questions that I would like to ask you. If given a choice, your take on immunotherapy in lung cancer, will it be in the first line or will it be in the second line, and your reasons for it?
So I think in a PD-L1 expressing tumor, now we know that it's always better to use it in the first line, because now we have got huge data with, especially with the with pembrolizumab, yes. Especially in at least patients who are expressing at least 1%, I will always have them preferred in the first line. But yes, if a patient is not affordable at that point of time, or I have a choice in the second line, then I will still like to benefit my patients even in second line if that has not been used in first line.
Okay, sir, in your practice, although of course the data does not suggest so, most of the times in second line immunotherapy is what I'm talking, to offer the cost benefit ratio to patients in who are really looking forward to immunotherapy, do you make it a point to do a PD-L1 expression and then offer them such therapies, or is it like a blanket statement that post chemotherapy the progression patient has to be on immunotherapy?
No. So yes, it is a very cost-effective thing to actually check for PD-L1, but then the issue comes which PD-L1 test to do. So yes, I have in my mind, because in the first line I will always have to check with DACO to check for pembrolizumab. In second line, I have both the agents if I'm not using the first line. So that the test is very important, which test I'm choosing for, because there's a lot of discrepancy with the test results. So, but then anyway, whatever drug I want to choose, I'll try to check whether my patient is more likely to respond and then decide for my immunotherapy.
Okay, and sir, lastly, any patient who's really asking for immunotherapy in second line and you would select them by saying that no, you are not fit for immunotherapy, any such patient or a patient selection criteria?
So one of the important thing has been, again, I could not just show those slides on patients who have already pre-existing immune-related disorders are ones because they can have higher toxicity, though their efficacy is not hampered. I had the data on my slide blog, but then they could have more immune-related reactions to immunotherapy, and I will be more cautious in such patients.
So, sir, I am basically trying to ask about the performance status. So, do you really consider performance status while selecting your patients for immunotherapy?
Because it's all based on trials, but then we have real world data with the even with the which I could not show in my presentation. So real world data shows that even with patients who are PS2, 3 could actually benefit with addition of immunotherapy, whereas it is difficult to give chemotherapy in such patients. So I would consider such patients even candidates for immunotherapy.
Right, sir. Right, sir. So thank you so much for your presentation and being a part of this webinar. Always a pleasure to have you. Thank you, sir.
Thank you, Rajat.
So we move on now after this very illustrious talk by Dr. Sajjan to the next topic that we have in lung update is about how to really improve upon the survival in patients who are having early lung cancer. And we're talking about patients of early lung cancer now where there is a lot of data to suggest that we should be testing for our molecular targets even in early lung cancer, and the case in point being the trial which is the ADAURA trial. So we all know that our ADAURA trial has tried to change the way we look at the treatment of early lung cancer, and to bring more light to this particular topic of ADAURA trial, we have with us Dr. Dattatreya. Sir has been very gracious and to accept our invitation on a Sunday afternoon, and I welcome him here. And it is a pleasure to have you, sir. Good afternoon. And sir is the senior consultant in Hyderabad Omega Hospitals, and he will be enlightening us more on the topic of ADAURA trial. So, sir, over to you.
Thank you so much, Rajat. First of all, let me congratulate you for an excellent conference, and you being the program that has taken a lot of pains. And in fact, after every talk, you are making sure that all the key take-home messages are conveyed to the audience. And more than that, you yourself have done the homework so that appropriate questions are asked to the faculty. So kudos to you for all the hard work. Excellent. So I think we all know that non-small cell lung cancer, a resectable disease, around 30% of patients at diagnosis have resectable disease. Next slide. Next slide, please. And the next slide. And then once you resect, then for all stage 2 and stage 3 non-small cell lung cancer patients, we routinely advocate 4 cycles of adjuvant cisplatin-based chemotherapy. Even select patients of stage 1B disease also get adjuvant cisplatin-based chemotherapy. Now, various large randomized trials and meta-analysis have shown us that the absolute 5-year OS benefit comes to say around 5%. The OS hazard ratio is 0.89. and the DFS hazard ratio is 0.84. So what that tells us is, next slide, even if it is stage 1B, close to half of the patients recur by the end of 5 years. In stage 2, almost 2/3 of them recur by the end of 5 years. And in stage 3, in fact, 3 in 4 or 3/4 of them recur. So disease recurrence or death following surgery and adjuvant chemotherapy remains high across disease stages. Next slide. Now we come to EGFR mutant non-small cell lung cancer, and be it whatever stage 1, 2, 3, or 4, we do have a limited number of studies which have shown that across disease stages, the prevalence of EGFR mutation appears broadly similar. And we know the impact that the EGFR TKIs have done on metastatic non-small cell lung cancer. Can we also have a similar impact, if not identical impact, of using adjuvant EGFR TKIs after surgery and or cisplatin-based adjuvant chemotherapy? Because a similar proportion of these patients can benefit the same way as it happens in the advanced setting. The prevalence of EGFR mutant non-small cell lung cancer in Asians is 30 to 40%, in Caucasians 10 to 20%. So with that background, with that introduction, let me go ahead with the ADAURA trial. Next slide, which talks about using osimertinib as adjuvant treatment in patients of stage 1B to stage 3A EGFR mutant NSCLC after complete tumor resection. Next slide. So this was a properly conducted pragmatic phase 3 randomized double-blind study design. And you stratified the patients based on stage 1B versus stage 2 and stage 3A. And they also looked at exon 19 deletion versus L858R and the race, Asians versus non-Asians. Now, the primary endpoint was DFS by investigator assessment in stage 2 and stage 3A patients. And the assumed DFS hazard ratio was thought to be 0.70. So, at the start of the trial, with this statistical design, osimertinib, the benefit with a hazard ratio of 0.70 would be improving the DFS. And this was what they assumed. At 22 months, the IDMC recommendation came that the study was unblinded early because of efficacy. And therefore, an unplanned interim analysis happened. And we'll look at that data. Now, you give osimertinib 80 mg once daily for 3 years versus placebo once daily for 3 years. Let's look at some of the inclusion exclusion criteria. So non-small cell lung cancer, non-squamous post-op staging stage 1B to 3A, and either exon 19 deletion or L858 or EGF mutation, standard post-op adjuvant chemotherapy was allowed, but not mandatory. So, which means that a proportion of patients possibly did not get the adjuvant chemotherapy also because it was not mandatory. Now, that comes to something like in stage 1B patients, a good number of patients, 26% of them actually got adjuvant chemo for reasons because it was a clinical discretion by the investigator. On the other hand, in 20% of patients of stage 3, adjuvant chemotherapy was not given. And in fact, in almost 29% of patients in stage 2 also, adjuvant chemo was not given. So 40% of patients did not receive adjuvant chemotherapy across stage 1B, stage 2, and stage 3. So that has been one criticism of this trial. Now, an MRI or a CT scan of brain prior to surgery also was mandatory, and if not done before surgery, at least before the patient got enrolled in the trial. Now we know that CT scans are not of the brains are not that good for the brain metastasis, and that again is one more limitation or criticism of this trial, because as you can see, around 50% of patients brain imaging at randomization or before surgery was a CT scan and not an MRI. Having said that, males 30%, smokers around 30%, and non-Asians around 36%. So whether it's male or female, Asians or non-Asians, smoking or non-smokers, you need to test your patients for EGFR mutations. 55 for E19 deletion and 45 for L858R point mutations. So I think it becomes imperative in clinical practice after surgery is performed for stage 1B to stage 3A non-small cell lung cancer, do check for the EGFR mutations, whether it's male, female, smoker, non-smoker, or Asians, non-Asians. So what happened by giving adjuvant osimertinib? The primary population, next slide, the intention to the main population, stage 2, stage 3A, hazard ratio of 0.17. Now, it improved the DFS versus placebo in resected EGFR mutant non-small cell lung cancer. What did they assume? Hazard ratio of 0.70. What they found? Hazard ratio of 0.17. If you take the entire population of stage 1B, 2, and stage 3A, the hazard ratio is still a very, very impressive 0.20. Stage 1B, 1/3 of patient population, stage 2, 1/3, and stage 3A, 1/3. Even if 1/3 was stage 1B, the hazard ratio was still 0.20 across the entire population. So next slide, 83% reduction in the risk of disease recurrence or death in stage 2, stage 3A, and that becomes 80% when you have stage 1B, 2, and 3A. Next slide. So whatever the disease stage, the 2-year DFS was consistent. improving more in those patients who had more and more advanced stage. Hazard ratio of 0.39, 0.17, 0.12 for DFS with regard to stage 1B, stage 2, or stage 3A respectively. So whatever the stage, adjuvant osimertinib benefited. Next slide. Whatever the subgroups, across all subgroups, osimertinib proved better with regard to disease recurrence or death according to investigator assessment. But what about overall survival? Next slide. Maturity is 5% only. On the osimertinib arm, the maturity is 3%, the placebo arm, the maturity is 7%. But then some pointers are coming out. Next slide. With regard to an early snapshot showing a 7% benefit by using osimertinib. Now, patients and investigators remained blinded to treatment in order to facilitate assessment of OS at maturity. Having said that, these curves are only those curves which are showing 5% maturity. But even then, pointers are coming out, hazard ratio of 0.40. Now, what about other adjuvant EGFR TKI trials in the EGFR mutant and CLC settings? Next slide. 5 trials are shown. Select, Radiant. Next slide. E1, adjuvant CTONG and BR19. And across all these trials, you find significant DFS improvement. But none of these trials showed an advantage in overall survival. The osimertinib study also shows an adjuvant improvement in the DFS, in the median DFS. Now, the hazard ratio in the ADAURA trial is 0.17. Across the entire population, 0.20. Look at adjuvant CTONG, the median in the DFS, the hazard ratio was 0.54. It did not show significant OS improvement. So by all means, adjuvant osimertinib seems to be the drug when compared to what all other EGFR TKI evidence we have. Now, what about the type of recurrences? Next slide. Now, is the patient having a loco-regional recurrence or a distant recurrence also has an impact on patient outcomes after surgery. Most importantly, osimertinib has CNS penetration, and therefore it possibly might be able to impact the OS by preventing CNS recurrences. So let's look at what the type of recurrences in the ADAURA trial. Next slide. Now, 11% of patients only had DFS events. Next slide. In the osimertinib arm, in the placebo arm, you have 46% DFS events. Now, of the 11% recurrences, more than 60% are local regional recurrences only, and less than 40% are distant recurrences in the osimertinib arm. In the placebo arm, the reverse was true. First of all, 46% of DFS events, and then more and more distant recurrences rather than local regional recurrences. In the ADAURA, in the osimertinib arm, next slide, the CNS recurrences were only 1%. The next slide, please. So CNS CNS recurrences are of the 11 recurrences in the disease sites, only 1% was CNS. Next slide. Whereas that was almost 10% in the placebo arm. Next slide, please. So what it tells us is that overall, ADAURA is able to, osimertinib is able to prevent CNS DFS events to a very large extent, which is only 10% in the placebo arm and only 1% in the osimertinib arm. Coming to the CNS DFS in the overall population, next slide. In the placebo arm, it was 48.2 months. Next slide, please. In the osimertinib, it is not reached. And look at the hazard ratio again, 0.18. In fact, the blue curve there is almost flat. So that's the advantage of using adjuvant osimertinib. And true to the fact that it has a BBB penetration, it's able to prevent CNS recurrences. We all know osimertinib is a very comfortable drug to use. Next slide. And therefore, looking at the safety summary, grade 3 adverse events were 20%, but in only 11% of patients, it led to discontinuation. And in 7% of them, you had to reduce the dosage. Overall, if it's because of osimertinib, the grade 3 adverse events were only 10%. I think we all agree that this is a drug which has been comfortably used by all of us for a pretty long time now. Next slide. And what are those side effects? some diarrhea, paronychia, dry skin, pruritus, etc. In fact, the incidence of grade 1 to institutional only 3% in the osimertinib arm, and QTC prolongation in 7% of patients. The reason why I brought out the QTC prolongation was make sure to check your patient's drug chart summary for other comorbid conditions so that there's no interaction with the QTC interval. Next slide. So let's now look at post-operative chemotherapy use and the outcome. Some patients, 40% of patients in this trial did not receive adjuvant chemotherapy, and 60% of them received adjuvant chemo. Next slide. In stage 1B, next slide please, 26% of patients received adjuvant chemo. In stage 3A, 20% of them did not receive adjuvant chemo. In stage 2, 29% of patients did not receive adjuvant chemo. Having said that, adjuvant chemotherapy or no chemotherapy, next slide, osimertinib is able to benefit all patient populations with a hazard ratio of 0.16 and 0.23 respectively. With adjuvant chemo, hazard ratio of 0.56. Even if adjuvant chemo is not given, the hazard ratio is 0.13. Next slide. So coming to the disease stage, again, whether it is stage 1B, stage 2, or stage 3A, adjuvant chemotherapy or not, the hazard ratios are hovering between 0.14 to 0.38. So that is the advantage, or that's the impact of adjuvant osimertinib. Regardless of disease state and regardless of adjuvant chemotherapy, a clinically meaningful DFS benefit is seen by adjuvant osimertinib. Next slide. So this is just a stage-wise chart. Stage 1B, again, a benefit across both the populations. Next slide. Stage 2, again, benefit whether it's with or without adjuvant chemo. Stage 3, next slide, also similar. So I think that's what, next slide, please. So that's what osimertinib has done. Very quick, I'll take 2 more minutes. Very quickly, we'll look at the patient-reported outcomes. Next slide. They looked at quality of life, and they looked at the health SF36, and this was the data collection period. Next slide. And they looked at osimertinib versus placebo, and overall the compliance rates with this health survey, next slide, was more than equal to 85%. So this tells us that the quality of life analysis data would be robust because compliance rates are 85% or higher when across both the arms. Next slide. Be it physical component, next slide please, or mental component, majority of the patients, more than 80%, did not have a clinically meaningful worsening in the physical or the mental components. So to summarize my last 2 slides, next slide, adjuvant osimertinib, I would like to reiterate, is the first target agent in a global trial to show a statistically significant and clinically meaningful improvement in DFS, whether it is stage 1B, stage 2, or stage 3A. The reduction in risk of recurrence is as high as 80% across all the 3 subsets, stage 1B, 2, and 3A. If it was stage 2 and stage 3A, then the hazard ratio becomes 0.16. The DFS rates at 2 years, 89% osimertinib versus 52%. Even in the CNS DFS, you find a clinically meaningful improvement when compared to placebo. And the safety profile has been the same as what you have seen in all other, wherever the drug has been used. Now, the median duration of exposure in this study was 22 months, and even with almost 2 years of exposure, the adverse event profile has been consistent, and that speaks a lot about the safety of these molecules. Last slide. Whether the patient has received or not received adjuvant chemotherapy, you find a clinically meaningful DFS benefit, and whatever the state, be it stage 1B, stage 2, or stage 3A. About the disease recurrences, 11% were the DFS events in the osimertinib arm, which was more than 40% in the placebo arm, almost 46%. Then again, you have more local recurrences, more regional recurrences, and less systemic recurrences with adjuvant osimertinib. And on top of all this, the quality of life is maintained. So to conclude my last line, adjuvant osimertinib should prove and should provide a highly effective practice-changing treatment for patients with stage 1B, stage 2, stage 3A, EGFR mutant non-small cell lung cancer after complete tumor resection, whether you give them adjuvant cisplatin-based chemotherapy or not. Thank you so much, Rajat, and thanks a lot, everybody.
Thank you, sir. Thank you for this very insightful talk, a very detailed description of ADAURA trial. Sir, just in the interest of time, 2 questions. Sir, one is that just on the basis of a 2-year DFS, are you willing to change your practice as of now, or there is a school of thought which says that we should not jump the gun and wait till the time we get more mature data in terms of either DFS or probably hoping for an overall survival? And the other question is that it's a little difficult to digest the fact that they did not offer chemotherapy to 20% patients who were in stage 2 and 3. So your take on that?
Yeah, so I think if the hazard ratio with osimertinib, answering your first question, would have been, say, again, like they assumed 0.7, or it had come as, say, 0.54 as what erlotinib in the CTOM did, then maybe I would have waited. I would have said, okay, all the previous trials have shown good hazard ratios in DFS, but no OS benefit was seen. But a hazard ratio of 0.16, I think that possibly becomes practice.
Too compelling.
And that too, CNS DFS events also go down so less. So these are the 2 strong pointers which tell me that I should possibly think of using, our patients need to benefit from this data. I think that's the very important take-home message, that our patients should benefit from this adjuvant data. And whether for whatever reasons adjuvant chemotherapy is given or not, adjuvant osimertinib makes a huge difference when compared to any of the other EGFR TKIs in the adjuvant setting. The second question was
chemotherapy. 20% not receiving chemotherapy.
Yeah. So I think that's something which I think in our practice also it does happen, that for various reasons, when we explain to the patient has not recovered fully, or the patient understands there's only a 5% benefit with the adjuvant chemo, and therefore either the patient decides or we decide not to give adjuvant cisplatin-based chemotherapy. That does happen, though I think 20% or 30% is a pretty high number. But even then, I think we do see commonly patients where for various reasons, you cannot give adjuvant cisplatin-based chemotherapy. Still, I think osimertinib stands out there to benefit much more than what chemotherapy can. Having said that, the OS maturity is 5% only. We'll have to wait for the OS data. In the meantime, the DFS advantage is huge. Hazard ratios are like unheard of in lung cancer.
Rajat, can I ask one question to
yes,
Dr.
sir.
Dattatreya?
Please, sir, go ahead.
Hi, sir.
Hi, Manish.
My apology for holding you back for another 2 minutes on a Sunday afternoon.
No, not at all.
How justified are we in comparing CTOM with ADAURA when we know that CTOM compared gefitinib to chemotherapy, whereas in ADAURA, chemotherapy followed by osimertinib versus placebo? Osimertinib was offered for 3 years, gefitinib was offered for 2 years. And last, not the least, the duration of therapy was lesser. The comparison was versus placebo. And would you not offer a gefitinib for a patient or an adjuvant gefitinib for a patient who is unaffording for osimertinib, or you would like to disenfranchise them from the benefit of an adjuvant TKI when we know that the principle is late?
So that was one reason why I was trying to emphasize on the fact that in stage 1B, 26% of patients got adjuvant chemo, but in stage 2, 29% of patients did not get adjuvant chemotherapy. And in stage 3A also, a significant 20% of patients did not get adjuvant chemotherapy. So you had a good number of patients, and almost 40% of them in this trial, who did not receive adjuvant chemotherapy. Now, in the CTOM trial, as you rightly said, we compared the adjuvant EGFR TKI to adjuvant chemo rather than sequence that. Now, adjuvant gefitinib or any of the first generation EGFR TKIs, CNS penetration is an issue. And so if a patient can't afford, it's a different issue, but then we have not shown a OS advantage in any of the first generation EGFR TKI trials. The same also is to osimertinib, but then the CNS events, the DFS events, all of them tilt me with a hazard ratio of less than 0.20 across the entire population, tilts me in choosing osimertinib over an adjuvant first generation EGFR TKI. I think it becomes prudent to understand that a third generation EGFR TKI has two things: maximal efficacy and minimal toxicity, and on top of that has CNS penetration too.
So, right, Dr. Sham sir is there, and I think on the chat he's saying that why gefitinib, because we don't have such positive data for gefitinib. I think he's echoing your
We have a
words.
CTONG data.
That was only DFS improvement. It did not show an OS improvement at all.
The OS improvement is yet to come for osimertinib also.
Absolutely, but the OS improvement is not there, has already come for the CTONG data. Now, osimertinib, the hazard ratio was 0.54 there, and it's 0.16 here. Again,
I agree. It's not to undermine osimertinib, but to underscore that EGFR TKI works in the adjuvant setting.
Yeah, so when we have to choose among say a first or third generation TKI, then I think why not look at a hazard ratio of 0.16 and choose that rather than 0.54 and choose that.
Right. I think so. We'll move ahead, sir. In the interest of time, we would have loved to have this discussion more. Thank you, sir, for your very nice discussion on this topic. Thank you for being there. Thank you.
Thank you.
So we move ahead, and now from non-small cell lung cancer, we move to small cell lung cancer, first line. And in the extensive stage, we have the coming up of immunotherapy along with chemotherapy. And this is what we want to discuss in the next 15 minutes or so. And who better than discussing this with an illustrious medical oncologist, a dynamic personality, Dr. Manish Singhal, sir. Thank you for being here, sir. And he's known to speak his mind always. And I'm sure that he will not really bother about the fact that this is an AstraZeneca session, and he'll speak on both Atizo as well as durvalumab. Over to you, sir.
Right. Thank you, Rajat, and congratulations for your unbridled excitement and zeal to carry out meeting on a Sunday afternoon. So right away, starting with the ideal management of first line extensive stage small cell lung cancer. It's a sort of a case-based discussion. Next slide, please. So a 62-year-old smoker patient who comes with slightly raised liver function test, and the CT scan shows that that there are left lower lobe nodule, but there is a massive splenomegaly, and the biopsy is suggestive of small cell lung cancer. Next slide. Usually the diagnostic workup that is required is a PET CT scan and a brain MRI, which is usually done in a small cell setting more often than non-small cell setting, because we know that about 20% or maybe around 30% patients may have upfront brain metastasis. And of course, the biopsy is rendered too. Next slide. This is the initial evaluation, which is recommended in the NCCN guidelines. And I think other than smoking cessation, everything else is generally carried out by everyone, and which helps us decide between a limited stage or an extensive stage disease. Next slide. So this is regarding the patient who had a massive hepatomegaly with extensive involvement of the liver with metastatic disease, and the biopsy was suggestive of small cell lung cancer. And so the brain MRI was at baseline was normal. Next slide. So usually we are confronted with a choice between a platinum and etoposide with or without an immunotherapy. There has been some very interesting data coming from the Japanese about using irinotecan upfront with a platinum-based therapy, which was not held well in the intergroup American study, and the platinum plus etoposide combination remains the combination of choice. The number of cycles are debated upon, but 4 versus 6. But I think usually people go up to 6 cycles if the patient is tolerating it well. Next slide. The question remains that the first line treatment has evolved, and now we do discuss about immunotherapy as an option, although cost can be a barrier. but we do discuss about immunotherapy in this particular combination. Next slide. So next slide, please. So if you look at the previous failed studies, which were not able to beat EP as the standard of care, where EP stood the test of time with a median overall survival just under 1 year, that is around 10 months or so. But with the advent of immunotherapy, durvalumab and atezolizumab, I think the median overall survival has crossed the 1 year mark, with the atezolizumab study showing 12.3 months as a median overall survival and the durvalumab study showing 12.9 months. And that's, I recall, as quite consistent results with the combination of immunochemotherapy. Next slide. So it is important that the first line therapy is as robust as possible, because we know that many patients in extensive stage small cell lung cancer are not able to go to second line, and a very minority of patients will be able to receive a third line therapy. Next slide. So if you go by data, the data is very clear that it shows that that immunotherapy along with chemotherapy has become a standard of care. Next slide. So we are fraught with choice between carboplatin and etoposide, or cisplatin plus etoposide with durvalumab, and carboplatin etoposide with atezolizumab. Next slide. So how do one choose between the two immuno-oncology agents, that is durva versus atezolizumab? So be it be a cross-trial comparison, but it's still worth looking at the survival curves, which are quite self-explanatory as far as the choice of agent is concerned. Next slide. So these are the subtle differences between the studies, how these studies were conceptualized. Untreated brain metastasis was excluded in the IMpassion study, whereas it was allowed in the Caspian trial. PCI was allowed in the IMpower 133 study, whereas it was not allowed, at least in the experimental arm in the Caspian study. And the reason for that was that many of these patients with brain metastasis, if they receive PCI, may have decline in their neurocognitive functions. And they were conceptualizing a long-term survival, and this way, this will impact their quality of life. Whereas cisplatin and carboplatin both were allowed in the Caspian trial. So these were the subtle differences, but I think to my mind, these are very small differences, which as compared to both the studies. And I would not really, put these differences in mind while choosing the therapy. But what is more important is in the subsequent slides. Next slide, please. So these are the overall survival curves. If you look at the IMpower 133 data set, it looks more like a banana-shaped curve, and the survival curve seems to be, moving together at the end of the curves. Whereas if you look at the Caspian trial, and if you look at 2-year median overall survival, or the percentage of patients surviving at 2 years is around 22%, which is 1 out of 4 patients surviving at 2 years, which is, I think, is quite gratifying from the survival curves perspective. And so the hazard ratios for the median overall survival are very similar between the two studies, but the tail of the curve is compelling. Next slide. So this patient was treated with the combination of cisplatin, etoposide, and durvalumab, achieving a near CR in 4 cycles. And thereafter, the patient was put on durvalumab maintenance, which was once in 4 weeks, 1500 milligram. And the serial scans did not show any progression of disease. Next slide. Now comes the question of PCI and whether we can hold PCI. Next slide. So these are the two studies. The Slotman study is an old PCI European study, which showed that there is a median overall survival gain. But the Japanese study did not really find a gain, which was also a randomized control trial and was an oral presentation in ASCO meeting. It did not show any gain. So I think the jury is still out about the use of PCI, and there can be different schools of thought. A patient who has not really progressed in the brain, I think the PCI can be held for some time. And as such, all these patients undergo brain surveillance, and the radiation can be used at the time of progression. Next slide. So it's just vocalizing the same thing, that there is paucity of the data of integrating PCI with immunotherapy. Not to say that we don't do it in routine practice. Sometimes we do PCIs, or as a matter of fact, when there's brain progression, people do use immunotherapy, continue to use immunotherapy and still use radiation to the brain. But there's no such formal data of combining PCI with immunotherapy. There is brain surveillance which undergoes, and I think one can use radiation at a later date also, provided you are doing a proper brain surveillance. Next slide. Coming to the question of thoracic RT, next slide. The CREST trial was a trial which did show that there is a progression-free survival benefit, and a 2-year overall survival was better in patients who have residual thoracic disease after their said chemotherapy for the extensive stage small cell lung cancer. And it did lead to some overall survival benefit, but this was truly present for those patients who had almost a complete remission with residual thoracic disease, complete remission of their extrathoracic disease, or who had very less or very low burden disease. These were the patients who can undergo a thoracic RT. As such, we don't have any data of combining thoracic RT with immunotherapy. So that remains a challenge with actually both the studies, be it the IMpower 133 or the CASPIAN trial. And this again remains an open area of debate, whether to add thoracic RT if the patient has residual disease in the lung. Next slide. Although the guidelines do talk about using PCI and versus a brain surveillance in the guidelines, and also considering thoracic RT, but not mandating the thoracic RT in patients who have extensive stage small cell lung cancer after they have received their systemic therapy. Next slide. So this is also the same as the NCCN guideline, the ISMO 2021, shows the same aspect of treatment and the same algorithm of treating small cell lung cancer, extensive stage disease. Next slide. So the patient remains on a 4-weekly durvalumab maintenance. And next slide. And one hypothetical question is that in a patient with liver metastasis, had brain metastatic disease, how would one manage? Next slide. So in case there is a symptomatic metastasis and the systemic therapy is not immediately warranted, one can do brain RT and then go into the systemic therapy. Otherwise, in an asymptomatic patient, one can definitely start systemic therapy first and hold brain RT for some time. Next slide. Depending on the brain metastatic disease, the choice of immunotherapy would vary. Next slide. So we have data from these 2 studies. The CASPIAN trial did not have any decrease in their hazard ratios with or without brain metastasis. So overall survival with brain metastasis was equally good in patients who didn't have any brain metastasis. Next slide. Whereas if you look at the forest plot for the IMpower 133, those who did not have brain metastasis did better. However, you must read in between the lines that the number of patients who had brain metastasis, because it actually did not allow untreated brain metastasis in this particular study. So that was a very small number, and the point estimate is crossing the unity line towards placebo, but this has to be taken with a pinch of salt. Next slide. The patient completed 8 cycles of durvalumab with no evidence of progression on serial scans. Next slide. So what about performance status? Of course, I think one can use IO drugs in PS2. In small cell lung cancer, even if the patient has a PS3 or 4, one can start with chemotherapy and one can add immuno-oncology drug at a later date if they are sick because of the disease and not because of comorbidities. Next slide. So these are open-ended questions. The role of any biomarkers, PD-L1 and TMB, which has not been highlighted so far in small cell lung cancer. Next slide. And the role of driver mutations is also an open question in small cell lung cancer, or patients who develop small cell lung cancer as a part of transformation after being treated with TKI. Next slide. Again, an open-ended question that COVID-19 changed the management of extensive stage small cell lung cancer. I think not very much. Next slide. So to summarize, the first-line durvalumab EP has shown substantial improvement in overall survival, and it is quite reflective of real-world practice as it allows 6 cycles of EP, and there's a flexibility of choosing cisplatin and carboplatin, which to my mind is a very small difference between IM power 133 versus the Caspian. The benefit is seen across all subgroups, and the brain metastasis subgroup is definitely compelling. The most compelling thing is 22% patients on durvalumab EP surviving at 2 years seems to be the most important difference between the two studies. Durvalumab does offer a convenient once monthly dosing, 1500 milligram in the maintenance phase, and the safety concerns are very similar to what has been experienced either in the Pacific trial or any other study of durvalumab as such. With that, I thank you for your kind attention, and back to the organizers.
Thank you, sir. Thank you for very much for this talk. Just in the interest of time, one question. So, sir, how much is the acceptance of this particular trial or these two trials in your OPD practice as far as immunotherapy in first line and SCLC is concerned? What about the cost benefit ratio? Are we really explaining these things to our patients, or how is it that you take it in your practice?
So thanks, Rajat, for that question. I definitely, in my own practice, definitely discuss cost benefit ratio. And so most patients are not able to afford, I would say 90-95% are not able to afford this combination because the cost benefit doesn't seem to outweigh the cost versus the benefit doesn't seem to outweigh the cost, the overall cost and the benefit. So so that is a very important thing which I think every healthcare professional should discuss with their patient. And but yes, most patients, those patients who have large insurances and can afford the drug or are reimbursed, they generally are the ones who accept durvalumab or for that matter atezolizumab. We've used this drug even, I've used this drug even in second line small cell lung cancer, those who didn't have the opportunity to use it in the first line. But as such, in second line, no such great results.
No such case.
I think if you have to use it, you've got to use it in the first line.
Completely agree. Right, sir. Thank you so much. Thank you for being here, sir. Thank you. So now we move on to the last part of our webinar this afternoon, and last but not the least is the panel discussion on early lung cancer. As we know that there are a lot of new things which have come up in the management of early lung cancer, be it the tyrosine kinase inhibitors or immunotherapy. So this is from the medical oncology point of view, but of course we have our surgical and radiation oncology colleagues who would definitely like to pitch in, because conventionally the early lung cancer is really called the surgeons or the radiation oncologists domain. And to do justice to this panel discussion, we have with us a very well-known, renowned senior medical oncologist, Dr. Shyam Agarwal, sir. Sir happens to be the head of the department at Sir Gangaram Hospital. Sir, we are very privileged to have you here, and we have been keeping you waiting for quite some time. So over to you, sir. Thank you for being here. Thank you.
Invite the panelists who are available. Can you?
Yes, sir. I'll do that. So Dr. Shubham Garg is there. Dr. Shubham Garg from IUSPL Fortis Noida is there, senior surgical oncologist. Dr. Darlong sir is there from Rajiv Gandhi Cancer Institute. Dr. Tripti Saxena, radiation oncologist from Fortis Noida. Dr. Mondal, I can see is here from Apollo Hospital, Delhi. Dr. Aditya Murli.
Yeah, hi, I'm around.
Hello. Welcome. And Dr. Pankaj Goyal is, I think, here from RGCI. Welcome, everyone.
Dr. Bharat is not there.
Hi, Dr. Bharat. Thank you.
Dr. Bharat has not been able to join, sir. Yes.
Okay. So thanks, Rajat, for this opportunity to put this panel discussion here. So I think the initial part of the discussion will be focusing on the diagnostics because we have surgeons here. So I think it's sometimes very important for all of us to figure out what we should be doing with a given individual in terms of how to establish the diagnosis, whether patient needs radiation, concurrent CTRT, surgery. So I think those are very important issues. And I think the numbers of such cases are increasing to my mind. I mean, when we are talking about stage 3 particularly. And earlier, of course, it used to be radiation domain. Even now it is with the durvalumab, but the surgeons are also increasing in number, and so are the pulmonologists. So I think the discussions are on. So let's get going with the first case. So this is a 67-year-old lady, smoker, and she has a right lower lobe mass, which is measuring, I'll show you the scan, I think, 5.5 centimeter. And there is an equivocal node of 1.3 centimeter. So we have the biopsy done already here, adenocarcinoma. So this is a straightforward scenario, I guess. So I go to the surgeon, Dr. Shubham, what is it that you want further to decide whether this patient is operable or straight away operable? And so can we go to the next slide? Yes, sir, Dr. Shubham.
Two components from our ends, operability and resectability. For resectability, we'll need to see the scans, what's the relation to the vessels. For operability, we need to confirm the staging, whether it's really a localized disease or a loco-regional disease. The PET shows there's no metastasis as such, distant metastasis, but we need to do a mediastinal evaluation to look for the nodal staging. With the current evidence that we have for a 5.5 centimeter lesion with a possible node in the 4R region, which could be a N2 station, I would want to go with the EBUS FNA for this lesion.
Okay, Dr. Darlong, you...
Yeah, I would agree with Dr. Shubham. I would add a contrast CT, contrast MRI brain in this case with a node having a node in that mediastinum with adenocarcinoma, so you can miss on a PET scan MRI brain with a contrast. And obviously, EBUS staging is very much part of the workup, I think.
Okay, so I think amongst the two surgeons, anybody from the radiation side or medical oncology wants to make a comment? Dr. Mondal?
I think, sir, the staging workup and the investigation plan is quite okay. Maybe a pulmonary function test would be required before planning for resection.
Great. So can we move on to the next slide? Okay, next slide. So I think that was the question, EBUS versus EUS versus mediastinoscopy. So coming back to our surgical colleagues. So can I show the next slide, please? Just for the benefit of people like us. So what are the areas where we should go for EUS or mediastinoscopy, or maybe where EBUS may not be helpful? Dr. Darlong, I mean,
I think I would always prefer the EBUS first in most cases, and EUS maybe, if they can access if they can give an idea about level 5 and 6 or 8, otherwise EBUS is our usual choice.
Dr. Shubham, please.
The mediastinoscopy is just like the Congress party nowadays. It's still there, but it's nowhere to be seen. We would want to do more and more mediastinoscopies, but we never get to do them. But yes, EBUS is the first step forward nowadays.
I would like to add one point, Shubham. Mediastinoscopy is still not out. Especially for left-sided lung cancers, I still use a mediastinoscope just to be sure when not operating on N3 disease. Just yesterday only, I did a mediastinoscope for a left-sided lower lobe tumor. So I think EBUS is much, mediastinoscope is still much in
largest
there.
national party after BJP, sir. So the mediastinoscopy still stands.
Somebody still speaking for Rahul Gandhi,
I'm standing up for mediastinoscopy, sir.
Yeah, I know. So my point is, is EBUS sufficient, or would you need US in certain?
So I see the best would be to have a EBUS EUS combination, because EUS gives you access to the station 9 nodes, which we very conveniently forget. So ideal would be, if you really want to substitute for a mediastinoscopy, would be even better than a mediastinoscopy would be EBUS and EUS FNA. But still the convention, the guidelines that we have, the ESTS guidelines, it mandates mediastinoscopy prior to surgery if the EBUS is negative and you still feel that the node could be suspicious.
Can I add one point, Shivam?
Hanji, sir.
How much is the positive rate of level 9 nodes?
No, I agree.
Practice?
It is not, sir, but then, the evidence, if you want to use EUS FNA to the best, that is the only indication for using EUS FNA to is to get patient 9.
That's the problem is the price constraint we have. I mean, in the walk-up itself, patients spend around $1 lakh and they don't get to go for the real treatment.
So it's very easy, sir. The radiation oncologists forget to get a EUS or EBUS done, they just radiate. So.
Okay, so I think practically it seems EBUS and the most common, of course, required EUS, and I think we just would be perhaps. Dr. Tripti, you want to add anything, to this discussion on the diagnostic modalities?
Sir, I think as Dr. Shubham told, EBUS is easily doable and available. So we prefer to do the stage the patients by using EBUS only. And we refer our patients to Dr. Shubham. Yeah. We'll go with EBUS, sir.
Okay, so can we move on? The next slide. It's a similar slide. I think we can skip this. Next slide, please. So I think this patient underwent EBUS, and this is what we got here, that the station 4 on the right side was positive, and 4 left and 7 not biopsy due to small nodal size, and the single station non-bulky and 2 no distant metastasis, I think as desired by the radiation oncologist and of course by the surgeons, that this is the FEV1 and ECOG is 1 and no contradictions or indications to surgery. So Dr. Darlong, what do you think? How should we be?
I mean, we go for a neoadjuvant chemotherapy first and then go for surgery after that.
I agree, sir. Neoadjuvant chemotherapy.
So can you give us the reason for that?
Well, and to being, I mean, we'd like to basically downstage the systemic part, the nodal, all those things. And and chemotherapy given in the neoadjuvant setting, we have more chances of giving a complete systemic therapy, unlike in the adjuvant setting. This is what the studies have shown, that they can complete the chemotherapy much better when it's given the neoadjuvant setting. So we should give the benefit of systemic treatment.
So can I bring in Pankaj Goyal or Aditya, Dr. Aditya? So are you okay giving chemotherapy to such a patient, or you have a different view?
Sir, ultimately, this is a MDT discussion. And if our surgical colleague feels that, maybe they want to downstage a disease a little bit before they operate, I think we would be happy to give. So essentially, single N2 can go both ways. Single site N2 can go both ways. But if the surgical colleagues, input, if they want us to give neoadjuvant, I'd be happy to give, no problems.
So
Sir, I think if the surgeon is asking for a neoadjuvant chemotherapy, there should be no doubt about it.
No, I would not want to put it as downstage. I would want to put it that these patients tend to fail distally more than locally, and that is why the insistence from our end to go for neoadjuvant chemotherapy first rather than for surgery. The extent of surgery or the extent of resection does not change by giving chemotherapy.
So bringing in our radiation colleagues, so are you, I mean, what are your views regarding CTRT?
So, sir, that can be an alternative. Surgery is definitely preferred whenever possible. And if not, then, or if the patient is really not willing, then CTRT can be an alternative.
So, sir, considering the N2 nodal stations, surgeries they are not the CTRT is an equally good alternative for these patients.
So how will you decide for a given patient in the MDT, whether one should go in for neoadjuvant chemo or followed by surgery or CTRT? So Dr. Shubham?
So I think the resectability and the operability of the patient to my mind, there is no doubt that if the patient is resectable and operable in terms of fitness for surgery and the risk stratification, they should be offered surgery first, other than the neoadjuvant part for this. I think the question what should have been whether we should consider neoadjuvant chemotherapy versus neoadjuvant chemotherapy, radiotherapy for such kind of patients other than definitive chemotherapy, radiotherapy. Obviously, if the patient is not operable in terms of their physical condition, then even we would not want to put our foot into the door, and we would also want to send the patients for chemotherapy, radiotherapy. But if the patient is resectable, operable, then definitely surgery should be done.
So as per your statement, the question is, Dr. Mandal, whether patient should be given pre-operative chemo or pre-operative chemoradiation.
Yes.
Right, Shubham?
So, pre-operative chemoradiation, pre-operative chemotherapy, definitive CTRT, everything is a valid option for this patient. Now, definitely, the final call depends on the choice of a group of doctors working together, whether after radiation the surgeon is confident to operate upon, because there are a lot of radiation-induced changes after chemoradiation. So many surgeons do not feel comfortable in operating after radiation. So that's a big issue. Otherwise, I think, sir, everything is valid option. It needs discussion with the patient, discussing about the options, cost, side effects of all the treatments, and the patient has to be a party in this discussion and decision making.
Dr. Darlong, sir?
Yes, sir. I mean, this is a straightforward case, I think, in N2 case, single station, and patient is fit. So, I mean, the ideal protocol that we follow is go for neoadjuvant chemotherapy, because they complete the systemic treatment more instead of giving them in adjuvant setting, like what has been said. So I think after this, it depends on the patient now whether she wants to go for surgery. If she's against surgery, obviously that's the second choice, I think, CTRT.
Patient is saying, do your best. I am willing.
In that case, I think MDT will be very much unanimous in doing a surgery. Neoadjuvant chemotherapy and surgery.
So, Dr. Shubham, if you have a patient like this, will you push for neoadjuvant chemo or neoadjuvant or, upfront CTRT?
No, sir, definitely neoadjuvant chemotherapy followed by surgery. So,
but why we raised the issue of CTRT, right?
No, I raised the issue of neoadjuvant chemotherapy radiation, that if there was ever a question of radiation, it was never a definitive CTRT. It was only the question that a radiation guy should have raised was for a neoadjuvant chemo radiation. They should have never raised the question for a definitive CTRT.
No, Dr. It's not like radiation doesn't have a role in these patients. Radiation and chemotherapy with a definitive intent or definitive chemoradiation is equally good as compared to chemotherapy followed by surgery. So in such situation where you have multiple options with equally good results, the ideal way to go forward would be to involve the patient in decision making and discuss the pros and cons of each and everything. It should be like.
I'm yet to see a patient, very frankly, Dr. Mandal, in which you tell them that the surgery is equal to radiation and the patient will choose surgery. And
then the patient to me, I will counsel and send him back to you after.
I mean, really, I have not seen a patient yet who has been told that we will give you a scar and we'll give you this thing, and they opt for surgery ever. So
I'll be happy to counsel such patients and give chemoradiation if they do not agree and send them back to you.
Yeah, Dr. Tripti, you want to make any comment? I think there is a little conflict going on.
Definitely, sir. So, as I agree to Dr. Mandal, every modality has equal place, like giving the chemotherapy, neoadjuvant chemotherapy followed by surgery, or pre-chemo RT and surgery, and definitive CTRT. Both stand probably at the same place. The decision should be involved by the patients too. And considering the pre-operative chemo RT, probably the surgeon's comfort is to be discussed during MDT. And if they are comfortable enough, we can go for the pre-operative chemo CTRT. Else, definitive CTRT has an equivalent role if patients are not willing to go for the surgery.
Patient, as if we at all consider about chemoradiation, then it's an adenocarcinoma, and definitive CTRT can be followed by maintenance durvalumab as well to increase the outcome.
That is without saying. I mean, so I think the question, Dr. Shubham.
Sure.
So is there a head-to-head trial between surgery followed by adjuvant chemo versus definitive CTRT. And so definitely it's not there with durvalumab, but then is there a head-to-head study? Because that is where the conflict is arising, because a radiation person is saying that I can give you equivalent results. You are saying that you can give equivalent results. So is there a head-to-head trial to that effect, to make that statement, qualify that statement from the radiation point of view?
Yeah, I can't recall of any because probably they thought surgery was better, so they didn't do a trial like this. Is there a one from the radiation side?
Yeah, Dr. Mondal, is there a study to head-to-head study, phase 3 randomized study?
No, sir, I cannot remember any such studies.
No. So therefore, the data which we are quoting is from individual studies, where the long-term results seem to be similar between the two groups of patients, which are treated at different institutions at different times, right?
Exactly, sir.
Right. So, Dr. Darlong, any comment here?
Yeah, I mean, we don't have any head-to-head trial and all.
Right. I think Rajat is saying that he seems to be favoring CTRT. Well, yes, but I think he can give chemo in both the sides, whether it is neoadjuvant or it is CTRT. So I don't know. But I think so far what we've been taught is that if the patient can be operated, and Dr. Mandal did make a statement in his opening remarks that if the surgeon says no, then I'll take up for chemoradiation. Dr. Mandal?
I agree, sir. I agree, fully agree, because that's the standard of practice.
Right.
So there are two things. One is what is the current standard of practice, and the second question is whether there is a good alternative or not. Now, to answer the first question, the surgery is definitely standard of care and a preferred treatment whenever it comes to lung cancer. If it is operable, it's assumed that the outcome will be better. Now, the second question is there a good alternative? Yes, chemoradiation is definitely equally good alternative. Now, why do not we do this? Because of lack of trial, and definitely patient comes to radiation oncologist later on. There are a lot of studies, a lot of randomized control studies, which had to be stopped in between because of lack of patients for radiation. So these things are practical problems.
So Dr. Agarwal, just let me interrupt. I find this really interesting that, surgery is the standard of care and it is the preferred modality, but we have comparable data with CTRT. And when a patient comes, we'll sit down and tell the patient that you have both the options and then let the patient choose. Then how will the patient ever choose surgery if it's the preferred option and you tell them that both are equal?
It's preferred because
that is what my whole question is, that when it comes to the patient, we tell them both are equal and then we expect them to choose surgery. And when we know that the standard of care is surgery, I will myself send a patient away to you if I feel that he's not operable or he's at the risk of dying, and no surgeon would want to put their foot in their mouth.
If you compare the historical data for both the treatments, then the outcome is almost equal. But in absence of a head-to-head comparison, see, like in stage 1 cancer, SBRT has perhaps better outcome compared to surgery. But yet we prefer the patient to be seen by surgeon for surgery. And only when the patient is not agreeing or there is medical contraindications, we choose to give SBRT. But
right. So I think
why we prefer it? Because there is lack of randomized control trial data.
So maybe patient should also be involved in the tumor boards. Yeah. Then probably things will become more simpler or complicated. I don't know.
So there are different type of practice. One, when you discuss each and everything with the patient and make him a party to the decision making, and then second, where doctor or physician takes the decision and informs it to the patient. Now, many times patients come who wants to be involved in the decision making, knowing pros and cons, each and everything. And there are group of patients who leave it entirely to the physician, that doctor, whatever you feel best, you do it. So I think it should be better to optimize according to the patient's need, and that way you can decide the treatment option.
Right. I think
so, sir, can I come in with a point here?
Yeah, Rajat.
Sir, so there's a lot of discussion which has gone on this particular thing, and I think Dr. Mondal has tried to heat it up more by making surgeons more furious by saying that SBRT is equivalent to surgery in T1 N0. I think so. The point on this is that NACT RT, I think no surgeon would like to have, because One is that it is difficult to do a surgery after NACT-RT, and surgeons would allude to this more. But if we talk about NACT followed by surgery versus a CT-RT, yes, as most of the panelists pointed out, that there is an equivalent data, but we have to make the patient understand the fact that if this patient, a T3N2 patient, is being operated upon after an NACT, what are the chances that he will require an adjuvant radiation? This also should be told to the patient. So that will be a triple modality treatment, and an adjuvant radiation should also be discussed in the beginning, is what I feel. And that is one part. Of course, it is not 100% sure that he will receive adjuvant RT, but there is a possibility. And also he has to be told that if he's not being offered surgery and only definitive CT-RT, what are the chances that he will land up in CR versus landing up in a partial response? This is, I think that this should also be discussed with the patient.
So Rajat, if it this 4R node was positive, you are given in NACT, and then you do surgery. So depending upon pathology report, you will offer radiation, or patient will be a party to radiation anyway because initially it was positive.
Yeah, that's
I
what.
think with the lung art, I mean, you are not offering a port to all cases now.
Yes, we are not offering port to these patients, right?
So, you know, that brings us to the point.
Triple modality treatment versus the bimodality.
Right. So I think definitive CT-RT should also be maybe put into more practice if patients can afford durvalumab. But that seems to have changed the, outcome to some extent. So, Dr. Pankaj, what is your thought on durvalumab?
Sir, durvalumab, I think that remains a valid option. And I think just like we have this osimertinib after CT-RT also and after surgery also, time will come when you will have this option that you will be offering durvalumab to both. So it will complicate the matter further. So patient can offer durvalumab, and then you are stuck whether you want to go for a surgery or you want to go for a CT-RT. So I go by the standard practice that if we can assure R0 resection, then definitely surgery should be the first option. And if it becomes high risk or high nodal positivity, multiple stations, then it goes for CT-RT after systemic therapy.
Okay, I come back to Dr. Mandal or Dr. Tripti. So if the patient cannot afford durvalumab, and a patient like this, will you still insist on CT-RT, or will you be happy to give it over to the surgeon more happily?
Sir, as discussed, like the patient will be discussed in the multi-modality treatment, and the case will be discussed with the surgeon, and the surgical option is the first. If the patient is not medically resectable or medical comorbidities or not willing for surgery, then the option of CT-RT will be discussed. So the first priority is surgery, then only the radiation, and durvalumab comes later.
No, so Dr. Mandal, you get my point?
I got your point, sir. I will be happy to take the surgeon. I'll be happy to offer the surgeon to take the first call. And
exactly, sir.
If durva is not available. I mean, if patient can't afford durvalumab.
In both cases, sir, because as of now, the standard remains surgery for any resectable and operable patients. So in any case, we our practice is to go for chemotherapy and then evaluation for surgery. If at all radiation is required for adjuvant setting, we give adjuvant radiation. Only when it is not resectable or inoperable for some other reasons, or if the patient is really not willing for surgery, even after counseling, we go for CT-RT.
So Rajat, you back out a little in favor of surgery?
I just want to make a point that probably the surgeons are thinking as to where are these kind of radiation oncologists practicing. so he's been very gracious enough in saying that he'll refer it to the surgeons. And brings a smile to the face of the surgeon.
For definitive CT-RT. So in a patient where both the options are suitable or possible, so we will go for surgery, as Dr. Mandal has agreed. He has conceded that if patient is operable and there is no contraindication, then surgery remains somewhat better in the absence of a randomized study.
Yes, sir. To my mind, if this patient is planned for an NACT followed by surgery and is already being told that he will require adjuvant radiation, I have no problems, and I'll be absolutely happy giving this treatment plan to the patient.
Okay, so I think everybody seems to fall in line that surgeons do have an upper edge. So coming to the post-op radiation, doctor, since we are in early, discussing the early lung cancer. So Dr. Tripti, what are the indications for post-operative radiation today?
So if the margin is positive, if it is R1 or R2 resection, we will definitely consider the patient for post-op radiation therapy.
What about node positivity?
If there are multiple N2 level nodes are positive, we'll consider this patient for radiation, definitely.
Definitely. Dr. Madal, any difference in the post-op radiation for lung cancer, post-operative?
No, sir, I agree with Dr. Tripti. Maybe some additional high-risk factors like LVI, PNI may be considered. And bulky node, bulky N2 is an area of controversy. Maybe we can take into account that also.
No. So I need to get this clear. So a patient is node negative, but the patient has lymphovascular invasion and or perineural invasion. So will you offer radiation? Should radiation be given?
No.
No, sir, not at all.
No.
No. So agree, Dr. Shubham?
Yes, sir.
Dr. Darlong?
Yeah, I agree, sir. I mean, R1 resection and maybe a extracellular extension of the node might be an indication for post-OPAVATI.
So margin and node positivity, right? There is a consensus there. So now coming to adjuvant radiation, Dr. Murli. So
yes, sir.
Who are the operated patients where you think we should be giving adjuvant chemo?
Adjuvant chemo, anything above 1B, definitely they will need adjuvant chemo. Any lung tumor above 4 centimeters, adjuvant chemo definitely has a role, no doubt in it, sir.
Sir, but in this case, we have already given the chemo, no?
No, we are not deviating from the case. Now we are discussing early lung cancer now. So
yeah, so if a patient, if a patient is operated upfront, then any tumor more than 4 centimeters and any node positive, there is a definite survival benefit with chemo, sir.
So Pankaj, what chemotherapy protocol in the adjuvant setting?
Previously, it used to be that E and P, but now I think depending upon the pathology, we can very well offer, depending upon the pathology side, we can give PEM and platin, or we can give a taxane plus platin.
Okay, so I think again there seems to be a reasonable consensus. Mostly people use carbo, but I had reviewed some time back. The trials are mainly with cisplatinum, but I think oncologists feel okay using carbo. Pankaj, you agree? Or Dr. Murli?
Yes, I agree. 67-year-old people giving cisplatin in India is a problem. So carbo is what I would prefer based upon the histology, of course. Yeah.
So we just discussed ADORA study. Are you doing EGFR nowadays for your patients to decide on, the EGFR inhibition?
Sir, so in my practice, I'm offering testing for EGFR. However, ever since the time ADORA came out, although I discussed this option with every patient, I have not found a single patient in whom we can definitely convince them to take 2 years of osimertinib. So the challenges are, not so much with regards to the actual data, but the financial issues do portend that. So all people get tested for sure. So and then based upon the individual patient situation. So if we know that patient is stage 3A or stage 2B and T3 tumor, and we know that the chances of distant failure are very much there. If a patient is EGFR positive, we might try and convince them to take osimertinib. Although many patients have come back and asked whether we can give first-line TKIs because they seem to be more affordable in this setting. I have not wanted to use first-line TKIs as adjuvant TKI.
So Pankaj, the question is a 4-centimeter tumor, a node negative, and EGFR is positive. So what will you do? Will you give chemo? Will you give, everything is affordable, and will you give chemo? Will you give osimertinib? Will you give both?
Sir, osimertinib, if the patient is affording, then patient goes for osimertinib.
Okay, I'll change it a little. A patient has a 5-centimeter tumor and 2 nodes positive and EGFR positive. Then what?
Sir, even then.
osimertinib.
Sir, I would differ. I would differ, sir. Irrespective of what Adora did, there is clear-cut overall survival benefit. Everything is there for adjuvant chemotherapy, especially in the node-positive setting. Adora had its share of criticisms. Dr. Dattatreya enumerated that beautifully. So chemo for sure. Then osimertinib discussion.
Okay, Aditya, but if the tumor is 4 centimeter node negative, chemo will be given, right?
Yeah, 4 centimeter chemo has to be given, sir.
So you follow the guideline for chemo?
Yes, sir.
And if patient can afford, EGFR drug, which is osimertinib, should be given.
Yes, sir. I agree, sir. Yeah.
Okay, and if the patient can't afford osimertinib, then gefitinib?
No, sir. This question has been asked to me many times in my clinic. I have never not found the courage to do that yet, sir.
Okay. Do surgeons have a say in this? The role of chemo and osimertinib. Shubham, what are your thoughts?
Sir, I'm all in favor of anything which makes my lung cancer survivors live longer. So
that's very diplomatic and a political.
No. It's not diplomatic, sir. It's very. I've learned from past experience. I always tell my patients, see, the breast cancer surgery has not improved. What has improved is only the chemotherapy, and which is why everybody is talking of breast cancer. If the lung cancer starts to live that long, can you imagine how many surgeries we'll get to do? So I am all in for giving anything which makes them live long.
Dr. Darlong, any thoughts there?
Yes, we always, because when they follow up, that's the time we see the pathology report, the final reports. So we always tell them, this is the option, and this is a new thing which has come. If you can afford it, you should go for this. We always encourage them. The rest is for them to decide because the finances are huge.
Right. So I think before I go to the radiation oncologist, I just want to make a statement on immunotherapy, PD-L1 status, etc. So, I don't think they have come of age at this point in time for either adjuvant or even for that matter, neoadjuvant immunotherapy in combination with chemo. So I think the trials are awaited. Aditya, you agree?
Absolutely agree, Dr. Shamagarwal. Even the IM power 010, for all the excitement it is generated in terms of hazard ratios for DFS benefit and all, you using DFS as a primary endpoint for adjuvant trial in itself is a questionable endpoint. And also, that trial, the IM power trial did not consider EGFR status at all. So there are some criticisms of that. I am definitely not comfortable giving immunotherapy in the adjuvant setting for now.
Okay, great. So the final, I think we're running short of time. The final thoughts are from Dr. Mandal and the surgeons regarding the SABR, that is stereotactic ablative radiation. So I believe there's a tussle between the two parties. So I think we will begin with Mandal because we are talking of stereotactic radiation. So what are the indications and how do you score over the surgeons?
Sir, SABR in lung cancer is indicated only for early stage lung cancer. So either it has to be stage 1 or 2, but the tumor size preferably should be less than 4 centimeter. And given this case scenario, if there is a node, then definitely that is out of purview of any SBRT. Now, how SBRT is scoring over surgery is again an area of debate because the randomized trials had stopped in between, but the long-term data of the participants actually showed excellent response with SBRT, and the survival reached almost 90 to 95%. So I think that's quite impressive to suggest that SBRT can actually challenge surgeries in such patients. But there are some definitely some contraindications in and patient selection, which patient should be actually offered radiation, which patient should not. So if it is a peripherally located tumor, right, away from chest wall, definitely SBRT holds a place in this treatment in absence of nodal disease.
Dr. Tripti, your thoughts on a centrally located tumor versus peripherally located tumor and node positivity before I go to the surgeons?
Okay, sir. So there are well thought discussions on that, like if the tumor is like less than 4 centimeter T1, T2, if not positive, no SPRT. It's only for the T1, T2, and 0 disease, and that too very well done in peripheral tumors, and we can get the equivalent result giving the 3 fractions. But again, it's a challenge in centrally located tumors, like which are less than 2 centimeter of periphery of proximal bronchial tree, or the ultra centrally located tumor, which are close to the OARs. But there are various studies where they have modified the fractionation schedules. We cannot give in 3 fractions. Even the ESCO says we can do in a 5 fraction or in a 7 or up to 15 fractions. The crux is we should be able to achieve the biological equivalent dose of more than 100 gray. So the results are equal. If the dose achieved is less than 100, biological equivalent dose is less than 100 gray, the results are inferior. So it's a challenge for centrally located and ultra centrally located tumors, but one can always see the scans, one can always define the volumes and look for the doses. If they are achievable and we are able to achieve the biological equivalent dose, we can vouch for the equivalent results, but definitely it's doable in peripheral located tumors.
So I think even in centrally located tumors, you can select out patients.
We can select the patients, and there are different fractionation schedules and the radiation schedules available in the literature. Yeah,
I think nearly 30% patients tend to recur in the long run, either regionally or locally or distant. So coming back to surgeons, so which patient do you think, Dr. Darlong?
Yeah, sir, I have absolutely no contraindication to SBRT in medically unfit patients. But in those patients who are fit, I think we should explain to them what's the current data with SBRT. We have it basically for medically unfit, inoperable patients. So to compare it with fit patients, I think is not justified. I mean, at the present setting. And if I see, I mean, if we compare with surgery, SBRT is just like a glorified wedge excision. From a surgeon's point of view, it's like a glorified wedge excision. You can have spread of tumor across alveolar space. We know it very well. STARS is a very known fact. And once you give SBRT in fit patients, I mean, how do you have any specific protocols? When do you go and do rebiopsy? And again, the question comes about salvage surgery in those who recur, I mean, at local sites. So all these things in fit patients, when surgery for such early cases can be done so easily with a VATS who stays in the hospital for just about 3-4 days. And if you give SBRT, I mean, it's the same time, I mean, 5-6 days in the hospital. So it's equivalent in practical terms. And at the present setting, we have that it is basically for medically unfit patients. I think that's my take at the present scenario.
Final comment from Dr. Shubham as we close the discussion. Dr. Shubham, please.
I couldn't agree with Dr. Darlong anymore. I think he summed it up very well, actually.
Okay, so it seems that there is a consensus. So Dr. Mondal, so if the patient is unfit and the tumor is peripherally located, so those are the ideal cases for...
Exactly, sir. I agree. I fully agree with Dr. Darlong that as of now, the data is definitely for medically inoperable because the trials were not completed for medically fit patients. So we cannot quote any evidence to say that it would be great. But if it is showing such excellent results in medically unfit patients, then we definitely can hope. But in absence of any data, in age of evidence-based medicine, we cannot vouch for that.
So I was just going through literature and I saw with the patients who are treated by SBRT, they were talking of abscopal effect that may act on the micrometastatic disease if else anywhere. And the other thing is they were talking of some immunogenic response if in the patients where we give further immunotherapy, these are antigens present which favor in the term of immunogenic response to immunotherapy. So these are the 2 points which people are talking about now if we consider patients for SBRT lung. So future is more and more in that.
So I think the thoughts are for immunotherapy as well. Although such effect is far and few, if I understand, from the clinical practice. So I think we've covered quite a few things in terms of diagnosis, in terms of selecting patients for resection versus CTRT, and then of course PORT. So I think, Rajat, we are coming to a close. People are leaving us. We are over time, and I think I thank Shubham, Dr. Darlong, Dr. Tripti, Dr. Mandal, my two medical oncology colleagues who have left for this very, very engaging and enlightening discussion, and certainly to Rajat, who gave us this opportunity to interact. Thank you very, very much.
Thank you, sir, for all this wonderful discussion. And thank you, Dr. Rajat.
Thank you, sir. Thank you, sir.
Thank you.
Thank you.
Thank you, everyone. Thank you, Dr. Sham sir, for being there. The discussion was very interesting, very engaging, and it was primarily because of you and all the eminent panelists that you had in the panel. So the very important thing that came out of the panel is that always early lung cancer has to be discussed in a multidisciplinary team, and this is how we should try and give the best that we can to our patients. As a medical oncologist, things coming up in terms of immunotherapy, be it adjuvant or neoadjuvant or adjuvant tyrosine kinase inhibitors, are only going to go a long way in increasing the survival in such patients. So thank you, Dr. Sham sir, once again, and I thank all the panelists for a very enlightening discussion this Sunday afternoon. So with this, we come to the end of this webinar on breast and lung cancer updates. I would like to thank all of you from the bottom of my heart for sparing your time on this Sunday afternoon to be with us. I personally have learned a lot from all the speakers who were engaged in this particular webinar, and from all our moderators and panelists. I would like to thank the audience who spared their time, and I'm sure that it was a discussion and a good information session for you to satiate your academic taste buds as well. We look forward to having you again in another part of this series of current oncology update series. Till then, it is a goodbye from my side. Thank you, Mighty Duo, for arranging and organizing this webinar well. And goodbye, and have a great evening ahead. Thank you.
Thank you, Rajat. It was a great meeting.
Thank you. Thank you, sir. Thank you. Thank you.